in the Care Continuum Conference. We will start our session today with the women's health, and the first speaker will be Dr. Mona Sheikh. She is a consultant, a family physician, and the trainer at Family Medicine Academy. She is an attending family physician in Al-Athir Primary Healthcare Center, and she is doing marvelous job at our academy in coordinating the clinical rotation for our resident. She will talk about how to manage menopausal symptoms for women during this transition period and improve their quality of life. So let's welcome Dr. Mona. Questions will be answered after by the end during the panel discussion. So please write down your questions in the chat at the end of the session.
Thank you very much, Dr. Iman. Good morning, everyone. It's a great pleasure and a great opportunity Assalamu alaikum. Okay. Good morning, everyone. It's a very great opportunity to be part of this special event and a special conference. This is Dr. Mona Sheikh. I will start today our first lecture in the Women's Health Conference by starting of managing symptoms of the post-menopausal women. The objective of my session will be, by the end of this session, you will be able to identify symptoms of different stage of the menopause and to recognize updated modalities of treatment for menopausal symptoms. I will start my presentation by sharing with you a case that presented to me in my clinic. Mrs. Sheikha Abdul Latif, she is a 54 years old female, para 5+2. She's medically free, attend to the clinic just for her usual routine checkup. By taking history with my patient, she complains of episodes of hotness that associated with excessive sweating. Her last menstrual period was 5 years ago. By taking more history, she denied any genitourinary symptoms. Patient also complained of low mood, excessive crying, and social isolation that prevent her from having interest of her usual activity. So, by definition, after a years of menstrual irregularity, women eventually experience a permanent cessation of menses or clinical menopause. And this is we define as the final menopausal period, retrospectively after 12 months of amenorrhea or cessation of the period. We can define or we can categorize the final menopausal period into 2 stages. The early stage, which is referred to the first 2 to 6 years, and thereafter we will call it the late final menopausal stage. We usually use the straw staging, which is the stages of reproductive aging workshop that can follow the patient from the menarche, then the menopausal transition period, and finally to the final menopausal period according to the years to define either early or late menopausal stage. What symptoms we expect that the patient have if they are in the menopausal stage? Most of the symptoms the patient will complain of is related to the estrogen deficiency, and we can divide them to both either the vasomotor symptoms, which including the hot flashes, or the genitourinary symptoms, or the genitourinary symptoms of the menopause, and we will go through these symptoms in the upcoming slides. So the vasomotor symptoms, what we call the hot flashes, this is one of the most common symptoms that the patient will have during the menopausal stage. And it occurs up to 80% of the female. It's usually the patient will present or complain of a sudden hotness, feeling of excessive sweating that usually start on the face and rapidly become as generalized. It usually takes 2 to 4 minutes, and it's associated with the profuse perspiration or sweating, followed by chills, shivering, feeling of anxiety, which make the patient very bothersome. Unfortunately, although most of the patients will describe these symptoms as severe symptoms, only 20 to 30% of the patient will seek a medical attention for treatment. Is there any risk factor that increase the possibility or severity of the hot flashes for the patient? Yes, actually being obese with, let's say, reduce the physical activity, being a smoker, the hormonal concentration regarding the level of the FSH, estradiol, it may increase the risk of the hot flashes and the severity of the hot flashes. Ethnic factors, being an African American, also increase the severity and the duration of the hot flashes or the vasomotor symptoms if comparing with the Caucasian or the Japanese and Asian ethnicity. Also, genetic variants may affect the severity and the duration of the hot flashes. Although there are several grading scales that we have to classify the hot flashes, it's very important to use one scale, a clinical scale, because according to the severity, we will treat the patient and we will put our management plan. So we can utilize a 4-point scale, either the hot flash or the vasomotor symptoms, it's not present, or it's mild. And when we say mild, that means that doesn't interfere with the patient's daily activities, or moderate, that there is interfere somewhat with the usual activities, or it is severe, so it is very bothersome that even the usual activity cannot be performed. There is very well-known study, it's called the SWAN study. It's very popular for the menopausal symptoms, especially the vasomotor symptoms. It takes the duration, the severity, the risk factors. That study, the SWAN study, it's about the women's health actions for the menopausal. The median total vasomotor duration, it will be 7.4 years according to the age of the woman. And if the menopausal or if the vasomotor symptoms start early in the menopause, the duration will prolong. If the vasomotor symptoms start late in the menopause, such as in the late final menopausal stage, the duration will be decreased. But in the average, the median will be 7.4 years. So just imagine that the female at the end of their reproductive life, they will suffer for at least 7 years of a very bothersome symptoms. On the other hand, we said that we have the vasomotor symptoms. On the other hand, we have the genitourinary symptoms of the menopause, which also related to the hypoestrogenic effect on the vagina and the genitalia of the woman. It's including the vulvovaginal dryness, decrease the vaginal lubrication during the sexual activity, dyspareunia, vaginal or vulvar bleeding, decrease the sexual desire, sometimes feeling of burning, irritation, itching, and a patient may complain of a vaginal discharge or leukorrhea, and sometimes the patient even present with urinary symptoms such as urinary frequency, dysuria, urethral discomfort, hematuria, or in some cases as a recurrent UTI. Is there any symptoms that will the patient complain other than the hypoestrogenic effect of the menopause, yes, there is a lot of symptoms patient may complain, such as the depression, and it is a significant increased risk of the new onset depression in women during the menopausal transition. And when we say the menopausal transition, that in the old terminology, that means the perimenopausal period, that is the months or years just before the final cessation of the period. And sleep disturbance, sometimes they related, the sleep disturbance related to the hot flashes that they have, or maybe because of primary causes of sleep disturbance or other complaints such as sleep apnea, restless leg syndrome. All these may lead to the sleep disturbance. Joint aches and pain, breast pain, and this is usually due to the estradiol level fluctuation, which may present as a breast pain, and the menstrual migraines. The menstrual migraine, usually the patient may have a cluster migraine during the menstruation, and it will increase in severity and in duration after the menopausal period. Other symptoms that may have osteoarthritis, body composition will change since the patient will lose their lean mass and it will have more regarding fat mass. Also, the distribution of fat will have more in the central opacity. Skin changes due to the collagen loss. The patient will have more of wrinkling, aging, and also impaired the balance. What about long-term consequences of an estrogen deficiency? Yes, as long as the patient and increase the duration of the menopause and an estrogen deficiency, the patient will have more complaint, more symptoms, such as bone loss and osteoporosis. The cardiovascular risk disease will increase, and this is maybe due to more than one factor. One of them is because of the change of a lipid profile with increase in LDL level and the triglyceride. Also, the cognitive function will impair due to the estrogen or long-term estrogen deficiency and will lead to dementia. One of the important things while we are taking a history and asking about the symptoms of the patient is the quality of life of the patient. This is a cornerstone of us as a family medicine or a family physician to ask the patient about the degree of discomfort, the behavioral response to the symptoms, and the impact of symptoms on her daily activity, sexual activity, and her partner relationship and support. We will come back to our scenario or our patient, Abdul Latif. After we take a detailed history from her, we go for the physical examination. Actually, we don't expect to see much in physical examination for the postmenopausal. We check her vital signs. It was within the normal. Thyroid exam was normal, and all of her systemic examination was unremarkable. One of the things we can find in the examination for postmenopausal women during the pelvic examination, and we can see the vaginal labia and the clitoris changes due to the hypoestrogenic changes. Do we need any lab test to order for patients, for our patient Abdul Latif, or any patient come for evaluation for a menopausal or postmenopausal stage? Actually, laboratory evaluation is not necessary or suggested, especially if we are talking about women that present after the age of 45 years old, and she present with the, let's say, classical symptoms of amenorrhea and the hot flashes, the vasomotor flashes. What about if we have a patient between the age of 40 and 45 years old, and she present with the symptoms of an irregular menstruation, she is having some mild symptoms of the vasomotor symptoms, genitourinary symptoms? Here, the laboratory evaluation should be performed just to rule out other endocrine disorder. If we go through the investigation, which is not mandatory, just to see what investigation or what laboratory test that will be disarranged during this period, if we order for the patient an FSH, it will be high. If we order for the patient an estradiol, it will be low. And one study reported that a random serum FSH will be more than 25. It's characteristic for the late menopausal transition. The measurement of an FSH during the late menopausal transition, that means after 6 years after menopause, are not routinely recommended due to their variability. Actually, the FSH and the estradiol, after the late phase of a final menopausal period, they will be regained to the normal premenopausal level. So the measurement of an FSH and the estradiol will be misleading for the diagnosis and for the treatment, and it will add nothing for us during the management plan. So the diagnosis will be mainly about our history and examination, so it is clinical diagnosis. There is certain investigation also we can order if we are just in concern about the diagnosis, such as serum inhibin B, which will be low, the anti-Mullerian hormone, and it's another product of the ovary granulosa cells, also will be low. The ovarian antifollicular count, it's defined as the remaining complement of a follicle measuring 2 to 4 millimeter in diameter on the transvaginal ultrasound. It will be declined in number. So, is there any other test that we can order? Yes, there is some other test if we are in doubt about the diagnosis, and especially we said between 40 and 45 years old, if the patient, she is still sexually active and she is not using the reliable contraception method, we can order pregnancy test or the level of a serum human gonadotropin level. Also, additional endocrine tests we can order, such as a TSH, prolactin, if the patient have symptoms suggest of endocrinopathies. Now we're going to talk about the management of the postmenopausal symptoms. As we at the beginning said, we can divide the symptoms to the vasomotor hot flashes and the genitourinary symptoms. So we have both pharmacological and non-pharmacological management. We will start with the hot flashes. We have a general principles we have to put it in our mind before we decide to manage this patient and to choose which type of management is. Will we go for the pharmacological therapy or non-pharmacological? So we have to take full history about the symptom intensity and the frequency. Medical history, it's very important, so we can decide if the patient is candidate for the menopausal hormone therapy or not. And the personal choice for the patient, if she would like to start the menopausal hormonal therapy or no, and if there is any coexisting symptoms rather than the vasomotor or genitourinary, such as the depression, sleep disturbance, osteoarthritis, and other symptoms. So, as if you remember, we said we have a clinical stages for the hot flashes, starting from 1, 2, 3, 4, mild, moderate, severe. So, any woman with mild hot flashes, that means it doesn't interfere the lifestyle or the daily lifestyle of the patient. Usually, we do not need any pharmacotherapy. We can use the simple behavioral measures, such as lowering the room temperature, using the AC, using the fans, dressing very light dresses, avoiding any triggers such as spicy food, any citruses, trying to have a healthy lifestyle by doing exercise, reducing hair weight. We can use also the CBT, hypnosis, vitamin E, also one of the promising medication that can we use as a non-pharmacological treatment for the mild hot flashes. What about if the patient have moderate to severe? That means it interferes with her daily activity. Here, there is the rule of the menopausal hormonal therapy if there is no contraindication to use it. So, it is a broad word or a broad term that we are using, what we call the menopausal hormonal therapy, and it's described both either using unopposed estrogen for the women who have no uterus or having underwent a hysterectomy, or a combined estrogen and progestin therapy. The primary goal for the menopausal hormonal therapy is to relieve the hot flashes, and the other symptoms that associated with the hot flashes and the vasomotor, such as sleep disturbance, mood liability, depression, in some cases the joint ache, they will be covered and respond well to the menopausal hormonal therapy and the estrogen effect. So the first question I have to ask myself if I decide to start my patient on the menopausal hormonal therapy, is my patient a good candidate for the MHT or not, according to the patient age, severity of symptoms, and the patient calculated risk for the cardiovascular and breast cancer. So we consider the initiation of an MHT to be safe in this category of the patient: healthy patient, they are symptomatic moderate to severe symptoms within 10 years of menopause, and younger than 60 years old, because in the geriatric society, they avoid using MHT after the age of 65. The Pearson criteria says it's not safe to use the MHT after the age of 65. And if the patient have no absolute contraindication for MHT. As I said before, the Endocrine Society 2015 Clinical Practice Guideline suggests that before starting an MHT, to calculate the cardiovascular and the breast cancer risk before initiating the patient. And after we calculate, we can divide the patient to mild, moderate, or severe risk. If the patient have low risk, that means less than 5%, it's okay to start her on an MHT. If she is having moderate risk between 5 to 10%, the MHT is questionable, and it's preferable to go for the transdermal option rather than the oral option. And if the patient have high risk, that means more than 10%, it's preferably to avoid starting patient on the MHT. So I just have a brief about the MHT. All types of an estrogen are effective. The potency and therefore the doses of an estrogen preparation are different, but there is different, when we choose which type of the estrogen we're gonna use, it's depend on the availability in the market, and it's depend on the cost and the patient preference. Estrogen, it's available in many forms, such as oral, transdermal, that when we use it for the vasomotor symptom, and other types such as gels, lotions, rings in case of genitourinary symptoms. In the past, the old modality that one size fit all, that means one concentration that will give for all the patient, and if the patient have symptoms relief, we will continue indefinitely. The new recommendation and the new evidence base, should we start with the low dose? Example, we can use the transdermal estradiol 0.025 milligram or oral estradiol 0.5 milligram per day, and titrate up accordingly until the symptoms relieve, then we stop. We have different modalities or different types of the estrogen choices, such as the microionized estradiol, it's oral or transdermal, and the conjugated equine estrogen. And we can add the progesterone, as we said, if the patient is still having the uterus, we can add the progesterone, either cyclic, like when we are using the microionized progesterone, we can add 200 milligram at the first 12 days, and this will be cyclic progesterone on top of an estrogen, or we can continuous progesterone by adding 100 milligram daily during the whole month. One of the available medication that we have in the market, it's not available in all markets, but it's available in Saudi Arabia and the local countries, is the Brimarine. Any side effect we expect to have after starting the MHT? Yes, breast soreness because of the progesterone effect, the mood symptoms, the vaginal bleeding, and it's usually, if you are giving the patient a cyclic estrogen progesterone regimen, and it's usually common in the early month of the continuous estrogen progesterone regimen during the first 6 months, then it will disappear. Is there any contraindication for the MHT? Yes, include the history of a breast cancer, any chronic heart disease, a previous VTE event or stroke, any active liver disease, unexplained vaginal bleeding, high-risk endometrial cancer, transient ischemic attack, and in case of unexplained vaginal bleeding, if we decide to start the MHT, we must to have an endometrial biopsy, then we decide to start or not according to the result of the endometrial biopsy. Can we use the MHT for prevention of a chronic disease such as cardiovascular diseases or osteoporosis? There is no longer recommendation to use the MHT for the prevention of a chronic disease such as chronic heart disease. There is a well-known study that changed, and we know this study, which is the Women's Health Initiative randomized controlled trial study that changed the practice after publishing of this study in 2002. 80% it found after the release of this study that will be 80% decrease in the prescription of an MHT or a menopausal hormonal therapy due to the publication of the long-term use of an MHT and the increased risk of breast cancer and endometrial cancer. And also the other thing that we are hesitant regarding MHT, that we need to improve training in the menopausal medicine regarding obs-and-gynae and internal medicine, just to understand the benefit and risk of the menopausal hormonal therapy. Is there any non-hormonal pharmacotherapy that we can use? Yes, we have the SSRI and the SNRI, and it's the most effective pharmacological alternative for estrogen, including some antidepressant. Although there is no head-to-head trials have been performed, but there is indirect comparison suggests that the vanilla vaccine, this vanilla vaccine, paroxetine, citalopram, and escitalopram have similar modest benefit for hot flashes. And I believe that most of this medication are available in Wasfati and PHC, in our PHC, and we can use them effectively for our patient. Other medication, including the anti-epileptic therapy, such as gabapentin, pregabalin, clonidine, but we have to put in our mind the side effects such as dizziness, dry mouth, and the oxybutynin. What about the genitourinary syndrome of the menopause? We can use the first line to use the non-hormonal vaginal moisturizer and lubricant. If the patient doesn't get any benefit from these non-hormonal, we can use the low-dose vaginal estrogen, and it is the most effective treatment for moderate to severe symptoms. And we have different modalities of treatment, including creams, lotions, rings, and vaginal tablets. Okay. Is there any complementary and alternative therapy? I think a lot of our patients come and ask us about any alternative therapy they have from the just al-attar or from over-the-counter medication, and they ask us. We can categorize them into 3 categories, which is the promising therapies, and this is need further studies such as the CBT, the hypnosis, mind-body-based therapies, and the inconsistent evidence. There is a inconsistency between the studies, especially regarding the plant-based therapies such as isoflavins and phytoestrogens such as soya beans, lentil. All these still we cannot conclude. The black cohosh, the Chinese herb, and weight loss. Actually, the ineffective therapies such as the acupuncture, evening primrose oil, although most of our patients, they feel comfortable on the primrose oil, the flax seeds, and the exercise, although the obesity is one of the risk factors for severe and prolonged duration of the vasomotor symptoms. Is there any therapies that is not recommended? Yes, the compound bioidentical hormone therapy. And when we call the bioidentical hormone, it technically refers to hormone with the same molecular structure as a hormone that is indigenously produced, and there is no evidence for their safety and efficacy. So since there are numerous approved estrogen and progesterone formulation, so we prefer to use the well-known estrogen and progesterone therapies. Okay, at the end, I'll just conclude by my patient, how I manage my patient, Sheikh Abdul Latif. We choose the initial therapy based upon the patient's predominant symptoms, which was the mood, low mood, and excessive crying, and the loss of interest. The main concern is depression, and the hot flashes were not very severe. So we start here on an SSRI, escitalopram 10 milligram once daily, along with the CBT. So what lesson we learned from our session? That always ask about symptoms of menopause, since most of your patients will suffer without talking. Diagnosis of menopause is a clinical. There is no investigation needed. Always individualize your management plan according to the patient circumstances, and an MHT can be used accordingly. This is my references I use. Thank you very much.
Thank you, Dr. Mona, for this informative, comprehensive talk. And now we will proceed with our next speaker, Dr. Wala Ad-Dahaleb. She is a family medicine consultant, attending family physician in Doha Primary Healthcare Center in Al Khobar. And she is a clinical instructor and trainer in our Family Medicine Academy, and she's doing a great job in leading the weekly academic activity for our resident. She will talk to us today about how to manage hypertension or high blood pressure during pregnancy. So let's welcome Dr. Wala Ad-Dahaleb.
Assalamu alaikum. Good morning, everybody. Thank you, Dr. Iman, for your nice introduction. Today, inshallah, my talk will be about a very important and common topic in our primary care centers. I'm going to talk about uncontrolled hypertension management in a pregnancy. By the end of this session, inshallah, you will be able to recognize hypertensive disorders in a pregnancy, discuss how to approach and manage a pregnant lady with uncontrolled hypertension, and to list the indication for referral. First of all, when we talk about hypertension, why it is important? Actually, hypertension is one of the most common medical problems encountered during a pregnancy, complicating up to 10% of gestation. The rate of hypertensive disorders in a pregnancy increase with the presence of some risk factors such as obesity and metabolic syndrome. As effective treatments are limited, so our role as a primary care practitioner is for prevention, early detection of the risk factor and the causes. All these are of great importance. The hypertensive disorders in a pregnancy are classified into 4 categories based on the National High Blood Pressure Education Program. We have 4 categories: chronic hypertension, gestational hypertension, preeclampsia, and preeclampsia superimposed. Several epidemiological studies have been performed to determine the prevalence of hypertensive disorders in a pregnancy. The most recent one showed that the most prevalent subtype of hypertensive disorders is preeclampsia, with a wide range between 0.2 to 9.2%. Kingdom-wise, we have a lot of studies to measure the prevalence of hypertensive disorders in a pregnancy. One of these studies was done among almost 9,500 women and showed that the prevalence was low, 2.4%. Preeclampsia was found the most prevalent subtype, followed by gestational hypertension and eclampsia. Okay, now let's come to my case scenario. I saw this patient almost 3 years ago. I have a 43-year-old lady, non-smoker, gravida for bara 3. She's a known case of hypertension on diet and exercise and amlodipine 10 milligram daily. But unfortunately, the patient stopped her medication by herself for the last 2 years. And the patient was not on a regular follow-up. She has no complaint today. She came to my clinic for her first antenatal care visit. Her OB/GYN history was unremarkable. We calculated her gestational age and it was found to be 15 weeks based on her menstrual dates. Her blood pressure was measured in the office and it was found to be within a normal range, 134/90 and 138/88. Otherwise, vitally, she was stable. Apart from her BMI, she was obese. Physical examination within normal. As the patient has no frequent follow-up, so there was no recent lab for this patient. So what we did for this patient, we ordered for her the routine antenatal care laboratory testing in addition to the following test as a baseline. We ordered for her serum creatinine, urine dipstick for proteinuria, CBC, liver function test, and we screen her for diabetes. We refer the patient for ultrasound examination for accurate gestational dating. Also, regarding the non-pharmacological management, we initiate low-salt diet with the patient. We advise for home blood pressure monitoring, and we educate the patient for the red flags. I started the patient on low-dose aspirin, 1 tablet daily, in addition to the antenatal vitamins, and I gave her follow-up after 4 weeks. The patient came 4 weeks later to the clinic, but now she has mild headache on and off. It is mild to moderate in severity, occipital relieved partially with analgesia, and there was no associated symptoms. And unfortunately, there was no home blood pressure record. So I measured her blood pressure in the clinic, and at this time it was slightly elevated. The average systolic is more than 155, and the diastolic is 100 millimeter mercury. Otherwise, examination normal apart from +1 pitting edema. I review her lab, the patient having low hemoglobin 10.3, her platelet count within normal, 254, liver function test, creatinine were normal, urine dipstick negative for proteinuria, normal plasma glucose level. Ultrasound was consistent with her gestational age. So we labeled this patient now with uncontrolled hypertension. And what we did for this patient, we encourage the comprehensive lifestyle modification and refer her to dietitian. And I start her on methyl dopa 250 twice daily. We continue the aspirin and other vitamins. And at this time, we consider the OB/GYN consultation and the close follow-up within 1 week. But the patient presented again 2 weeks. She is still complaining of headache. Her blood pressure is still elevated despite increasing the dose of methyl dopa. And at this time, we found that there is a +3 proteinuria in her urine dipstick. So the diagnosis is revert now to a preeclampsia superimposed on a chronic hypertension, and we referred the patient directly to the OB/GYN ER for inpatient monitoring. There, the patient was stabilized and she was monitored for the development of severe feature. Alhamdulillah, she was delivered at 39 weeks, normal vaginal delivery. During the delivery, she received intrapartum magnesium sulfate for seizure prophylaxis. She came again to me 4 weeks postpartum. The patient was doing well. Her blood pressure reading systolic range between 135, 138, diastolic 75 to 80. She is on diet, little exercise, and methyl dopa 250 twice daily. We encourage breastfeeding. Family planning was discussed with her, and we gave her follow-up within 4 weeks. So let's have a brief discussion regarding hypertensive disorders in a pregnancy. As I mentioned earlier, we have 4 categories. The first one is a chronic hypertension. It is either a pre-existing hypertension or first detected early in a pregnancy before 20 weeks or persistent more than 12 weeks postpartum. And usually we consider the pharmacological management if we have severe range of blood pressure reading. Okay, why it is important to know about chronic hypertension? Because it have a risk on both the mother and the fetus. The most common harm that can occur to the mother, she might develop severe hypertension, superimpose the preeclampsia, as what happened with our patient, abruptive placenta, cesarean section, other complications like myocardial infarction, stroke, and death. Regarding the harm on the fetus, they may have small for gestational age or fetal restriction, preterm delivery, congenital anomalies, and neonatal death. Here in this schedule, I tried to summarize one study that was conducted to estimate the incidence and a prediction interval of adverse pregnancy outcome in a woman with chronic hypertension when compared to the general population. The study found that the superimposed preeclampsia happened in 20 as you can see here, 29.2% compared to 3.8% in the general population. The risk is almost threefold of a preterm delivery, birth weight less than 2.5 kg, and a neonatal intensive care admission when compared to the general population. Regarding the association between maternal hypertension during pregnancy and the development of congenital heart defect in the offspring, actually there is a recent study that was done to measure this association, and unfortunately it was found that there is a strong association between them. The magnitude of the effect is almost similar among all the subtypes of congenital heart defect and among multiple antihypertensive disorders. So the congenital heart defect can occur either because of the hypertension or because of the medication. This is the first category. The second one is gestational hypertension. It is usually detected after 20 weeks gestation. And the good thing is that there is no proteinuria, no criteria for a preeclampsia. 50% of the patient with gestational hypertension eventually will develop a preeclampsia. Others may have persistent hypertension. So we have to revise our diagnosis postpartum and maybe revert it to chronic hypertension, and minority of the patient may have a transient hypertension and resolve postpartum. Regarding the preeclampsia, it also occurs after 20 weeks of gestation, but here, in addition to the new onset hypertension, we will have either proteinuria or significant new end organ dysfunction. In 2013, the American College of Obstetricians and Gynecologists removed the proteinuria as essential criteria for the diagnosis. So the occurrence of a new onset hypertension and significant organ dysfunction are sufficient for the diagnosis of a preeclampsia. Preeclampsia superimposed, and this is my case, it is usually occur in a patient with a chronic hypertension. After 20 weeks of gestation, the patient might develop either one or more of the following criteria. They might have worsening or resistant hypertension, a new onset or sudden increase in proteinuria, and or significant new end organ dysfunction. It can occur up to 40%. There are several factors increase the risk of having preeclampsia superimposed, as in my patient, if she is having long-standing severe hypertension, untreated or uncontrolled, or if they have secondary hypertension, obesity, smoking, or a previous history of preeclampsia. So our goal as a primary care practitioner is to establish the diagnosis, decide the treatment threshold, decide the targeted blood pressure, and avoid the drugs that might adversely affect the fetus and the mother. Okay, how to approach a patient with a chronic hypertension? Usually, the first antenatal care visit should start before conception, in which thorough history and physical examination should be done. And in addition to the routine antenatal laboratory test, we have to put in mind that we have to order some extra laboratory tests if was not obtained within the previous 6 months. We have to order serum creatinine, urine protein creatinine ratio, or a 24-hour urine for total protein, CBC, electrolyte, liver transaminase, and a platelet are optional. And cardiac assessment is very important, especially if it was not done in the previous 1 year. We can order to the patient transthoracic echocardiography to look for the evidence of left ventricular hypertrophy. And if we don't have this facility, we can order instead ECG. Testing for secondary causes, reviewing the patient medication, looking for any comorbidities is also important. Although have limited data, but recommended home blood pressure monitoring also should be considered. Obstetrician, maternal fetal medicine consultation should be considered from the beginning. Regarding the ultrasound examination, in addition to the routine, what we do is the first trimester and at 18 to 20 weeks for anomaly scan, we have to initiate sonographic screening, looking for fetal growth restriction at 28 to 38 weeks, and we can order it earlier if you are suspecting small for gestational age. Regarding the pharmacological management, there are minimal information on the effect of salt-restricted diet, DASH diet. However, these are considered healthy lifestyle approaches, and it is reasonable to continue during a pregnancy. We have to encourage the mother to meet the gestational weight gain according to her BMI. And in this schedule, you can find the recommended weight gain based on the patient BMI. So as my patient was obese, so 5 to 9 kg only is recommended. We have to tell the mother that excessive weight gain and adiposity associated with high blood pressure reading and may lead to weight retention postpartum. Regarding the pharmacological management, the first thing we have to think about is starting low-dose aspirin at 12-week gestation as recommended by the U.S. Preventive Task Force. The U.S. Preventive Task Force now expand the recommendation not to involve only women with preeclampsia, but also to involve women with multiple gestations, chronic disease like diabetes, hypertension, renal disease, or autoimmune. Regarding the recommendation by other guidelines like the American College of Obstetrician and Gynecology, they also recommend the initiation of aspirin late in the first trimester in 2 conditions. If the lady having history of a preterm delivery due to preeclampsia, or if she is having more than one previous pregnancy with preeclampsia. Regarding the vitamin D supplementation and the incidence of a preeclampsia, is there association? Actually, I find in the literature a lot of study talking about the association between these two. This study showed that it's almost done on 4,700 ladies in two arms. The first arm received vitamin D, the other one was the control or did not receive vitamin D. And the study found that administration of vitamin D during pregnancy associated with reduced risk of preeclampsia, and the risk was a little bit lower among women who started earlier, up to 20 weeks of gestation, or who was taking a high dose of vitamin D. Okay, when we come to the most important part for us, the management and the decision when to start pharmacological treatment, first of all, put on your mind whether it is severe or non-severe hypertension. Severe hypertension should be considered if the reading is more than or equal 160/110, and here we have to consider pharmacological treatment. Our target is a gradual blood pressure reduction. If the reading was non-severe, below 160/100, then the decision to start pharmacological treatment is depending on whether the patient is taking medication or is having end organ dysfunction. If the patient was not on antihypertensive medication, no end organ dysfunction, then we can start her with conservative management. We will consider pharmacological management if she is having severe range. If the patient was on medication but still no end organ dysfunction, then we have to individualize. We can continue our medication with the patient with consideration of stopping the medication in the first trimester to minimize fetal exposure. And here our target will be below 150/95. The target or the threshold for initiation of pharmacological treatment in the patient with end organ dysfunction will be lower, 150/100, with the target less than 140/90. What I mentioned is also supported in the American College of Obstetricians and Gynecologists. In this slide, I try to summarize some of the guidelines, like NICE guideline, International Society for the Study of Hypertension in Pregnancy, which have a lower threshold for starting pharmacological medication and lower target. Regarding the medication used for managing hypertensive disorders in a pregnancy, we have several recommended medication like labetalol, hydralazine, extended release nifedipine, and methyl-dopa. What I'm going to talk about is methyl-dopa, as is the only available medication in our primary care. Usually we start 250 milligram either twice or 3 times daily, and we increase the dose every 2 days as needed. The maximum dose is 3,000 milligram, and the good thing that this medication is having long-term safety profile, and the sedation is considered the most reported side effect by the patient. This is a recent study done to compare the efficacy and the safety of oral anti-hypertensive medication among pregnant women with chronic hypertension. The study found among beta blocker, atenolol was not recommended, associated with increased risk of a small for gestational age. Regarding the other medication like nifedipine, methyl-dopa was considered safe and associated with decreased incidence of severe hypertension, but the effect on preeclampsia was similar. Some of the medication better to be avoided during a pregnancy, like ACE inhibitor, ARBs, direct renin inhibitor, and if the patient already on these medication prior to a pregnancy, we have to change the medication before getting pregnant, as they are associated with significant fetal renal abnormalities and oligohydramnios. Spironolactone never considered safe during pregnancy. There is one case report associated with ambiguous genitalia in a human and newborn. Other studies most done on the animal. Nitroprusside is usually the last resort, and usually we reserve this medication for the refractory hypertension. There are limited clinical experience and can be associated with possible fetal cyanide poisoning. Regarding the frequency of antenatal care visits, we will need more frequent based on our cases. Education about the signs and the symptoms of a preeclampsia, very important. Regarding the fetal well-being monitoring, at 28 weeks, we have to educate the mother about the daily assessment of the fetal kick count, and if it was found to be less than 10 in 2 hours, then a prompt assessment should be done. At 32 weeks, it is better to start antenatal fetal surveillance for a pregnant lady if she was controlled with medication. If she was not controlled, then as the earlier assessment should be considered. Regarding the timing of delivery should be individualized and decided case by case. The American College of Obstetricians and Gynecologists would arrange and recommended timing for delivery according to the patient, whether controlled on medication or not, and the severity of the case. Intrapartum care and management should be done as in the general obstetric population. Cesarean section should be reserved for standard obstetric indication. Intrapartum magnesium sulfate administration for seizure prophylaxis is not indicated in the absence of superimposed preeclampsia, as the risk of seizure is low, less than 0.1%. And in a woman with a chronic kidney disease, we have to be careful when administering magnesium sulfate because of the risk of magnesium toxicity. Rapid fluctuation in the blood pressure should be avoided and minimized. Antihypertensive medication started before labor should be continued intrapartum. And if we have severe blood pressure reading, we have to initiate IV labetalol, hydralazine, or immediate release oral lifidipine. Regarding the volume status, fluid intake, and outcome, all these should be considered to maintain euvolemia. Okay, when we come to preeclampsia superimposed on a chronic hypertension, as in our case, the patient should be initially monitored in the hospital for inpatient monitoring and looking for severe feature development. In the absence of severe feature, the patient can be discharged, monitored on a closed outpatient setting, while in the presence of severe feature, the patient should be hospitalized until delivery. The timing and the indication for delivery based on several factors like gestational age, disease progression, severity of the disease, and the result of the ongoing fetal and maternal assessment. Regarding the postpartum care, analgesia is very important. We have to keep in mind that the patient blood pressure will immediately decline postpartum, maybe because of a fluid loss, but it will start to increase within 3 to 5 days. So we have to follow up a patient at 3 to 10 days or 2 weeks if she can measure it using home blood pressure measurement. The choice of the medication will be the same as during a pregnancy or a pre-pregnancy. Breastfeeding should be encouraged, and put in your mind that you are using medication with a good safety profile during breastfeeding. In this table, I summarize some of the medication and their safety profile. Among beta blocker, you can use labetalol safely, calcium channel blocker like nifedipine, diltiazem, verapamil, ACE inhibitor. All these are acceptable options. Try to avoid ARBs as no data available. Regarding the use of diuretics, there are some theoretically, they mentioned that it is associated with reduced milk volume, but it is safe to use low dose hydrochlorothiazide below 50 milligram. Methyl dopa and hydralazine are considered safe, but make sure that the patient did not develop maternal depression. Family planning and contraception, discussion about appropriate timing for a future pregnancy should be discussed with the patient. If the patient was having uncontrolled hypertension, then try to avoid estrogen-containing contraceptive. Follow up with the primary care provider, and cardiovascular risk assessment is of a great importance. So in summary, ultrasound is superior for accurate gestational dating if we are not certain about the menstrual date. At 12 weeks of gestation, initiate low-dose aspirin to decrease the risk of a preeclampsia. Measure the patient blood pressure at each perinatal visit. At 20 weeks gestation, discuss with the patient the sign and the symptoms of a preeclampsia and when to seek medical advice. At 28 to 32 weeks, start ultrasound screening for fetal growth restriction, and you can repeat it every 3 to 4 weeks. At 32 weeks, start the antenatal fetal testing, either with non-stress test or biophysical profile. The timing of delivery should be considered based on the patient controllability, whether she is on medication or not. Okay, this is the end of my talk. Thank you for listening.
Thank you very much, Dr. Wala, for this very comprehensive talk. And now we'll proceed with our next speaker, Dr. Haifa At-Turki. My pleasure to have you here with us. She's professor and consultant of obstetric and gynecology and infertility at Imam Abdurrahman bin Faisal University. She had an Australian fellowship in assisted reproductive technology and a member of the American Society for Gynecology and Laparoscopic Surgery. She will talk to us about how to assess patient with infertility or women with infertility at primary healthcare level and in vitro fertilization counseling. Welcome, Dr. Haifa.
Assalamu alaikum rahmatullah. Thank you very much, Dr. Iman, for this wonderful introduction. Good morning, everyone. It's a pleasure to be here with you today. I would love to thank the organizing committee as well as the event troop for all the efforts they tried all over the preparation for this event. And I would like to congratulate all of us for passing the difficult period of COVID-19. And finally, we can have some freedom a little bit, but still I can remind myself and you of having some precaution standards as we are still on the gray zone. I guess all of you had some difficulties in having the parking, so I hope that everybody is catching on. Okay, do we have a pointer? Is it working? Okay. Okay. Appreciate it. Thank you very much. So I don't have any disclosure regarding the presentation today. Okay, so what is the objective? Why we are here today? Personally, we are here to highlight the infertility in general, but as well as asked to speak more about female infertility. So we are here specifically going to discuss some issues about female infertility. We are here also to help our colleagues from family medicine, GPs, and general practitioners to approach infertile patients. As we know, this is a great struggle with a lot of people to have such cases, and to help the infertile couple to achieve their dream of paterning a child. And of course, we have to remember all that we have to follow the national and international guidelines of infertility, as well as to be updated and the best practice. All of us, we know that infertility is a medical condition. Unfortunately, it was not considered as a medical condition before. It was not considered to be even a disease. But in 2010-2011, the WHO categorized infertility as a disease, finally. Unfortunately, again, a lot of people, they are still looking at infertility treatment as a luxury. It's not a condition that's really affecting the life of the patients or the couple. There are a lot of psychological, spiritual, mental, social, and medical impact on the couple. And it is one of the conditions where you will find that the couple are suffering together. Most of the time, it's an individual suffering. But here in infertility, we do have the whole couple affected. Their life is completely affected because of this issue. So here we are going to speak about female infertility, although we know that male infertility or infertility in general should be really highlighted. What is the definition? Reproductive endocrinologists define infertility when a lady who is younger than the age of 35 having unprotected regular sexual relation for 12 months and was unable to conceive. We do have primary, as all of you know, and secondary infertility. Primary infertility, that this patient's never conceived or get pregnant before. Secondary infertility, that this patient got pregnant regardless to the outcome of this pregnancy, whether she was ended with ectopic pregnancy, miscarriage, preterm delivery, or a full-term delivery. Is it important to highlight it? Is it of high prevalence? Yes, it is. About 10% in the worldwide ladies or a couple suffering from infertility. It was found in search literature that about 1 in 4 ladies, they are suffering from infertility. And as it is related to the biological age, so time is ticking, whenever the patient is getting older, her chances of fertility will be declining. So it is a global condition, but it was found that in certain regions, the infertility a little bit is common or much higher, like in East Europe, North Africa, and Middle East. And now, of course, people are migrating from one place to another, but it looks that it has some ethnicity underlying conditions, maybe some genetics issues that's playing a role, or as well as environmental factors. In the Middle East, we do have a lot of conditions recently affecting us, like the environmental factors, the effect of the wars we pass through. We do have intermarriages. All of these factors may play a real role in infertility cases. 2% of the women between the age of 20 to 40, they were unable to have a live birth. A live birth, we're not speaking about pregnancy, we're speaking a take-home baby. And about 11% of those ladies who had a birth before, they were unable to have a second child. So why this period of 12 months were proposed, and then after that the 6 months? Because it was found that about 85% of the ladies who are having a regular sexual relation, 85% of them will conceive within 12 months. And the chances will be based on the beginning. Also, in the first 3 months, they will have a chance of 25% to be pregnant, decline to 15% after that in the coming 9 months. And that's why we know as time is passing, the chances of fertility is going down. And that is happening when the ladies are less than 35 years of age. Above 35, that's why we are recommending them to be starting their follow-up as soon as 6 months passed after a regular unprotected sexual relation. Because after the age of 35, the decline of the infertility started, the chances of abnormality will be higher. And a lot of studies was found that the ladies will have a lot of aneuploidy as soon as the age of 37. And as you know, when the ladies are reaching the age of 40, their chances of a pregnancy may not exceed 10%, but their chances of miscarriage may reach up to 80% because of the abnormal embryos due to an abnormal oocytes. What about in our region? Unfortunately, we don't have a national audit or a national survey, and we don't have a national registry, as in the breast cancer registry. We don't have infertility registry in the country. But we looked on that, and we published a study on the fertility, on the Middle East fertility in 2015. And we found out that about 19% is the prevalence of infertility in the Eastern province. But we do have weakness in this study, and we can admit that. The weakness of our study, that it was a hospital-based. Be a hospital-based, because you should look on the public if you are looking on the infertility. So definitely we were looking on hospital-based, where most of the patients who are seeking help are coming. But there was another study which published a few years ago also showing that in Al-Hassa there was about 20% the chances of infertility. So we are more or less on the same scale. What are the causes of infertility? As you know, we do have a male factor, female factor, an X-linked, or even a combined factor. I can tell you that male factor is the main cause of infertility recently globally. We published a study in Saudi Annals about 2016, 17, I cannot recall, sorry. And we found at that time that the chances of infertility due to male factor reaching up to almost 50%. I can tell you and guarantee you, if we will repeat a similar study, nowadays it will be much higher. It was reported now recently in a lot of places worldwide that male factor is responsible about 60% of infertility. So globally, there is a reduction or a decline in the male fertility. But here we are looking on the female infertility, which is counted about 40%. Unexplained infertility also starting to be higher than before. It was reported to be 10 to 15%, and now it's reaching to about 25%. We are always saying unexplained. Yes, for us nowadays, it may be explained in the future. Most of the causes of the female fertility is related to ovulatory disorders. About 25% of the causes of female fertility is ovulation disorders. After that, we do have the tubal factor, endometriosis, and so on. So how can we categorize ovulation disorders? The WHO made it a little bit easier for us in categorizing the ovulation disorders into 3 categories. Category number 1, which is caused by hypothalamic pituitary failure. So we do have a failure on the hypothalamus level to the pituitary level and then to the ovarian level. So the hypothalamus is not giving enough gonadotropin releasing hormone agonist pulsation, and accordingly, the gonadotropins will be low. If you will check the FSH and LH, they will be low, and accordingly, those ovaries are not responding. This counts about 10% of all the cases of infertility or ovulation, disorder, sorry, and most of those cases would present with primary amenorrhea. The commonest group is group 2, where most of them are polycystic ovarian syndrome. So we don't have any problem on the hypothalamus, no problem in the pituitary, no problem in the ovary, but we have a misconduct, no proper communication between them. So those are the commonest. It's count about 85% of all the ovulation disorders. And as we said, that the PCO is the highest prevalence on those. The least group is group 3, where we do have ovarian failure, or now what is called as ovarian insufficiency, where there is enough pulsation from thalamus and the pituitary secreting high gonadotropins, but unfortunately, the ovaries are not responding. It's account about 5% of the whole population. Those patients may present with a primary or secondary amenorrhea even, or they can be menstruating. So that's why the ovarian insufficiency start to be more common now to be diagnosed. In those cases, you will have a high FSH-LH level, but the patient will be most of the time hypoestrogenic. As we spoke about polycystic ovarian syndrome, I know that Prof. Jama, I guess, will give a lecture about polycystic ovarian syndrome, but I encourage all of you to download this beautiful booklet, which can be downloaded free of charge. And it is the international evidence guidelines for the assessment and management of polycystic ovarian syndrome. It was published in 2018, and it is a wonderful, wonderful, wonderful guidelines. It was started in Australia by the Monash University in collaboration with the ISHRI and the ASRM. And here you will have all the management, not only for infertile patients with polycystic ovarian syndrome, but also as a management for polycystic ovarian syndrome, where I guess all of us are facing a lot of cases. You per se, as a family medicine, you will have a lot of cases who are coming with irregular cycle and other problems of polycystic ovarian syndrome. We said that the evaluation should be started earlier if the patient is younger or older than 35, and it should be within 12 months if the patient is 35. Should we start a little bit earlier? Yes, we have to, if the patient is having other underlying condition. So if this patient is having irregular cycle, oligomenorrhea, or amenorrhea even, we'll not tell the patient to go and wait for a year and come back to us, because we know that nothing will happen in a year. She is having a problem with her ovulation. If the patient is having a history of pelvic inflammatory disease, whether she was hospitalized and was on extensive antibiotic, or there was a history of any infection with gonorrhea or so on. If there is a destructive pelvic surgery, if this patient had a massive pelvic surgery, if the patient was exposed by any means to a chemotherapy or radiotherapy, or if she's a known case of severe endometriosis, because not all the cases of mild, minimal or mild endometriosis need an intervention as soon as possible. How can we approach those female infertility? Of course, history is always the key for anything. As we are telling our young junior medical students colleague that history is the most important, we have to remind ourselves that you cannot approach any diagnosis without a proper history. So you have to look on the age as the first thing of this patient. So this is your compass to guide you where to start and where to go. The duration of infertility. For her obstetric history, if she got pregnant before, what happened during her obstetric history? Menstrual cycle, to check whether she is having a regular cycle, that will indicate any ovulation or not. Any previous medical, surgical, any chronic diseases, and any history of sexually transmitted diseases. Sexual history is very important, and please don't feel shy to discuss this with your patient, because unfortunately, I do have a lot of patients who are coming, they are not infertile per se, they don't have an infertility issue, they do have a sexual issue. So either they are having vaginismus on the female side, or there is an ejaculation problem, or erectile issues with the male partner. So discuss exactly what is happening during sexual relation, if it's a complete one, or there is any problems during the sexual relation. Look on the patient's lifestyle, whether she's a smoker, using any substances, what is her occupation, and so on. Family history is very important. And why we're looking on the family history? Because you can identify a lot of underlying genetic issues or aneuploidy in the family, where you have to help the patient not only to get pregnant, but hopefully to have a healthy child. Then we will follow, of course, with physical examination. You have to look on her vital signs and the BMI. And the BMI is very important. We are always highlighting it. And unfortunately, a lot of people, they are missing that, just starting whatsoever they have to do without paying any attention to the BMI of the patients. To have a very low BMI is a problem, having a high BMI is a problem. Actually, in a lot of places, you will be sued if you start the patient on ovulation induction if the BMI is high as 35. So your aim is not to make this patient pregnant. Your aim is to have a healthy pregnancy. Unfortunately, once we had a patient or the scale cannot take even her weight, and her BMI is definitely more than 50. And this patient received ovulation induction somewhere. She got pregnant. She came to the hospital when she was term, and she ended with thrombosis. So here you have to be very careful when you are initiating the physical examination. You have to look on the thyroid, of course, because we do have also a lot of thyroid issues. You have to do the breast examination. And as we are in October, we have always to remember that breast examination is very crucial to any lady, and to look for any androgen access and so on. And we have to skip because Dr. Ima is showing me that I do have only 10 minutes. Investigations, yes, again, we said that male partner is not included, but I have to tell you, please, always look on the male partner. A lot of patients coming to the clinic and she's saying, I did everything, I'm fine. And I told her, what about the semen analysis of your husband? She said, no, they told me, let's finish with you first. And then we'll see, there is nothing called, we'll finish with you and we'll finish with him first. It is a disease of the couple. We have to work on the couple all together. Then we have to assess the ovarian function and reserve. We have to assess the uterine cavity, and then we have to assess the ovarian, the fallopian tube. We will go quickly on the way how to assess the ovarian function. Antral follicle count is one of the best indicator. It's very easy. It can be done on the follicular phase, day 2 or 3 of the cycle. It's just a pelvic ultrasound bedside. You will look on the antral follicles, which is less than 9 millimeter, to know whether this patient is having enough reserve or not. And now the ovarian volume, one of the things which can help, and it can be calculated easily with the advanced vaginal probe. FSH on the follicular phase, day 2 or 3, is again indicator. It was the only indicator before we used to have. It's not as sensitive as the antral follicle count and the AMH, but still we can depend on, because you will have a lot of patients still having normal FSH, but they do have a low ovarian reserve. AMH, or anti-Mullerian hormone, was the thing which came to the bubbed on the market. We said, yes, we have the best indicator, but it's not anymore really, because we know that there's a variation from lab to lab, and it cannot really indicate exactly. And especially when the Boussidian criteria came, we do understand that a lot of patients, they do have a normal AMH, but they will have a low or they will have a poor response. Fallopian tube, of course, you know that the histosalpingography can be done. It's easy, will not give a lot of radiation, but it is inconvenient to the patient, and you have to educate your patient, because a lot of patients, they are just scared from performing histosalpingography. And histosalpingography is more than enough. You can do sonohystro also, where you just put a catheter in the cervix and inject a saline. It can show you the uterine cavity, but it may need more experience to show the tube's patency. Laparoscopy is the gold standard, but you don't need to go for laparoscopy unless you need to do something. Like if you have a hydrosalpinx, you want to remove the hydrosalpinx before the procedure, yes, you can do that. If the patient is having an ovarian cyst or other indications, that he will go for surgical, but it is never the first line for diagnostic procedure. Assessment of uterine cavity, as we said, sonohystro is wonderful. If you are expecting a polyp, submucous fibroid, sonohystro can help you. The ultrasound, vaginal pelvic ultrasound, and by the use of a 3D vaginal scan, you can approach. Yesterday, I had a patient who the sonographer was doing the ultrasound, and I bobbed in to look on her ultrasound. And I felt that there is something abnormal on her cavity. So it looks to be either a bipronate or a septum. And when we performed a 3D vaginal scan, it beautifully showed that there is a septum. So if you do a 3D vaginal scan, sometimes you don't need even to go for MRI or other diagnostic. Of course, hysteroscopy is the gold standard. But again, we recommend hysteroscopy for see and do. You don't go for hysteroscopy just for diagnostic. If you are having something, then you can do the hysteroscopy to diagnose and perform. Differential diagnosis, of course, it's more related to the abnormality in the ovulation. You have to get sure that you are not having thyroid problems, patients who are having congenital adrenal hyperplasia, and most of them will be diagnosed a little bit earlier. Okay, how we are going to manage those patients. Lifestyle management is one of the first things we are speaking about, and that's why we said BMI is very important. Patients who are overweight, the first thing you have to do, ask them to reduce their weight. And now even in a lot of places, their bariatric surgery is covered by the insurance if this patient is failed to get a pregnancy, as they are failed to control their diabetes and so on. If the patient is a smoker, they have to put smoking, regardless to the type of smoking, whether they are vaping, cigarettes, shisha, whatsoever, and advise them to start on folic acid if they did not start yet. And I think you guys in the family medicine doing a great job on that. Then we have the real management on controlled ovarian hyperstimulation, where you are using an ovulation induction agent, whether it's oral or gonadotropins. And most of the time, we encourage our colleague from the family medicine to start the oral and to skip the gonadotropins for the fertility physicians, not to have the complications as we are going to speak about it. intrauterine insemination, and most of the time intrauterine insemination is saved or spaced for the male factor, a mild male factor, but it can be used also in some of the patients who they are having failed to have a response with ovulation induction alone, and they're especially having one patent tube. IVF can be done as a first step because of the age factors, can be done because of repeated failure of ovulation induction, or because of a tubal factor, and ICSI, as you know, intracytoplasmic sperm injection in cases of a male factor. Abortive procedures are very important when you are suspecting, again, as we said, a septum, a uterine septum. You have to go and remove it. If the patient is having a hydrosalpinx before going to the procedure, you have to go. So abortive procedure can be spared for the cases where there are abnormalities, and you have to go for that. Of course, for other abnormalities like bicornuate uterus and so on, it is recommended now not to do any on those patients, and fertility preservation, as we are going to see. Of course, this is the IUI. It's a very simple office procedure. IVF started in 1978 by Louise Brown. A lot of procedures done after that can be done with paracervical block or sedation. It's an office, it's a daily procedure, and there are a lot of cycles now worldwide done. And ICSI, of course, the same, but you have to inject. Fertility preservation is very important, and that's why we encourage sometimes patients to go for IVF earlier, so they will have an extra embryos or cerebellous embryos where will be frozen in the future. We do have a lot of cases that those patients got aged, and one of the patients reached even the menopause, and she was having a frozen embryo, and she got pregnant and had twins after that. So those cases showing how important to have really a fertility preservation by having a frozen embryos. In patients who are having malignancy, it's very important. Again, as we are saying, we do have a lot of breast cancer cases. Eastern province is one of the highest registry in the nation for the breast cancer. We encourage those patients to do fertility preservation. We are so proud that في 1440 هيئة كبار العلماء give a permission for oocytes freezing and ovarian tissue preservation or cryopreservation. And we do have a lot of patients, unfortunately, having an underlying malignancy, and their oncologists discussing all the treatment with them, but they are forgetting to discuss their fertility issue. And they are coming after finishing their chemotherapy or radiotherapy or wherever already they started. So please, it is also from your side to give all the education. Any patient with malignancy, we don't want them only to survive, we want them to have a quality of life. What are the complications of ovulation induction and so on? Multiple gestation is one of the highest, and it was reported worldwide that a lot of multiple pregnancies occurred because of ovulation induction rather than the IVF, because in IVF you can control the number of the embryos you are transferring. Usually with ovulation induction, like clomiphene citrate or letrozole, which is aromatase inhibitor, the chances are not high as in gonadotropins. And now the letrozole or the aromatase inhibitor is like becoming more a first line because it gives only monofollicle, 1 or 2 follicles, so chances of multiple pregnancy is less compared even with the clomiphene citrate. But with the gonadotropins, the chances can be more than higher. If you look that in the assisted reproduction, we have 10 times increase on the chances of multiple pregnancy compared to a natural conception with twins or so on. And that's why it is recommended in most of the countries. We don't have this law in the country. We are working now in a new guidelines for IVF. I'm a member of this committee. It's still unlikely that we will go for a single embryo transfer, but in a lot of Western countries, i.e. mainly Scandinavian countries, they are not allowing more than 1 embryo to be transferred if the patient is younger than 35, 36 years of age, unless you have to justify why. And with that, the chances of multiple pregnancy will be less than 1%. Ectopic pregnancy is another problem, and most of the time it is happening because of the maybe underlying issue, because we know that these patients are having an issue of their fertility, and that's why they are not getting pregnant. And it's happening mainly because of the tubal factor. It may increase up to more than 30% if those patients are having a reconstructive surgery like tubal reanastomosis. Observationally, it was found that all the patients who are having ovulation treatment or assisted reproductive, they may have ectopic pregnancy, but it failed to be statistically significant if the patient is having only ovulation induction or ovulation induction plus IUI to have ectopic pregnancy compared to the normal population. It is more with the IVF cycle. Of course, OHSS, ovarian hyperstimulation, is the nightmare for any physician because it has a lot of morbidity and mortality, and it is preventable condition. We have to remember that it is preventable. So now with the advanced freezing system, we can just go, we don't need to cancel any cycle, and then we can freeze all and transfer when the patient's condition is allowing that. Because ovarian hyperstimulation is still up to date in UK, there is about 1% annual report of mortality related to ovarian hyperstimulation syndrome, which definitely don't want anyone to go on this journey. Things to remember, that infertility is a very devastating condition to anyone, to their couple, their family, and so on. And the best way is a proper counseling. And we have to understand the emotional stress, physical, financial stress, because unfortunately, still up to now, we don't have a proper programs to help those patients during the or over the nation. Most of the patients, unfortunately, they are paying it by their pocket, and still the insurance company is not covering in most of the cases. You have to remember that you have sometimes to refer those patients as early as possible, but you have to do the proper workup before referring them. You can start the ovulation induction, but there should be a limitation. You should not keep bobbing those patients with ovulation induction. You should not continue from or to start from zero. You have to continue from where this patient had. We had a lot of patients that had many cycles of ovulation induction. And when they are coming, their physician will say, okay, I will start with you and I will see your response. No, please don't do that. We have to have the emotional and educational support. You have to remember that there should be no feeling of guilt or blame. It's the disease of the couple. We all work together as a team. I don't think that we do have time for the scenarios, so just feel whatsoever you like if you'd like to have any scenarios. Thank you very much.
Thank you very much, Dr. Haifa, for this lovely, inspiring, humanistic talk. Okay. I would remind the online audience that they can write their questions in the chat, and we will answer their questions, inshallah, during the panel discussion. Now we will proceed with our next speaker, Dr. Saleh Al-Nas, who is a consultant, family physician, and diabetologist. He's an attending family physician in Dareen Primary Healthcare Center in Qatif, and he's a clinical instructor and a trainer at our Family Medicine Academy in Eastern Province. Dr. Saleh will talk about how to manage diabetes in a pregnancy. So let's welcome Dr. Saleh.
Okay, assalamu alaikum wa rahmatullah. Thank you, Dr. Iman, for the nice introduction, and thank you, Prof. Haifa, for excellent talk about infertility. My talk will be about very prevalent condition in our country, diabetes management in a pregnancy. So I will go through the definition of GDM and we'll come across the controversy about the definition of GDM. Then we'll talk about the lifestyle therapy and the appropriate pharmacotherapy. Then we'll talk about the postpartum. Starting with the two questions. You have 10 seconds to vote. This is 36-year-old woman, no previous pregnancies. She presented for the first antenatal health check, booked for 8 weeks gestational. So 8-week gestational, found to have fasting plasma glucose 140 milligram, A1C 7.3. The question, does she have gestational diabetes? Yes or no? Okay, so the majority, they said yes. She does have gestational diabetes. What about you? You are included in the voting? So I see a lot of waving no. No. Why I'm pointing to this question? Because this is critical. This is the first booked visit for your patient in primary care settings. She's found to have a reading consistent with what's called overt diabetes. What's so important and critical about this, she needs to be started medication right away. And you would refer for our colleague obstetric, for the obstetric care. Why is that? We don't want to delay. You don't label those to have GDM and you start lifestyle therapy. So you are delaying. So this is from the first, she's presenting with reading consistent with what's called overt diabetes, A1C 7.3 at 8 weeks gestational. This is tell us that this patient is having diabetes before getting pregnant. Moving to the second. Okay, this is the second voting questions. 28-year-old woman presented first antenatal health visit, booked at 12 weeks gestational, found to have fasting plasma glucose 99 milligram. So is it GDM, pre-gestational diabetes, normal or overt diabetes? For voting. Okay, so the majority, they choose normal, and we have 9% GDM and 22% pre-gestational diabetes. Pre-gestational diabetes, this is the terminology for pre-existent diabetes, whether it is type 1 or type 2. The patient labeled to have diabetes before getting pregnant. So for this scenario, it's not pre-gestational diabetes. Over diabetes, the first recognition of diabetes during pregnancy, like the scenario we presented the previous questions. So is it GDM or normal? This is the controversy here between the guidelines. If you would go with the ADA, they clearly stated in some of the versions of their standard medical care that GDM cannot be diagnosed in the first trimester. GDM is the first recognition of glycemia or dysglycemia in second or third trimester. The WHO, still they are labeling ladies with such reading with GDM even in the first trimesters. And both of them, they have their own rationale for this. Okay, so to summarize it, gestational diabetes diagnosed in second or third trimester of pregnancy that was not clearly overt diabetes prior to gestation. Overt diabetes is pre-gestational diabetes first recognized in a pregnancy and pre-gestational diabetes, this is either type 1 or type 2 pre-existence. Patient already labeled to have type 1 or type 2 prior to pregnancy. So both WHO and the ADA, they adopt the same threshold, the International Association Diabetes Pregnancy Study Group, based on this landmark study. It's called HABU study. This is landmark trials, and actually they defined, although they go with low threshold for defining gestational diabetes, but their definition based on maternal and fetal complications, based on the macrosomia, cesarean section, neonatal hypoglycemia. So they defined gestational diabetes based on these outcomes. The ACOG, based on the CCC criteria, they defined gestational diabetes based on the future risk of type 2 diabetes. So the ADA and the WHO, they adopted this low threshold based on the HABU trials. And this is the criteria, and the low threshold fasting plasma glucose 92, 1 hour 180 milligram, and 2 hour 153 milligram deciliter. Anyone, it's diagnostic for gestational diabetes. The difference between WHO and the ADA, WHO still recognizing gestational diabetes in the first trimester, while ADA, they clearly stated that gestational diabetes to be diagnosed in second or third trimester. The over diabetes, you are using non-diabetes or non-pregnancy criteria, fasting above 126, random above 200 milligram, and the A1C above 6.5. So we'll go through this to the remaining of the lecture. Case study, Sahar's 35-year-old woman, 2 previous uncomplicated pregnancies. At 24 weeks, she proceeded to OGTT and found to have the following reading: fasting plasma glucose 95 milligram, 1 hour 187, and the 2 hour 152 milligram. Does Sahar have gestational diabetes? No voting for this question. Okay, so she's having 2 abnormal. This one exceeding the 92, and this one exceeding the 180, and this almost touching 153. So she's have 2 abnormal, and she's having gestational diabetes. To start with, gestational diabetes need to be managed with multidisciplinary team. A team composed of diabetologist, endocrinologist, or primary care physicians, and the obstetrician, diabetes educator, the dietitian, the diabetes nurse specialist. Wherever you have the full components of this team, you could manage this patient. So to start with, does treating gestational diabetes showed by evidence that it decreased complication? Before bothering ourselves of treating GDM, does it have an evidence that treating GDM will prevent complication? Yes. Treatment GDM has been shown to prevent complication in pregnancy outcome, both fetal complication and maternal complications. Okay, and the lifestyle intervention is usually the start for gestational diabetes. But like the case we present the first one, if patient having overt diabetes or reading consistent with overt diabetes, okay, usually we start with medication right away. Along with the lifestyle, we shouldn't delay pharmacological management if the reading consistent with overt diabetes. This is a BMG meta-analysis showing the clear benefit of treating GDM, both in the macrosomia, the fetal complication, and the shoulder dystocia. So it's clearly that treating GDM prevent or decrease the complication of gestational diabetes. And usually we started with a trial of lifestyle therapy if the reading not consistent with the over diabetes. The fasting is not exceeding 7 millimole. What's the lifestyle therapy? it's person-centered, weight management, gestational weight management, physical activity, diet, and performing what's called self-monitoring blood glucose. This is the lifestyle therapy we start with our patients. We start with controlling the gestational weight gain. Why is that? Because excessive weight gain associated with adverse outcomes for both the baby and the mother. Okay, so usually we tend to minimize the weight gain for gestational diabetes. Okay, for obese, we don't exceed 9 kg, 5 to 9 kg. So above 9 kg, this is too much for obese lady. Okay, and the evidence showing that it's safe and has been shown. Why? To minimize the weight gain, decreasing the insulin resistance, and decreasing the requirement of insulin doses, and decreasing both fetal and maternal complication. This is from the Institute of Medicine in 2009, and clearly they show for obese lady, total weight gain over pregnancy 5 to 9 kg. And for the overweight, you go from 6.8 to 11.3, and for the normal weight, go from 11 to 15.9 kg. We're done with controlling or minimizing gestational weight gain, and we have shown that it decreases complication, both maternal and fetal. Moving to the second component of lifestyle therapy, which is the physical activity. Of course, if there is no obstetric contraindication, for physical activity, we advise all to have a minimum of 30 minutes exercise or physical activity per day, or to be divided 10 minutes 3 times per day. And the studies shown that physical activity reducing the glucose concentration, reducing the insulin resistance, but unfortunately, the studies didn't show that physical activity will reduce perinatal complication. But still, we advise pregnant with gestational diabetes to do physical activity, because this will help her to control her glucose. And how we define moderate physical activity, we tell our patient that you would be a little bit slightly out of breath. Okay, moving to the third component of lifestyle therapy. We're done with the gestational weight gain, with the physical activity, and we are talking about the whole bulk for the lifestyle therapy, which is dietary advice. This picture is a lot of carbohydrate, a lot of vitamins, minerals, fibers, which all beneficial for pregnant ladies. Why we are focusing on carbohydrate? Because many women with gestational diabetes, they tend to restrict their carbohydrate intake, and restricting carbohydrate to less than 170 grams per day associated with ketones, and ketones, you know, cross the placenta, and it's harmful for the baby. So low carb diet is not advised for gestational diabetes. Yes, we do advise to go with low glycemic index diet, because especially when you have troubles with 1 hour or 2 hour postprandial hyperglycemia, it will help us, the low glycemic index diet. Okay, and we tell patients to substitute the high glycemic index with low glycemic index. And of course, all of them, they should get individualized plan based on their needs and characters. We don't get pre-printed material of 1700, 1800 kilocalories to be distributed to all pregnant ladies with GDM. So the minimum carb intake is 175 grams per day, and this is suggested to be distributed between main meals and snacks, depends on the patient lifestyles and characters. Okay, and the main issue to refer to registered dietitian to receive individualized MNT, medical nutrition therapy. We are moving to the fourth component of lifestyle therapy. All pregnant lady with diabetes should do SMBG, self-monitoring blood glucose. We go usually with fasting and postprandial. The pre-meals, if patient on intensive insulin therapy, 4 injections per day, we go with the pre-meals to match the insulin dose for each meal. Otherwise, we go with the fasting and the postprandial. The postprandial is well correlated with the maternal complication, and the 1 hour reading should be less than 140, not 120. The 2 hour less than 120. So this is the target for GDM, the fasting less than 95, the 1 hour less than 140, and 2 hour less than 120. Both for GDM and for pre-existing diabetes. Okay, so back to our case scenario. Sahar, she was diagnosed at 24 weeks to have GDM, and we started with a trial of lifestyle therapy with the gestational weight gain, with the SMBG, with the physical activity, and with diet. So the first line would be diet and physical activity, and the majority of the GDM could be controlled with lifestyle therapy alone. If targets not reached after 1 month, you would think of pharmacological therapy. Usually 1 month is too long. From the guidelines, it's stated 1 to 2 weeks. Then you will intervene with pharmacological therapy. Both insulin, metformin, and some guidelines, they stating glibenclamide, but the first line is insulin. Why is that? Because both oral agents, metformin and glibenclamide, cross placenta and associated with risk of neonatal hypoglycemia. If you would compare glibenclamide to versus insulin, those assigned to glibenclamide, they have higher risk of neonatal hypoglycemia. So the first line would be insulin therapy, which does not cross the placenta. We have received these questions a lot. A lot of ladies, they already on glargine. So the guidelines stated clearly, if patient will control in glargine, you would continue. Although the MBH and the determer, that carries the class B or category for the pregnancy, but if the patient will control in glargine, you could continue because many observational data showing no harms. Okay, this is from different guidelines. The ADA is stating that if the target's not met with lifestyle modification, you would proceed with pharmacological therapy. And the first line, insulin. Insulin is preferred. This is the ADA statement. The Endocrine Society, they mention time period. If targets not met after 1 week of lifestyle medication, you would initiate pharmacological therapy. The International Diabetes Federation also, if targets not met with lifestyle modification, you would initiate pharmacotherapy, and also they preferred insulin. The NICE guidelines, they make it in details. If targets not met within 1 to 2 weeks of lifestyle modification, you would initiate metformin. What about if the patient having readings consistent with over diabetes? What do we mean by that? For example, fasting blood sugar more than 196 milligram, okay, you wouldn't delay initiating the pharmacotherapy. So, Sahar, this is her 3rd pregnancy, was complicated by GDM, but was well controlled with diet, exercise. We review her in postpartum visit. She given a birth, healthy 3.8 kg baby girl. The baby is well, no neonatal intensive care unit admission was required. Okay, here the primary care physicians play a crucial role because this is the golden period where the gestational diabetes or lady with GDM missed. They discharge from hospitals and no one followed them. So for primary care providers, we should encourage breastfeeding. Why is that? It has a positive impact on glucose tolerance and on weight loss. Also, we should advise to do OGTT depending on non-pregnancy criteria on 6 to 12 weeks, some guidelines are 3 to 12 weeks. Depends on which guidelines you are going with. But the majority, they advise for going with oral glucose tolerance test. The NICE guidelines advising the fast plasma glucose. Why we are focusing on postpartum follow-up to do OGTT 3 to 12 weeks or 6 to 12 weeks. Why is that? Imagine, this is the HABU trial. If you remember the landmark trials, okay, this is 11-year follow-up for those who get gestational diabetes. Imagine that 1 in 2, they get either type 2 diabetes or pre-diabetes within 11-year follow-up. 1 in 2 who got gestational diabetes, they will develop either type 2 or pre-diabetes. So this is within 11 years. That's why we should screen them. Even if the OGTT is normal, we should screen them at least annually or every 3 years. And we should advise and implement intensive lifestyle therapy because they are highly to get gestational diabetes within 11 or 10 years. Okay, so we don't forget the lifestyle measures. And this is the end of my talk. Thank you very much.
Thank you very much, Dr. Saleh, for this excellent talk. Now we will take 10-minute breaks, and then we will be back 10 past 10, inshallah, to resume our program. Thank you. هذا الظاهر شو اسمه دي هذا الظاهر في بوينتر هنا وديت حق تحركي السلايد باك اند فورث هذا في ظهر فورورد وهذه باكورد ودي البوينتر الحين انا افهم هذه انت السلايد فورورد وهذه announcement. We are going to start soon because we are a little bit behind the schedule. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome back again. Now our talk will be with a well-known figure OB-GYN and obstetric دكتورة فتحية الجامعة غنية عن التعريف. Pleasure to have her here with us to share an important talk that is common we are facing in our practice, especially with the increased prevalence of obesity. We will have a nice talk, inshallah, about polycystic ovarian syndrome, how to approach in family practice setting. So let's welcome our teacher, Dr. Fathiya.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. I'm glad to be with you this morning with my student in the past and my colleague right now, and I would like to thank the organizing committee to give me this chance. So I'm going to talk about polycystic ovarian syndrome. So how I can go with it? It's not moving now. Not working, just ما حطاها. Sorry for delay. Hi. So I'm going to talk about polycystic ovarian syndrome. Still it's not working, sorry for that. This is the one, yeah. Still not working. Oh, sorry, okay. So my objective for this talk is to discuss the diagnosis of polycystic ovarian syndrome, to go in a fast way into a clinical assessment and investigation, available treatment. If I have enough time, that I might go with the long-term monitoring of women with the polycystic ovarian syndrome. It has been known also to be called hyperandrogenic anovulation and also as Steen-Leventhal syndrome. Being a syndrome, it has multiple potential etiology and also variable clinical presentation. If we go with the history, actually they started to recognize this syndrome in 1721 in Italy. And in 1844, they had to add a polycystic changes. And in 1935, they started to describe this syndrome in detail by two American gynecologists, that is Steen and Leventhal. That's why it's called by their name. It is a heterogeneous disorder affecting roughly 4 to 70 to 10% actually of women in her reproductive age group, and it is the most common endocrinopathy in women and associated with the reproductive and metabolic disorder, including type 1 diabetes, and also nowadays they are talking about cardiovascular disease. How common it is, actually, it depends upon what the criteria you are using. If you are using National Institute of Health, that is WHO, it is about 3.4 up to 10%. With the Rotterdam criteria, it is about 18% showed in one study. Now, what criteria you are using in your clinical practice? What the criteria you are using in your clinical to diagnose patients with the PCO? Notre Dame criteria. Okay, so in clinical practice, whenever we see patients with the features of obesity, hirsutism, irregular cycle, infertility, diabetes, will always diagnose her to have polycystic ovarian syndrome. Yet that is not true, because some of them are criteria for diagnosis and some of them associated factors. So not every patient who is obese with irregular cycle with infertility have PCO, but you have to keep in your mind that you have to exclude polycystic ovarian syndrome in this patient. And they reported that most women with the polycystic ovarian disease describe a poor diagnosis experience related to the long delay on the diagnosis and inadequate health information and poor educational material they receive. And this is extremely very common among our patients. The reason for that, in the past, there was no definitive clinical criteria for definition of PCO. For that reason, the international consensus workshop group, that's what they call it, Rotterdam Consensus Group in 2003, recommended that all clinicians and investigators should use the international and agreed definition of PCO to ensure uniformity in the routine clinical management and also for research purpose. So According which criteria to use, if we review very quickly the National Institute criteria, and that's recommended in 1990 by consensus workshop sponsored by so-and-so, and they suggest to diagnose patient with the PCOS, you should have all of the following features. First one, that patient have oligoamenorrhea, oligoovulation, or anovulation. Second, she should have signs of androgen excess, whether it is clinical manifested or biochemical, and you should exclude all other disease that might give you the same picture of the PCO. When we come to the Rotterdam criteria, it is in 2003, again by consensus workshop sponsored by the European and American Society of the Endocrine. And they recommended actually, if you want to diagnose PCO, you should have 2 features of the 3 out of 3, 2 or more out of 3 features. They are first the same as national, oligo or anovulation, clinical or biochemical hyperandrogenism. And the third one, they are the first group actually to incorporate the polycystic ovarian polycystic ovary as part of the criteria of the diagnosis of polycystic ovarian syndrome. Yet they have to exclude other differential diagnoses that we will go very quickly through it. Just remember, a summary report from National Institute of Health evidence-based methodological workshop on PCO in 2010, they concluded that Rotterdam criteria should be adopted because it is the most inclusive one. So we will go with the Rotterdam criteria. The first feature of PCO clinically, that's oligoovulation or anovulation manifested with the menstrual disorder in the form of oligomenorrhea, amenorrhea, and majority of the patient actually, they will start to have amenorrhea, and then they will have continuous heavy bleeding. That's what we call it hypermenorrhea. While hyperandrogenism usually manifested in the form of clinically hirsutism, acne, and androgenic alopecia, or it could be biochemical by increased androgen level in the form of testosterone, whether total or free, and increase free androgen index and slightly elevated of dehydroepiandrosterone sulfate. The most important actually, the most important clinical manifestation of hyperandrogenism is the hirsutism. So what is the significance of hirsutism? First, it is very common in PCO. It's about 65 to 70% of patient PCO have hirsutism, and it might predict actually metabolic complication associated with the PCO and failure to conceive with the infertility treatment. So it will delay pregnancy, and hirsutism often tend to be more severe in abdominally obese patients. That's what we call it trunk obesity or android type of obesity. If we come to say, what are the most common causes of anovulation? No, I will go before to the third criteria of polycystic ovarian syndrome. That is actually I have different presentation, but now they changed my presentation. I will go with it. Sorry for that. Okay. So what are the most common causes of anovulation and hyperandrogenism that it has to be excluded? First, causes of anovulation: hyperthyroidism, hyperprolactinemia, premature ovarian failure, and hypogonadotropic hypogonadism. While the most common causes of androgen excess are congenital adrenal hyperplasia, Cushing syndrome, and androgen secreting tumor, ovarian or. The third criteria of diagnosis of polycystic is the polycystic ovary. According to the Rotterdam criteria, to diagnose polycystic ovary, you should have at least one ovary that has 12 cysts that's manifested. It's actually follicle. They call it atretic follicle or immature follicle, presented in the peripheral of ovary. And in addition, that the ovarian volume will be increased up to 10 ml. So a present of peripheral cyst, 12 or more in one ovary or in both ovary, that is actually diagnostic of polycystic ovary. It's one very important point that the ultrasound finding of polycystic ovaries found in 8 to 25% of the patient without having polycystic ovarian syndrome. And they call it asymptomatic polycystic ovaries. And according to the Rotterdam Consensus Curriculum, that women having this asymptomatic PCO, it means absent of anovulation and absent of hyperandrogenism, should not be considered as having polycystic ovarian syndrome until more is known about this problem. And it's very common in clinical practice. Patient will do ultrasound and they found that she has polycystic ovary without, only with one criteria, they diagnose her and they put her on metformin and she will come, not because of the diagnosis, but she will come to you with the side effect of the metformin. She wants to change her medication. There is this criteria usually used for adult women, that is after age of 18. What about the adolescent? There are usually a little bit of a problem in diagnosing adolescent girl with the polycystic ovarian syndrome for many reasons. And ovulation is common during this period of time after menarche. This is a regular cycle, plus the ovary is rich of follicles, so it gives you a picture of polycystic ovary. And hirsutism, also you cannot assess it according to the Farman-Galway score because it's not applicable for adolescent. So nowadays they are depending mainly on a degree of hirsutism, which is presented on 60%, and they add to it anti-Mullerian hormone. They said anti-Mullerian hormone in this adolescent and even in adult, it will be increased because it reflects actually the number of follicles in the ovary. And with two criteria, hirsutism plus, you can diagnose adolescent lady, girl or lady, whatever, to have polycystic ovarian syndrome. They don't know exactly what is the etiology behind this syndrome, but many studies confirm that it is genetic, transmitted as autosomal dominant, but usually modified by environmental factor, and which is the most common is the obesity. Pathophysiology is still questionable, and they are talking mainly about insulin resistance that definitely will lead to hyperinsulinemia, and that one will act on different organ, whether in hypothalamus, pituitary, that to increase LH, will FSH, LH more, that LH itself will increase androgen production by the ovary, and also it will suppress the ovulation. It will work at the level of the ovary to decrease sex hormone binding globulin, increase free testosterone, and also it acts on the adrenal by increasing androgen production. So it will end with the status of hyperandrogenemia, that is usually it suppresses ovulation at the same time if you clinical manifestation of PCO. Now, the onset of PCO, they believe it is during the time of menarche. Yani patient with the PCO, most of the time they might manifest, but we miss it to diagnose her to have polycystic ovarian syndrome. And usually she might have delayed menarche by 14, 15. And then when she starts to have period, it is irregular. And usually she will have obesity plus hirsutism. And it might happen even before the onset of menarche by 8 to 9 years of age. Patient might be obese and have excessive hair growth. That is, later on, it might be manifested as polycystic ovarian syndrome. And some of the women never have actually signs of androgen excess. The phenotype of polycystic is very important to me because it will direct you actually to the management of your patient. So there are 4 types. Type 1, they call it classical because it has the 3 features of polycystic ovarian syndrome: irregular cycle, hirsutism, plus polycystic ovary. Type B, they have the first and second one, anovulation, and also hyperandrogenism. And that is going with the National Institute of Health because they don't have polycystic ovary as a criteria. The third, or C and D, present of polycystic ovarian syndrome, and C with hyperandrogenism, hirsutism, but regular cycle. And the fourth one, that phenotype D, that PCO, plus in addition that patient having an ovulatory cycle, but yet she doesn't have hirsutism or hyperandrogenism. There are many clinical features associated with the PCO. It might confuse us as a diagnostic criteria, such as in reproductive obesity. It is present 40 to 80%, infertility, miscarriage, increased incidence, and endometrial hyperplasia and endometrial cancer. In a metabolic, it is impaired GT, type 2 diabetes increase, gestational diabetes in a patient with the PCO when she got pregnant, dyslipidemia, and nowadays they are talking about cardiovascular disease associated with it. The importance of the obesity in the polycystic ovarian syndrome is that the risk of metabolic disorder, such as impaired GT and diabetes and dyslipidemia, it will be significantly increased in obese women with the PCO, and they believe that excess weight and obesity may have an important impact on early development of polycystic as environmental factor and on the clinical presentation. So obese women present with the PC earlier than if you are having a lean woman or normal weight woman. And the PCO is the most common obesity related to the endocrine syndrome in female. Do we need to investigate all patients with polycystic ovarian syndrome? Do we need to investigate them? We need or we don't need? According to most of the investigation we do, they suggest PCO, but they don't diagnose polycystic ovary except 2 tests important to us. The first test is actually to diagnose patient with the polycystic ovary by transabdominal ultrasound, and now be replaced by transvaginal in married women or transrectal in a single woman. So it will give you an idea about present or absent of polycystic ovaries. This is one. Second, it excludes to you, and most of the investigation, it excludes to you actually other differential diagnosis. So here it will exclude to you androgen production, ovarian tumor. At the same time, you might have chance to assess endometrium. Here, you have chance to assess the endometrial thickness, and they always say that if it is less than 7 millimeters, it indicates patient unlikely to have a problem with the cystic hyperplasia. So the other suggested routine test is the hormonal. We always do it. So what is the reason to do hormonal in the first visit? First, if she is married, you have to exclude pregnancy if she is amenorrheic. If you do FSH, sorry. If you do FSH and LH, so what is the benefit of it? They always say the BCO has LH 2-to-1 or 3-to-1 of FSH in favor of high LH. But actually it is suggestive, but not diagnostic. So the reason to do it actually to exclude other reason for amenorrhea, such as hypogonadotrophic hypogonadism, it will be 2 of them low, or premature ovarian failure, both of them will be high. If we come to thyroid function, it's important to test for thyroid because one cause of amenorrhea, hyperprolactinemia to be excluded also, if usually we do 17-hydroxyprogesterone, and the reason for that, this is not suggestive of PCO, it is normal in PCO patient, but it excludes to you congenital adrenal hyperplasia. If we come to the androgen, this is the second test important to know to assess, because patient might have biochemical hyperandrogenemia not manifested on a clinical. So you have to assess a dehydroepiandrosterone sulfate, and it is slightly elevated in patient with the PCO. Yet, if it is extremely high, 700, 800 nanogram, it is suggested of a tumor releasing androgen, whether ovarian or adrenal. And the other one, of course, you can go with the free testosterone or total testosterone, and also you will find that a free androgen index will be high. So it is actually important to exclude other differential diagnoses, and some of them it might suggest to you this is the actually associated with the PCO. We always almost miss to screen for metabolic disorder. It is being recommended not only for mature women after the age of 20, oh my God, it is actually for also women who is having for adolescent. And they do either they will go with fasting blood, they do lipid profile. This is the most common. They go with the 2-hour GTT oral. If patient cannot tolerate, you will go with this one. And this is actually the latest recommendation to screen PCO patient according whatever you want, but actually we go with the Rotterdam that they screen patient with the oral GTT if she has body mass index more than 28. So the diagnosis of metabolic disorder, you are familiar how to diagnose impaired GTT or abnormal GTT. Also nowadays, they are suggested that you have to assess patient regarding risk factor for cardiovascular, for fatty liver, suggest but not recommended, and if she has symptom of sleep apnea. Examination is mandatory during first examination to do body mass index and measurement of waist circumference if it is more than 88. This is actual diagnosis of trunk obesity, and it is more significant, and so to assess the degree of hirsutism. Treatment, which is the most important controversy in a patient with the PCO. Treatment, the aim of it to lower insulin resistance and to restoration of regular cycle, and to suppress the hyperandrogenemia, and of course, restoration of infertility in a patient who seek fertility. So most patients with this are usually diagnosed and treated by family doctor or general practitioner, unless there is a complication, you will refer her. And you are treating symptom, but you are not treating underlying cause. And you should explain to patient. So primary treatment of polycystic either, or usually lifestyle modification plus medication. If we come to the lifestyle modification, the most important or first line of therapy of this patient who is obese and overweight is weight loss. So weight loss is the recommended first. And they do recommend that high protein diet and low hypoglycemic index diet. Yet they don't recommend metformin to be used for weight loss. They don't recommend it at all. Anti-obesity drugs, they don't recommend it. Yet bariatric surgery, it can be used for a patient who is extremely overweight. What about weight loss and lifestyle therapy, the importance of it? There is no evidence that one type of diet should be right than the other. So any type of diet that the patient would like to be on it, as soon as it decrease her weight is okay, significant. The aim to decrease weight by 5 to 15%. And it will help her regarding reproductive and metabolic dysfunction, both of them, the diet. It is not recommended for hirsutism And weight loss has minimal effect on hirsutism, and if the patient has vitamin D deficiency. What about exercise? Actually, there is no large randomized trial to assess the exercise in a patient with the BCO, but in general, we always say exercise alone or exercise with the diet actually will help to decrease weight, and also it will help to decrease incidence of metabolic disorder in a patient with the BCO, in general patient, and also in a patient with the BCO. Medication. What are the most common medication we use in clinical practice for the patient with the BCO? You will say metformin plus hormonal oral contraceptive. These two main medication are important. If I start with the metformin, so metformin is insulin sensitizing agent, right? And it is benefit in metabolic disorder rather than any other disorder. Okay, so they recommend metformin in a patient with impaired GT or type 2 gestational diabetes. Yet it's not first line of medication. It should be used as for a second line if lifestyle changes did not help her to reduce her weight. Metformin for menstrual, it regulates menstrual cycle yet, but it has a limited value. So you don't use it first line. Contraceptive is the best. Metformin, hirsutism has no effect at all. Metformin, comparing with the lifestyle modification superior to the metformin in metabolic disorder, reducing the risk of metabolic disorder, or if the patient has impaired GT to progressive to the type 2 gestational, it would use. So it is not first line of therapy, metformin. Metformin compared with hormonal contraceptive pills, no doubt hormonal contraceptive pills act on reproductive and hyperandrogenism, while metformin only working in metabolic disorder. Nowadays, there are against using of metformin in many symptoms of PCO. And with the final recommendation, they said there was widespread enthusiasm in using metformin for numbers of indications of PCO, yet the clinical data show no longer support this approach. So don't use it and as first line of therapy. The second important one is hormonal contraceptive pill. No doubt, hormonal contraceptive, it will work in two, reproductive plus hyperandrogenism. So both of them, contraceptive, it will work. The reason of that contraceptive pills, it acts centrally to suppress LH or FSH. So it will suppress androgen production by ovary. It acts on the liver, and it will increase the sex hormone binding globulin, it decreases testosterone, and also it will work at the adrenal. So at the end, you are suppressing androgen at the same time, contraceptive pill at the level of endometrium, definitely it will act to regulate the cycle, at the same time regulate, prevent cystic hyperplasia and endometrial hyperplasia. You might ask yourself about the side effect of oral contraceptive comparing in a patient with the PCO. Contraceptive pill might increase insulin resistance, but actually it does not improve that. So it might worsen metabolic disorder. Contraceptive pills, it might increase weight. It might not. In PCO, it might change even a weight gain into more general rather than trunk obesity. And also, it does not have that much high risk factor regarding cardiovascular. So they do actually recommend contraceptive pill as first line of management patients with the PCO who are having two, reproductive and hyperandrogenism. Metformin, you might add it for a patient that she has metabolic disorder. Just give me 2 minutes more, I will not continue. What about using anti-androgenic medication? What are the indications to use this medication? Actually, you can use it if you start oral contraceptive pills and after 6 months, it did not give you a good response, then you can add this one. Or you have extremely hirsute patient, yet you cannot prescribe for her contraceptive pill. Either she cannot tolerate it or totally contraindicated. Here, there is role of anti-androgen to start it, either in addition of contraceptive pill or to treat hirsutism in PCO patient. Another common drugs we always use it is the progestin therapy. That is Primalotin and Profera. So what is the rule in BCO? It's actually BCO, you need it in case of emergency situation. If the patient has amenorrhea, then she continues to have a bleeding for more than a week, 10 days, and heavy, you have to stop it by progestin therapy. Yet you can use it for a patient that does not have hirsutism, but she do have a regular cycle. To regulate her cycle, every 2 months, you can give her 10 days BID Profera or Primalotin, she will have withdrawal, so you are protecting her from having cystic hyperplasia and later on endometrial cancer. And believe me, just 2 months ago, one patient called me that she is having in 26 years, nearly married, she is having endometrial carcinoma. The first contact, whether she has polycystic ovary diagnosis, she said, yes, I'm having polycystic ovary. So this is the 2 indication for treatment of therapy. No doubt for menstrual dysfunction, contraceptive pills, for hyperandrogenism, contraceptive pills, and treatment of the adolescent, more or less the same as adult. Lifestyle, if she is obese, contraceptive pills, or you might add metformin for her if she has metabolic disorder. Or contraindication you can add, but she has to be on contraceptive, but she is married, contraceptive by any means, any type of contraceptive if she is married. Because androgen effect. Associated factor, I don't know whether I have a little bit time to go. Okay, so the associated factor, infertility, Dr. Haifa already, depression, you have to assess patient. If she is obese, she might go into and having symptom of sleep apnea, blood pressure, very important. And also they suggest, but not recommend, it means a weak recommendation to do fatty liver scan for alcohol, to exclude fatty liver in a patient, obese patient with the PCO, pregnancy complication. I have actually another presentation. I will leave it with you to, if anyone interested to it. Metabolic risk factor definitely is very high. It's 5 to 10% increased risk of diabetes, of impaired GTT and diabetes mellitus in a patient with the PCO. Reproductive risk factor, endometrial cancer, no doubt, and this is easy to diagnose it by ultrasound. You can see that endometrial lining, and also you can see endometrial thickness with multiple tiny cells that might indicate polycystic cystic hyperplasia, and you can go very easy into endometrial sample. You have to assess risk factor for a patient with the PCO. This is a new recommendation or new suggestion. There is a relation between autoimmune disease and polycystic ovarian syndrome, and she might have autoimmune thyroiditis, and you have to check her thyroid, and actually part of their stroke, being at high risk of cardiovascular, she will be at high risk of stroke also. So in summary, you have to diagnose patient according to the international criteria. You have to explain to her problem, and you have to treat her presenting symptoms, whether infertility or whatever it is. And of course, sometimes you need multidisciplinary teamwork with all this specialty. So thank you. It's really big subject to talk about it, and I try to.
Thank you, Dr. Fathiya, for this excellent talk. And I would like to invite all the speakers today to the stage, please. Dr. Wada, Dr. Mona. Because we are a little bit delayed, behind the schedule. So we'll take one question for every speaker. Okay, we'll start with our audience. Any question? Yes, Dr. Ghadir.
Nowadays that we face a lot of menopausal women in our clinics. Do you recommend the contraception that we have? Do you recommend the combination of estrogen and progesterone that we have in Wasfati for our primary health care as a good choice for hormonal therapy for hot flashes or not?
Thank you very much, Dr. Ghadir, for your question. Actually, we cannot use the available oral contraception pills for the management of the vasomotor symptoms and postmenopausal because they contain a high concentration of estrogen. We can use this formula, the oral contraceptive pill, in one situation. In cases of perimenopausal symptoms or in case of transitional menopausal, when the patient still they are having their sexual activity and they still having not using any contraception. But once we use the contraception pills, it will give benefit for the symptoms of vasomotor. But for the final menopausal period, it's not recommended to use the standard oral contraception pills because of the high estrogen concentration. Thank you very much.
Any further questions from the audience? Okay, I would like to ask a few questions from the online audience. There is a question for Dr. Saleh. What are the best oral hypoglycemic agent or insulin types that can be used during pregnancy?
Okay, so we answered this in the lecture, said that the ADA, American Diabetes Association, they preferred insulin, and the International Diabetes Federation also, they preferred insulin. So insulin is the first line. It's preferred to the oral medication. The NICE guidelines, they acknowledge the use of metformin. And about the glibenclamide, we said that in studies compared to the insulin associated with higher risk of neonatal hypoglycemia. So the insulin is the preferred medication because it doesn't cross the placenta compared to the metformin and the glibenclamide. Among insulins, MBH and DTMR, they carry category B in a pregnancy. The glargines, many patients, they are using glargine or they are on glargine and they get pregnant from observational data or observational studies. It's appears to be safe, and the recommendation that if patient on glargine to continue with it.
Another questions for Dr. Saleh as well. For patients who are pre-DM before getting pregnant, are they at risk to get GDM during pregnancy or any special intervention that can be done when she gets pregnant?
Okay, excellent question. This is a controversial among the which guidelines you would implement. Okay, would you go with the ADA, which is not defining and diagnosing GDM in the first trimester, or would you go with WHO and this patient will be able to have a GDM or what's called the entity of early GDM? So this is carries a controversy among which guidelines you are following.
Mm-hmm. Thank you very much, Dr. Saleh. My questions are for Dr. Wala. You have mentioned about target blood pressure during pregnancy, and the threshold for treatment should depend on for treating with antihypertensive medication, especially in the first trimester, will depend on the level of blood pressure. So if we have a case that is known to be hypertensive and they came in the first trimester stopping their medication, however, her blood pressure is still low or sometimes on the lower side. So would you resume her medication or start her on antihypertensive medication? What do you think? How you will advise your patient?
Actually, if the patient is well controlled and she is a known case of hypertension, our decision to start her on pharmacological management depends on multiple factors. We have to put in our mind the level of her blood pressure. If it is less than 160 over 110, then we don't prefer to start her on medication. We can follow up her closely, and we have to make sure that there is no end organ dysfunction, whether renal or cardiac problem, no other comorbidities. And if the patient develops more or higher readings, then we can consider initiation of the medication. But for the first trimester, we prefer to minimize the fetal exposure to medication.
Yes, thank you. So follow-up is important for such patient, I think.
Yes.
Yeah. Yes, exactly. Thank you, Dr. Wala. A question to Dr. Haifa. For the IVF, is there any limit for age or any rule for age in the successful for IVF?
Thank you for the one who asked this question, because most of the people thinking that IVF is a magic. So you can do it at any time. And there are, this is a message also to send to our public that they are seeing a lot of cases, mainly in the celebrities, in the news, that ladies who are in their 50s or 60s, and they are getting pregnant and sometimes with twins and a beautiful outcome. But we have to understand that this is all an oocyte donation program, which we don't have over here, and it's not under the umbrella of the, it's not allowed in our countries. So usually the age is the main predictive factor for the success in IVF. As we said, as the patient is getting more than 35, her fertility decline, her success rate is declined. And there are a lot of people, they are thinking that the success with IVF is really very high, even a very young age group. We know that the success rate cannot be more than 30 to 35%, hoping that if she is having a previous pregnancy can be up to 40, but it's never reaching higher than that. At the age of 40, we know that the success rate will never be more than 5 to 10%. At the age of 45, somebody was asking me just now, at the age of 45, can we do an IVF? Actually, this one needs an extensive counseling to the patients, because we know that we do have a late marriages. Patients cannot get pregnant at the time she wishes. She has to get married first and then to start her family. At the age of 45, we have to understand that the success rate will be less than 2%. We cannot say zero because there is nothing called zero, but it is less than 2%. So it's really very low success rate. And most of the patients who are more than that, sometimes, believe me, we advise them not to go for the cycle and to try spontaneously, because their chances of getting pregnant maybe spontaneously is maybe higher than the success rate of the IVF or equivalent. So the chances of pregnancy per se above 40 is very low, and that's the key of counseling the patients. And this is very important also for the patients who are having recurrent implantation failure. Before they were saying just 5 trials above the age of 40 is fine, and now most of the recommendation is go to more and more trials if the patient is keen for that, and if her all presentation is allowing that, because it was found that as you are doing more cases, you increase your chances of success, knowingly that we have a very limited success rate.
Yeah, thank you, Dr. Haifa. I think this is an important issue to be discussed with the couples for such a procedure. Last questions for Dr. Fathiya. You have mentioned clearly about adolescent with PCO that we cannot rely on the ultrasound at this age before the 18. So if you encounter a mother who came with the ultrasound report shows a polycystic ovary and thick endometrial lining of a 10 millimeter, as well as she's having anovulation, she's obese, but without hirsutism, how you will approach such patient and how you will advise her?
So here you can say that she has two criteria for adult to diagnose her. That's an ovulation or irregular cycle plus possibility of polycystic ovarian syndrome. I guess you have to go and more detail in the history of irregular cycle, whether she was obese before the onset of menarche, here you don't have hirsutism. Obese, there is delay in the onset of menarche that it gives you even more in obese women with the delay in menarche. And now she is having a regular cycle, not only for the first 3 years of after menarche, but it might continue after that. It still continue to have a regular cycle. I guess here you can do anti-Mullerian and hormones, and if it is high, above normal, or it is high increase, it gives you more evidence that this patient is actually having, let us say, phenotype D of polycystic ovary, and you have to treat her regarding regulation of the cycle, not to regulate the cycle per se, but actually to prevent cystic hyperplasia, which can be happened even in prolonged period of an ovulation. In addition, of course, that you have to screen her for metabolic disorder, because still there is the chance to have impaired GT in this age group reach to 18%. So screen her for possibility of metabolic disorder, anti-Mullerian hormone, good history, it might give you at the end, really, this is a case of PCO and has to be treated to prevent the other phenomena of PCO.
Yes, thank you very much, Dr. Fathia. I hope we have more time to have an answer from our experts. But unfortunately, we are already behind the schedule. So I would like to thank all the speakers. We enjoyed really this morning. It was very, it has too many learning points actually from each speaker. Thank you very much. I would like to invite Dr. Saleh to moderate the next session, please.
Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum jamiyaan. So my talk will be briefly about tailoring insulin therapy for people with type 2 diabetes. When you go to the tailor, you want to get thobe not too long, not too short. And this applies to you as a primary care provider. You want to tailor the insulin therapy for your patient, not too much or not too little. Okay, I'm talking on behalf of Lily, and this is my disclosure. We will have two cases. One case about the idea of initiating basal insulin. This is a typical patient seen in primary care settings, middle age, with 2 or 3 oral medication maximum doses, sulfonylurea, metformin, and sitagliptin, and he's having what's called catabolic symptoms. He's having polyuria and polydipsia and unintentional weight loss, and this is his SMBG. Okay, so how would you approach this patient? Okay, he's having both fasting hyperglycemia, preprandial hyperglycemia, and postprandial hyperglycemia. Remember that he's having catabolic symptoms. So the best thing to initiate in patient who's having catabolic symptoms and intentional weight loss, polyuria, polydipsia, is insulin. And usually the recommendation to go with basal insulin first. So you would add Basaglar insulin once daily. And this is comparing the basal insulin analogs, the determer glargine and biosimilar glargine, Basaglar. What's biosimilar or called follow-on biologic agent? It's the same amino acid sequence to the glargine, the reference product, but the manufacturing process is different. It's only differs in the manufacturing process. Similar efficacy, similar safety profile, and same dosing between Basaglar and the reference product Lantus. That's why in 2015, the FDA approved the Basaglar as a follow-on biologic agent to be used in people with type 2 and type 1. This is how it looks, the Basaglar insulin. What's the dose? Either you go with the 10 units or you go weight-based dose, 0.1 to 0.2 units. Okay, and how would you monitor your patient? Every 3 days, you are measuring both fasting blood sugar and bedtime. And you go 2 units every 3 days. Who would go 2 units? Is it the patient or the physicians? Okay, usually we said that patient can safely and effectively self-titrate basal insulin. Okay, and this is shown by one of the study published in Diabetes Care that if you would compare the incidence of hypoglycemia between those who assigned to self-titrated or physician titration of the insulins, no much difference among the incidence of hypoglycemia, and also the same applies for the A1C reduction. So always we go with self-titration. So we equip our patient to self-titrate and we give them the algorithm to self-titrate at home. We don't wait the next appointment after 3 months or 6 months to increase the doses for our patients. And we give them a limit when to stop titrating the insulin doses. Okay, so patients started 10 units and titrated the Basaglar every 3 days. And the catabolic symptoms improved and his A1C reduced to 7% after 3 months on 30 units of insulin Basaglar. Would you stop the other oral medication? Only if hypoglycemia occur, you might decrease or discontinue sulfonylurea. Moving to the second case scenario, the first case was about starting basal insulin. So this patient already on basal insulin and his A1C dropped from 11. Okay, this patient, he was already in basal insulin when the A1C was 11 and titrated to 50 units, but the A1C is still remaining high, 8%. What does it mean? It means that there is postprandial hyperglycemia. So although we achieve the fasting blood sugar, but the A1C is still elevated. What does it mean? It means that patient is still running postprandial, and basal insulin has nothing to do with postprandial. It's only suppressing the hepatic glucose production during fasting and interprandial state. What does it mean? That no point of escalating the basal insulin dose aiming to control postprandial hyperglycemia. You have to interfere. And this is from one study that usually patients started basal insulin, the A1C dropped to 7.8, 7.5 or 8, less than 8%. How long it does take us as a physicians to intervene or to intensify the basal insulin regimen? If you would see here to this busy table, the insulin patient already in insulin, it takes average 4.9 to 4.2. Okay, so almost average 5 years it took us to intensify the basal insulin. This is what's called therapeutic inertia. So would you stop basal insulin if the fasting blood sugar achieved? Although the A1C is not achieved, you would stop titrating basal insulin and you will look for intensifying. And we said that if the A1C in the lower margin, that means that patient running postprandial hyperglycemia. The main component for the A1C less than 7.3 or less than 8 is the postprandial hyperglycemia, and basal insulin has nothing to do with postprandial hyperglycemia. What you will do? Would you add the oral medications, fourth oral medications, not recommended. Either you go with the GLP-1 or basal bolus insulin. Depends on your patient's individual characters. Or you could switch to premix insulin. This is depends on the patient's individual characters and needs. If you choose to go with basal bolus, usually we go with basal plus, choosing the largest meal with the blood sugar, postprandial blood sugar, then you build on basal bolus. What's the difference between the 3 rapid-acting insulin, the Lispro, Humalog, or the Glucosamine, or the Aspart? All are similar. So about the use of insulin, insulin bin is still, it's not without any limitation. There is a limitation for the bins, and this is a study comparing different types of bin, quick bin compared to the SoloStar or the Flex bin, and the patients, the majority of them, they prefer the quick bin because they found it easy to inject, and this is how it looks like. Okay, so usually we go with either 3 to 4 units or 10% of the basal dose. Okay, this is the, or we have what's called the 90-10 rules. Patient, for example, in 50 units, if the A1C less than 8%, you reduce 10% from the basal, which is 5 units, and you add it to the largest meal. The largest meals, the meal with the highest blood sugar, postprandial. Okay, this is the time you would discontinue sulfonylurea. Whenever you go more than 1 injection, this is the time to discontinue sulfonylurea. And this algorithm showing clearly the patient on more than 1 injection, the only one to be kept, metformin and the SGLT2 inhibitor. So it depends whether you would keep the same basal insulin, depends on the A1C below 8 or above 8. And you would go with the 90-10 rules. So this patient was started on Lispro 4 units, still the blood sugar is uncontrolled, you would proceed to basal bolus. So the take-home message, type 2 is progressive disease. Please avoid therapeutic inertia. Don't say that the patient's A1C is 7.8. Okay, just go and do a little exercise, do further. We should reinforce lifestyle therapy, but we shouldn't delay like the studies we show that 3 to 4 years to intensify and to take action. So the disease is a progressive and treatment regimen should be re-evaluated and intensification shouldn't be delayed. This is the end of my talk. Thank you.
السلام عليكم. Thank you دكتور صالح. الحين حنبدأ الجلسة الحوارية. الجلسة الحوارية بعنوان Effective Team Based. We invited a real team اشتغلوا مع بعض. طبعا مع الترانسفورميشن تغيروا الناس في أماكن مختلفة ولكن جمعهم هيستوري واحد. وجمعناهم احنا اليوم with their patients برضو الاكسبيرينس حقتها. وفكرة السيشن حنبدأ بعرض اللي هي المقطع من البيشنت فيدباك على شغل التيم. Then afterward we will see التيم بيكون موجود هنا قدامكم في الجلسة and we will discuss about this patient, other patients and نتمنى صراحة الأسئلة تكون من الجمهور في القاعة وأيضا من الجمهور أونلاين at any time. إحنا يعني الجلسة هذه يعني ودي تكون exchange experience most of the time. وحنطرح أسئلتنا إن شاء الله على الفريق ونشوف يعني إيش recommendation ممكن نطلع منها خلال هذه الجلسة. I would like to invite دكتورة منى الشيخ consultant family medicine at Al Athir PHC. She was working in Al Azizia before that and in Faisaliya primary healthcare. Also, I'd like to invite Miss Maryam Al Nasser, a pharmacist. She's currently working in Babtain. Before that, she was in the Dammam PHC. And I'd like to invite a health coach, Ayat Al Abedi. She's a nursing specialist at Al Faisaliya primary healthcare. She's a health coach, representative in Dammam sector. Thank you. حياكم الله، يعطيكم العافية for accepting our invitation. مصطفى إذا ممكن تشغل لنا الفيديو for the patient. مين اللي شغل لنا الفويس؟ في فترة من الفترات انتوا اشتغلتوا مع بعض صح؟ دكتورة ولا اشتغلتي أول مع آيات، بعدها مع مريم، واشتغلتوا في التيم بيز ولا اشتغلتوا يعني اجتهادا؟ على ما يشغلنا الفيديو بس اعطينا.
يعطيك العافيه دكتوره ندى. طبعا يمكن هذا البانل توداي يعني او الحديث راح يكون نقلا عن our own experience، يعني كنا نشتغل as a team حتى قبل ما نبدد او implement التيم based care في المراكز الصحيه. يمكن بدايه كان اول دفعه تخرجت من الهيلث كود كانت آيات من الدفعه الاولى اللي تخرجت، ففعلا لمسنا كانت إضافة جدا جميلة لما جات عندنا في المركز الصحي. في البداية جلسنا أنا معاها على أساس أنه نعرف كل واحد منا إيش الرول، إيش الحالات اللي إحنا راح نتعاون مع بعض في علاجها، هل هي جميع الحالات، بعض الحالات، إيش السكوب حق الهيلث كوتش اللي كان deal with patient، هل هم only مثلا for lifestyle modification السمنة أو لا مثلا في علاج uncontrolled diabetes. فكان جدا جميل إن إحنا أول جلسة لنا حطينا السكوب والرول for each of us. أنا كدكتورة إيش هي تتوقع مني إني أنا إيش الحالات اللي راح أحول لها، إيش الحالات اللي أنا ممكن I need her help معاي تكون في الخطة العلاجية. بعدها هي باشرت وعطتني إيش الأشياء اللي هم تقدر تساعدني فيها. فكانت إضافة جدا جميلة، اختصرنا العديد من يعني الفاسيليتيز أو خلينا نقول الريسورسز اللي كنا ما احنا عارفين كيف نستخدمها. قللت علينا كثير من الجهد والوقت مع المريض. يعني بعض المرضى أنا كنت أخذ معاهم مثلا خلينا نقول الكونسلتيشن 15 دقيقة، بعدين أجلس معاهم for الكونسلينج أكثر من 15 دقيقة just for simple counseling for obesity or smoking cessation. فلما صار التعاون ما بيني وبينها قلل الجهد، قلل الوقت. البيشنت ساتسفاكشن كان جدا جميل لما ناخذ الفيدباك من البيشنت وينقل لنا هذه التجربة، فكانت إضافة جدا جميلة.
والبيشنت اللي حنعرضها الآن يمكن كانت معكم ولا كانت في المركز؟ كانت مع
مريم. ممكن تقول لنا مريم أكثر عنها على ما يشتغل؟
هذه المريضة طبعا بنقول لكم تجربتي معاها. جات لنا المركز الصحي، كانت تعاني من يعني ضعف عام بالجسم، آلام بالعضلات، يعني شفتي تعبانة. فراحت عند الطبيب الدكتور هناك أخذ لها اللي هو التحاليل.
عليكم، أنا مريضة.
لحظة شوي كملي.
فبعد ما سوت لها اللي هو الانفستيجيشن وطلعت اللي هو اللاب تيست تبعها، عرفنا أن عندها اللي هو ارتفاع في إنزيمات الكبد. ففي ذاك الوقت عشان له نختصر الوقت الدكتور سوى لها ريفيرال حق اللي هو الصيدلية، روحي حق الصيدلية عشان نتابع العلاجات وتعطيك اللي هو كونسلنج على علاجاتها. وصلت عندنا للصيدلية، طلبنا منها تجيب العلاجاتها اللي الحين هي تستخدمها، فدخل الصيدلية مع كيستين كبار. كيستين يعني
مريم، خلينا نسمعها بما ان انت يعني قاعده تقولين نفس القصه، خلينا نسمعها ايش رايكم. وشغل يا مصطفى اذا ممكن تشغل.
السلام عليكم. انا مريضه، رحت المستوصف الصحي وكنت اعاني من الام العضلات، وللدكتور شكيت له ما في وقلت له انا عندي الام في العضلات. قال لي، وقلت له انا عندي ضغط وسكر وكوليسترول. بعدين قال لي سوي تحاليل وطلع عندي الانزيمات في الكبد مرتفعه، وقال لي جيبي ادويتك وروحي روحي للصيدلي. رحت للصيدلي قال لي وين ادويتك؟ قلت له هذا ادويتي. شافهم قال لي جيب الادويه حتى الفيتامينات اللي عندك جيبيهم. جبتهم وهي علبه الادويه المنظمه. فبعض الادويه تكون نفس الالوان يعني ما اتغلطت فيهم. فقال لي الادويه دي تاخذينها الكثر ودي تاخذينها الكثر، وقاموا ينظموا لي هو ويا الدكتور، قاموا يتصلون علي ويطمنون. والحمد لله يعني الحين صرت زينه علشان تابعوني الصيدلي ويا الدكتور. الله يعطيهم العافيه.
يعطيكم العافيه. هذه القصه مريم انت ومعك طبيب ولا مع دكتوره منى؟
كان معي طبيب. كيف نفس ما قالت اللي هو تقريبا قصتها المريضة، يعني هي كانت بولي فارماسي المريضة. كانت طريقة توزيع حق العلاجات بما أن هي تستلم العلاجات عن طريق وصفتي، على طول تجيها اللي هو الباكت حق الشركات مختلفة، تشيلهم من مكانها، تشيلهم من العلبة نفسها عشان توزعهم يصير عليها أسهل الموضوع. فشفت إنه عادة كانت توزعهم مو لأنها عارفة الاسم، هي كانت توزعهم لأن الشكل واللون. بعد طبعا المتابعة شفنا أن مثلا عندها 4 علاجات لونهم مثلا وردي، حطتهم مع بعض على أنهم دواء كوليسترول. فاللي فهمنا منها يعني بعد ما شفنا علاجاتها أن كانت تستخدم 3 شركات مختلفة من الروزوفاستاتين، بالإضافة على أنهم فبريت معاهم حطتهم في نفس المكان تبلعهم يوميا. عرفنا الحين السبب الإيرور من وين؟ من ستاتنز. طبعا على طول اللي هو الصيدلي سوى كوميونيكيت مع اللي هو الدكتور أباط يعني البروبلم حق هذا المريض، ان الريزون اباوت اللي هو ارتفاع انزيمات الكبد عنده عن طريق العلاجات ميديكيشن حقته.
طيب مريم، كان تكون التيم عندكم في المركز في هذيك الفتره ولا؟
نفس ما قالت الدكتوره منى، يعني كان التيم بيفور يعني امبلمنت. احنا كنا يعني مثل الفريق الواحد حتى من قبل ان احنا يعني ما نبدأ، يعني بدأنا احنا من نفسنا.
نشوف إذا في أي أسئلة من عندكم قصة البيشنت. كم عمرها؟
تقريبا 55 سنة. أو طبعا لو educated، ما تعرف تقرأ إنجليزي، ما تعرف يعني علاجاتها هذا حق إيش. هي تعرف إن عندها ضغط، عندها سكر، عندها كوليسترول، بس ما تعرف بالضبط إنه والله أقرأ شنو في علبة هذا اسم العلاج شنو. ما هي بعارفة هذا الموضوع. فالإيرور يحصل كل يوم، يحصل وراح يحصل حتى مستقبلا. فعشان نمنع هذا يعني الموضوع لازم يكون في صيدلي، يعني ما في أحسن من الصيدلي إنه يعرف في العلاجات. دائما أتوقع أن أغلب الدكاترة فيس إن كل يوم يجيهم مريض جايب لهم علبة فاضية ممكن خلطهم 5 أو 6 علاجات مع بعض بس بدون اسم حتى عليها. تقريبا هذا تشوفون بشكل يومي. صحيح؟
صحيح. طيب مريم، الحين كنتوا أول قلتي لي في الفريق بدون يعني اجتهادا منكم، الآن بعد ما صار في تيم بيز من وزارة وكذا، شو اختلف عليك؟
طبعا للأسف الحين في البرايمري هيلث كير تقريبا الرول اوف فارماسيست دمج، يعني مو موجود. فعشان نرجعه شفتي نفس ما قلت لك انه في احتياج، يعني كثير مرضى بوليفارماسي، كثير مرضى non adherence، كثير مرضى non control. So they need يعني إن في أحد يسوي لهم مونيتورينج. هذا المونيتورينج هو راح يكون سيف تايم حق اللي هو وقت الدكتور. نفس الوقت لو يعني راح يحتاج أي assessment أو نيو assessment، نفسه هو الصيدلي راح يلاحظ هذا الشيء وراح يسوي له ريفيرال مرة ثانية حق اللي هو الدكتور عشان يتابع الموضوع بشكل مفصل أكثر.
اوكي دكتورة منى، what do you think؟ يعني انت الان شغاله في تيم بيز صح؟
صحيح.
لكن ما في فارماسيست.
صحيح. طبعا التيم بيز ما يعتمد على فقط دكتور، الفارماسيست، الهيلث كوتش. هو مفروض انه فريق متكامل ابتداء من موظف الاستقبال في المركز الصحي، النيرسز، الاداريين، الفارماسيست، الهيلث كوتش، الدايتيشن. واحنا هذا اللي نطمح له، انه يكون في تيم، في اعضاء معينين، كل عضو يكون فيه له رول معين. طبعا اللي اختلف علينا يمكن وجود هذه الأعضاء والتعريف بدور كل عضو من أعضاء الفريق. الشيء الثاني من الأشياء المهمة أنه يكون في باثوي للمريض، يعني المريض عارف أنه هو بمجرد يدخل المركز هو وين حيتجه، لأنه هو تبع الفريق مثلا دكتورة منى أو تبع الفريق A أو تبع الفريق B، فيكون في خطة واضحة للمريض يعرف أنه هو مين حيروح له.
بس هذه موجودة حاليا صح؟
هذا الحين بدأت تطبق بعد ما implement من الوزارة التيم.
طيب ولا أنت كتيم كم صار لك في التيم؟
الحين مو فترة طويلة to be honest، يعني تقريبا 3 to 4 months.
4 months؟
Yes, almost.
طيب هل احتجتي فيها فارماسيست في هذا الوقت؟
خلالها yes a lot بعد مو بس شوي.
تواصلتي مع مريم؟
تواصلت مع مريم من كنت في العزيزية. يس الحين من هي راحت البابطين شوية التواصل يمكن قل، لكن نحتاج فعلا يعني الأشياء الثانية اللي إحنا الحين قاعدين نحرص عليها، إن إحنا أول شيء التريننج حق all members اللي يكونون في التيم بيز. يعني أنا كدكتور عارف إيش الأشياء اللي علي، لكن كهيلث كوتش كفارماسيست they have to be trained trained على فكرة التيم بيز. الشيء الآخر بعد اللي هو الديليجيشن، يعني مفروض يكون عندهم بريفيليج وصلاحيات. يعني بكرة أنا لما أقول مثلا أحول patient for smoking cessation وبعد ما أنا قررت I discuss مثلا الحالة مع الهيلث كوتش، مفروض الريفيل ميديكيشن ما يحتاج البيشنت يرجع لي، تكون عندها صلاحيات، أو عند الفارماسيست مثلا يكون عنده صلاحيات تريفيل الميديكيشن.
طيب واقعيا معلش واقعيا انت يعني تتكلمين عليه حاجه موديل
يس يعني ان هذه الايديال او البنش ماركينج.
واقعيا صراحه
واقعيا لا ما هو موجود، وهذا اللي نحتاجه.
من اللي موجود حتى طالما نتكون تيم بيس، من اللي موجود من الوضع الحالي يعني كيف ممكن نوصل للايديال حتى لو نقطه واحده toward الايديال بالنسبه يعني
البريفيليج training and the privilege for all members of the team based health primary.
هذا doable.
Yes, doable, easy doable.
What do you think آيات؟
يعطيكم العافية. أأكد على كلام دكتورة منى، لو كان في بريفيليج أكيد بيفرق في الكير حق البيشنت، بحيث إن إحنا نقلل الوقت اللي هو يحتاج إنه يقضيه في المركز الصحي أو في المتابعة، بالذات في الريفل، إنه أحياناً ممكن إنه يحتاج إنه يمر على عيادتين. فهذا يعني هذا شيء ممكن إنه يقلل الساتسفاكشن اوف كلاينت، إن أنا على كل زيارة لازم أمر على عيادتين. actually I have a case presentation ممكن يوضح لنا شوي نقطة تشبه اللي ذكرتها دكتورة منى.
أنا كنت بقول لك from التعليق اللي أنت ذكرتيه I think إن ذكرتي لنا قصة patient كان عند السموكينج والويت مانجمنت، وقلتي إنه you find a way في التعاون مع الطبيب اللي موجود معك الآن بالمركز يعني سبورت هذا البيشنت لحد ما كوت. مضبوط
بالضبط. برغم ان هذا الكيس يعني كانت قبل لا يتكون التيم بيس، بس لكن كان يعني بشكل اساسي ان احنا نشتغل كفريق زي ما ذكرت الدكتوره منى. يعني فور سموكينج سيسيشن غالبا هو التريتمنت يتكون من جزئين، الميديكيشن والبيهافير، والجلسه الاولى غالبا تاخذ وقت جدا طويل، احيانا يكون من 30 الى 45 دقيقه، واحيانا ممكن تمتد الى ساعه اذا كان البيهافير تشينج يحتاج وقت اطول. فبالنسبة للكيس مثلا اللي حضرته اليوم 37 years old male سعودي، كان مدخن لمدة 14 سنة، يستخدم التمباك 6 to 7 pieces per day، فهو يعتبر heavily smoker، وكان في نفس الوقت عنده challenge في الويت مانجمنت. فبالنسبة له كانت زيارته الأولى إلى الطبيب، كانوا فيها حددوا فيها الهدف إنهم راح يشتغلوا في البداية على السموكينج سيسيشن، وبعدين راح ننتقل للويت مانجمنت، بما أن السموكينج سيسيشن يعتبر تشالنج صعب بما فيه الكفاية في البداية. فبعد ما الكلاينت تتعرف على البروسيس وشنو الاشياء الاساسيه اللي يحتاجها من ميديكيشن وبيهيفير، كان اتفق مع الطبيب انهم يستخدموا الباتشز، بما انه يعني حتى الكلاينت يعتبر one member of our team. بالنسبه لهذا الكلاينت كان ميديكال فري، فكان عنده حريه الاختيار الميديكيشن اللي يحس انه مناسب واللي يقدر يلتزم فيه اكثر. فبعد ما فهم ايش العلاج اللي ممكن انه يستخدمه ومتى يبدا فيه وطريقه الاستخدام، بعدها انتقل الى الهيلث كوتش عشان نتناقش عن البيهافير تشينج، شنو التشالنجز اللي عنده، السترينث، الويكنسز، الباست اكسبيرينس. فكانت هذه تقريبا الجلسه الاولى، وبعدها كان في 2 more follow up with the client. كان يعني قدر يقطع من البدايه، كانت اموره جدا كويسه، ملتزم على العلاج. بس تقريبا على الشهر الثاني كان عنده من جديد تشالنج. كان بالنسبه له كان في صعوبة في بعض الأحيان مقاومة رغبة التدخين، بالذات لما يكون حوالي مدخنين كثير في العمل وما يقدر يتجنب هذا الشيء. فكان جدا مهم نفس الشيء ان احنا نشتغل as a team base ونرجع الى الطبيب مرة ثانية، شنو ممكن الشيء الاضافي اللي ممكن احنا نقدمه، هل هو علاج دوائي، هل هو علاج سلوكي، ونتناقش في الحالة. فبعدها تقرر ان احنا نقدر نضيف again اللوزنج وينوصف عن طريق الطبيب، وايضا نعزز البيهافير ثيرابي عشان كيف ممكن انه يقاوم رغبة التدخين again. زين، واستمرنا تقريبا على هذا المنوال 3 شهور لين ما المراجع قدر انه يبطل تدخين. يعني خلال عدة جلسات لازم نرجع للطبيب مرة ثانية ونتناقش، هل احنا نقلل الدوز حاليا من الباتشز، هل نحتاج ان احنا نضيف شيء جديد، او هل هذا كافي بناء على البروجرس للكلاينت.
ونجحت صح التجربة
نجحت.
هذه؟ ايش الاشياء اللي خلتها تنجح؟
الأشياء اللي خلتها تنجح إنه كان في easy communication بين المراجع بين الدكتور، كان easy access، أقدر أنا أي وقت إن أنا أتناقش مع الطبيب بخصوص هذه الحالة، availability of medication، الكلاينت إنه كان متعاون، كان سلس، ما عنده مشاكل، كان يمر على عيادتين.
في فاكتورز من البيشنت وفاكتورز برضو من التيم يعني.
أكيد.
يمكن الكوميونيكيشن أكثر شيء نقدر نقول. التواصل اللي بينكم،
الكوميونيكيشن اكيد هو اللي سهل البروسس كلها. فرق لو انا اقول له لازم تحجز موعد هنا ولازم تحجز موعد هنا وانا ابهدله، فهي كانت البروسس ماشيه يعني قدر الامكان انها تكون في نفس الزياره، ان احنا نخلص كل شيء يحتاجه بحيث ما تتكرر الزيارات على متى يكون موعد متوفر هنا او موعد متوفر هنا. هو ينتقل من عياده الى اخرى في نفس اليوم، وقدر الامكان ان نحد من وقت الانتظار علشان رضا المراجع.
دكتورة إيمان.
Yes, thank you, and congratulate you for such successful stories among your collaborative team-based care. My question is about time. Time is a resources. Do you have allocated time to sit and with your team to discuss the cases, protected allocated time during the day?
حاليا احنا في الفيصلية نفس الشيء، نشتغل على تيم بيست كير. فهو واقعيا يعني بالنسبة لنا ما حددنا وقت معين، هو يعتمد على الكيسز نفسها، إن متى نحتاج إن احنا نرجع وديسكشن. يعني بالنسبة لي مثلا as a health coach في الفيصلية احنا عندنا 2 تيم، بس بما أن في health coach واحد فأنا واقعيا أغطي 2 teams. فعليا ارجع لهم يعني الوقت اللي انا احس انه محتاجه ارجع لهم، ان اعطيهم ريبورت الى الكيس، شنو الشيء اللي احنا حققناها، شنو الاشياء اللي فيها اوبستكلز، متى مثلا نحتاج ان احنا نعيد التحاليل او نغير الميديكيشن او هكذا
فقط، ولا في حاجه دوكيومنتد او شيء يعني، ولا يعني اذا ما في allocated time انت تقولين احنا التواصل هو اهم عامل يعني.
صحيح. إلى الآن يعني صراحة إحنا ما حددنا وقت معين، لكن أنا أرجع لهم باستمرار، ويعني أحاول أن أضيف النوت حقنا يعني هذا البلان أو هذا الشيء، مثلا كالميديكيشن إن إحنا رجعنا فيه إلى الطبيب وناقشناه.
إذا في بس دقيقة بس عشان دكتورة إيمان، يعطيك العافية دكتورة إيمان for your question. I think the allocated time it's يعني one of the key factors for an effective team based لأنه هو يحتاج أصلا ما بين فترة وفترة إنه يكون في خلينا نقول زي السايكل المتابعة الدورية. أنا أعرف أنا لازم يكون عندي outcomes في هذا التيم، هل فعلا أنا حققتها؟ هل الاوتكمز اللي انا كنت اطمح لها من البدايه لما حطيت الباثويز did I reach my successful criteria or not؟
بس هذا مو موجود دكتور،
هذا مو موجود
ولا
yes.
موجود في نظام التيم بيز الى الان؟
لا still until now يعني هذه كلها اجتهادات من كل مركز او من كل تيم على حسب الريسورسز اللي موجوده. هل في وقت ان احنا نجتمع؟ طبعا انا الاجتماع ما يقتصر على فقط عضوين او 3 اعضاء، مفروض انه يكون الفريق بشكل متكامل، كل واحد يقول عن الانجازات الاوبستكلز اللي واجهها، يعني يصير اوديتنج بشكل دوري على اساس يكون فعلا effective team based ويعطي الاوتكمز المرجوه. صحيح عشان كذا يمكن دكتورة أنا قلت من البداية الباث واي مهم جدا for the patient satisfaction، يعني بعد إنه البيشنت يدخل ويضيع أحد يقول له روح مر على الهيلث كوتش أول بعدين عند الطبيب أو المفروض يكون في باث واي واضح. وهذه حتى ممكن نسويها for each يعني مثلا الكرونيك ديزيز as الهايبرتنشن إيش الباث واي الدايابيتك وبناء عليه.
My name is Ibtisam Baissa. I'm consultant internist and endocrinologist and the director of diabetes, former director of diabetes center, Dammam Medical Complex for the past 17 years. I would like first of all to congratulate you really for the effort and the work that you have done, and also on the comment of the first presentation that has been presented. Actually, the primary healthcare place to look after a patient with chronic diseases to avoid the duplication of treatment. And I always encourage patients to bring all their medication with them to the physician when they come to the clinic. And this is what I used to do and encourage all physicians to do before you refill, adjust, or add any to the patient, all patient treatment. Because what happens, many patients, they go into like clinic shopping. They go from one clinic to another, or even in the same hospital, like in our hospital, you go from diabetes clinic to renal clinic to cardiology clinic. And because the doctor is busy, they keep adding medication without looking what medication the patient is on. And we end with patients like what have been in the first patient, hypertension treatment, different drugs from the same class, but different brands, and the patient is taking the same class. And I have seen it in my practice several times, actually. Hypertension treatment, ACE inhibitor, patient taking 2 or 3 from the same class. So thank you very much. And this is what I do really encourage, that all physicians review the medication with the patient before you do any adjustment. Thank you very much. Yes, diabetes center in the Dammam Medical Complex, and I was the director for 17 years. Now I'm retired from Ministry of Health. Actually, if you are going to discuss this, this is really a real important issue. And it's really a very challenging issue, سواء في مراكز السكر أو مراكز الرعاية الأولية.
كم يعطونكم وقت دكتورة؟
We don't have 10 minutes and sometimes 15 minutes, which is really you cannot do anything. And that is one of the reasons that probably we don't give the proper care for the patients. It's new patients and follow up 10 to 15 minutes.
يعني الدايابيتك سنتر 10 to 15 minutes والمركز الصحي 10 to 15 minutes ولسه البيشنت يعني يحتاج I think وقت أطول من medication.
Of course. I mean, the minimum, this is what I recommend. The minimum is like 30 minutes, 20 to 30 minutes for any follow-up patient. This is the minimum. This is the minimum. Some patients may require more, some patients may require less based on their education. And also we have to consider, this is what we do usually, is we benchmark our timing with international or whatever. We cannot do that as well, because the burden of the disease in the Kingdom of Saudi Arabia is really high. And we have a lot of number of patients. When we have limited centers and we have primary healthcare, we are lucky now that we are expanding and we have more professionals in the primary healthcare. But when I used to direct the center, most of the patient wants to be followed in the diabetes center. And really, we had, before I leave, we had the follow-up appointment up to 6 months, sometimes 1 year. Some patients might not be seen even up to 1 year or more. So the time is really quite challenging. So 15 minutes, I don't think it's really appropriate, especially if you don't have all the facilities, like the food care, because you have to do the annual checkup, like the food care, you have to follow the patients, educate the patients. So these are, it will take time. So in order to get over this, this is what we did in the diabetes center, is we developed a food care unit. So in the clinic, I cannot do all the tests. So this is the idea. That's why I congratulate you. So if one person will do the food assessment, one person will do the education, one person will review the medication. So that will save time for the physician to concentrate on other things.
والكوست برضه الكوست
Definitely. So thank you.
اسمحي لي دكتور بس آخر سؤال ناخذ دكتور.
Thank you so much. My name is Amani. I'm the manager of medication safety and quality management in Eastern Health Cluster. With regards to the role of pharmacists in this chain, actually, I am disagreeing with Ms. Mariam because it's not vanished. Nowadays, we are more focused on the major role of pharmacists to make more time to counsel the patient, and there is the availability of virtual clinics that can be a part of your chain, because I believe that كل شبكة لها أو كل مراكز صحية تتبع شبكة، والمراكز الصحية هذه مش مع الشبكة هناك أكثر من 10 أو إلى 15 virtual clinic by pharmacists for that role. So I think we need to just start to clarify the pathway and make this virtual clinic as a part of this pathway, and this will close the loop and the role of pharmacists will be there.
بس هذا موجود حاليا؟
موجود حاليا. You just need communication and like a very يعني
موجود في المراكز الصحية
موجود هو موجود تبع الشبكة. So you just need to meet مثلا المسؤول عن ال virtual clinics and how you can implement it، لأنه هو عائد على يعني مصلحة الشبكة ككل، سواء من مستشفيات if you need to refer a certain patient with a number of medication or certain cases. And I think بهذه الطريقة احنا نقدر نواكب العصر وما يحتاجه. Time consuming because even the pharmacist who's covering that, they are not like solely doing that, they are doing other jobs and beside this, but I think this has to be considered. وهو المغزى من إن الصيدليات تغلق. This is with the Vision 2030, like what's been doing in the West, in the West, but in the same time, the role of pharmacist is there to focus more about what he needs to provide beside dispensing. Thank you.
Thank you. يعطيكم العافية. So we will conclude our setting هذه. بس نبي نأكد على الرول الأساسي للتيم بيز. أغلب الريكومنديشن الآن ذكروها، يعني enhance الكوميونيكيشن. حاول نبدأ بالشيء الموجود عندنا just to achieve communicate more. يعني المعلومة اللي أعطتني إياها دكتورة يعني really valid وحتبني كثير، يعني إن شاء الله نطلع فيها في recommendation. المعلومة اللي قالتها الدكتورة ابتسام عن التايم والdistributed task على التيم المفروض تتفعل يعني بشكل أكبر، وإحنا إن شاء الله ماشيين في الركب، يعني طالما بدأنا هذه البذرة إن شاء الله حنستمر فيها. Thank you very much for coming today. ونشكركم على التجارب اللي ذكرتوها، ونشكر الجمهور برضه على أسئلتهم وطرحهم الفعال. Thank you.
Bismillah ar-Rahman ar-Rahim. Now we will move to the next theme. It's important theme and not well recognized. Actually, it's under umbrella of family medicine. Sport medicine is very broad subspecialty. And we will focus on the one of the important thing under sport medicine, which is pre-participation screening among athletes and anyone who wants to do any exercises. Our guest, the first guest is Dr. Mohammed Hakami. Dr. Mohammed Hakami, he is consultant family medicine, and he has subspecialty in sport medicine from California University, and he was the chief of the Olympic Games in the Ittihad Saudi, وأيضا still currently working there. He has a lot of experience dealing with such topic and dealing with the sport injury in general. Dr. Mohammed, the floor is yours.
Right. Good morning, everyone. And I believe we are about in the noon. So hello, everyone. And I'm going to turn on my video. So can you see me now?
Yes, clear.
Okay, so I'm going to start to share my presentation. So first of all, I'd like to thank all the attendants. So I can see like more than 5,000. Wow, that's a huge number. And I would like to thank the organizing committee for coming, for inviting me. And special thanks also to Dr. Nazir. And thank you for introducing this this important topic, sport medicine. I believe like we need people who specialize in this field. Like when we travel with a team in North America, they prefer specialists with wide scope of practice, something like family medicine or ER. And those are the eligible to proceed further studies in subspecialty like sport medicine. In Saudi Arabia, somehow, I don't know why, we don't have as much specialists with wide scope of practice, because when we travel the team, we're dealing with MSK, with GI, traveling, vaccinations, doping, nishtat, all those important topics, it needs someone with wide scope practice. My talk today is going to be about pre-participation screening and sudden cardiac death. So I want to just highlight before I start, we are not going to talk about the sudden cardiac death and how to screen for that, the general pre-participation screening. And I think I should start my presentation with the case scenario and see your input about it. So, okay, let's start with this case. So say that Dr. Nazir being assigned to help famous local football club as a team physician before the league start. They have famous contracted players, both national and international. Your first recommendation was to do pre-competition assessment for each player, and you decide to do comprehensive labs and 12 ECG for each player. Team manager criticized this decision, like why to screen healthy athletes? And those tests will be expensive and time consuming. What do you think? So I will pop up at the poll and see your interactions about this. So we want to see your interactions about this thing. And yeah, so the question is, would you screen all athletes, including labs and basic 12 lead ECG? Yes, no, I don't know. And just be honest about this answer. Okay. Okay, that's nice. So I will show you the results. So the majority of you said yes. Okay. So, but what about the evidence? What's the evidence of pre-participation screening? So let's just proceed to the lecture. And it has been suggested that proper medical history alone may identify or at least lead to suspicion up to 75% of problems that affect athletes. And for those people who say no, or I don't know, I understand. Currently in the United States, a governing body that regulates the content of pre-participation screening does not exist in professional sports, collegiate sports, or high school sports. Additionally, there is nothing that regulates cardiovascular screening. But FIFA do. FIFA, they design a form called pre-competition medical assessment. What I'm gonna do, I'm gonna walk you through the component of this form and show you the evidence. Now we are in family medicine. We talk about evidence more than just facts in the paper, right? And so this form, it does have a lot of data, just like the demographic data. There's a lot of components. I will summarize it, and there are under 7 components. Competition history, what this athlete is to do, what his position, left back, midfield, always important. Medical history, general physical exam, and cardiovascular system, and blood results, MSK system, and summary assessment. So in Saudi Federation of Sport Medicine, we translate this form. It's 14 page, it's available. If anyone wants it, it's already available. And now let's just go to the demographic data. Usually, like, we want to know about few important stuff like age, size, gender, and ethnicity. And why I'm highlighting ethnicity here, they found that athletes from West Africa, especially blacks, especially from West Africa, they do have bizarre repolarization on the ECG. So knowing these facts and also the size of the patient, if the patient have Holcomb manifestation and he is a big athlete, well, that's understandable. Someone thin and with these changes, that's warrants further investigation. So just knowing this demographic data is important for too many things. And also question on general health, like allergies, medication, use of supplements. And why I'm highlighting supplements here, let's just put this in an example. Say that you were the head of a medical team in Olympic Games. One of the athletes is in the shooting games. And you'll be surprised. There's athletes who are taking antihypertensive because not all the sports requires full fitness, like these people who doing this sports. So you want to know, for example, from the history, you know that he's taking covercilin. You want the Australian Society of Anti-Doping, and you search about the component of this drug. Brindopril is not prohibited during the competition, but indapamide, the diuretic, is prohibited. All the time it's prohibited. And to give the patient the power or the authority to use this medication, you have to have 3 reports and that he's been trying several medications not working. And for that, we need something called therapeutic use exemptions. Otherwise, this patient, if he tested positive, he will be banned for 4 years minimum. And another thing, let's say this athlete who have heartburn and he's been following with too many doctors, and then the gastroenterologist give him misoprostol. We know this can be one of the 3rd line or just to treat the peptic ulcer. And we check the Australian Society Anti-Doping, and it's not prohibited. But when the athletes went to the airport, they took him to the investigation, they took him to the jail. So why is this? We know that like this medication, the misoprostol, it's in the black markets. It goes like without authorization, people sell it in the black markets for a portion. So such working with this medication, you need to make reports, medication declaration forms, prescription. You have to have these things. So from the history alone, we can know this. And we used to make this form. Before we travel with the team, we distribute all those forms and we put the names of the medical personnel, and the organizing should sign of this, and they declare this medication not for sale, and it has a prescription. And before we travel, we put this page on the bag, like so the custom, they will see it and they know before, if they scan and they found the drugs, they know what this is for. So this is very important thing, and history alone can tell us. Supplements, why I ask athletes about the supplements. This is very important. So let's say that your athlete taking supplements. We know, like, we have to teach the athletes, like the supplements, it's their body, and they are the one responsible if they want to take it. But we have to tell them about this study. There's a study done in 2004. They analyzed the non-hormonal nutritional supplements of anabolic and androgenic steroids from the supplements, and they did this internationally. And they took samples from several supplements from different countries. And guess what? In Netherlands, 25% of the supplements were positive, and with androgen, with steroids, and they didn't declare it in the supplements. So most of the supplements not FDA regulated. And I believe companies from time to time, I don't know, for some profit reasons, or maybe during the manufacture, or a lot of theory, but they put androgenic stuff, or it could contaminate with androgenic stuff. So athletes like it, oh, it's work. And so we have to be careful about that. And another thing, then we will go about the physical examination. And this is a very important component of the FIFA pre-competition assessment. So what they said, apart from the specific orthopedic and cardiovascular examination, a general medical examination, including height, weight, and ethnicity, is always indicated. What's the evidence about this type about the examination, especially the orthopedic part? They did a study and they assessed the pre-competition orthopedic assessment part in the FIFA, and they found it's okay. But the challenge is to ensure the quality of the physical examination and to verify the predictive values. So whoever do the exams for athletes, he have to maintain a good knowledge, and he have to have a good experience with the MSK background. And let's just see it in the reality. I mean, everyone knows this athlete, and we know like that he have injury, and the mechanism was quite weird, like how he had that injury from such tackling athlete. He had sterocruciate ligament injury, lateral collateral ligament injury. That was bad injury for him. And the mechanism was not understandable. Like, how come such tackling cause all this damage? When they go back to the history of this athlete, they found that he had posterior cruciate ligament tear 2013, lateral collateral ligament tear 2014, and so on. So knowing this stuff about the athlete, we can prevent such things. We can tell the coach, well, this athlete is just recovering. I think the physio should make sure the proper reception, his fitness, his level of preparation is okay before I just let him play for 90 minutes of the game. So all this goes and all this comes from the physical examination and from the history. So this is very important. And how about the laboratory investigation? Testing athletes' bloods for abnormal values has mixed effectiveness. And there's a study who they tried to analyze the components of the FIFA components of the lab work, to screen or not to screen. What the recommendation they came from it? Said it is known that an athlete who have very low iron stores, ferritin, there may be a demonstrated reduction in performance. And testing hemoglobin and ferritin levels in certain athletes appear to be worthwhile. So especially for the female. And how about the vitamin D? They said further studies are needed for, and I'm not a fan of this actually. It's fat soluble. We see a lot of patients, let's say healthcare practitioners, they give the patient the advice to drink it with water. It's fat soluble. Why with water? And also the labs which measure the vitamin D, still their values, still there's no enough evidence. There's no enough evidence about it. Finally, we need to remember that athletes are people too. And some cases have higher behavior than the general population. So we should abide to the United States Preventive Task Force. Okay, just please allow me for a second. All right. I see. So Dr. Aziz tell me that you guys like missed me for 2 minutes. I apologize for that. Anyway, so we were talking about that athletes, we should know that they are human too, and they should abide to the United States Preventive Task Force screening test. And lastly, I'm going to talk about the cardiovascular screening, and I believe everyone take this into consideration. From basic science, we know that heart beats 90,000 times per day. With exercise, it has to enlarge to pump 25 liters around the body instead of 5 liters, and that then goes for 3 hours. And we have to know this is the athlete. This is his job, so he's doing this on a daily basis. So of course there will be physiological upper limits of cardiac dimension, but what's the limitation for that? There's a conference in Seattle, and they put good definition about the upper limits for for physiological changes. And they make an open access 2-page form in the PMG, and like they will walk you through what's the upper accepted limits in the ECG changes. And there's a study that said pre-competition cardiac assessment protocol, they assess this part in the FIFA pre-participation assessment form. And what they found, it's okay, but you have to ensure the correct results. Sport cardiologist, exercise specialist, physiologist, expertise is essential. We have to consult these people because changes here, just imagine the psychological impacts. If we interrupt this ECG, oh, you have focus. I have to be sure. There's a lot of consequences psychologically and even financially for the athlete and even for the whole club. So we have to be careful about interpreting these things. And I have to tell you a very important thing about the ECG. Like we know the leads looking to the heart from different angles. So let's say that like this example, this guy is looking to the element from the front, other one from the rear, other one from the side. Same thing is applicable to the ECGs. We have the augmented lead, and the right, the left, and the foot, and they are looking at the hearts from different sides, from the right, from the left, and from below, and lead 1, lead 2, lead 3 as well, but different degrees. The V leads, it's looking the hearts from the anterior side. And we have to understand how ECG works. If you really want to interpret the changes in the athlete, we don't have to rely on memorization here. So we know like basic science in ECG, depolarization, if the net vectors going to the leads give us positive deflect, it's going away, give us negative deflect, and the vice versa in repolarization. So let's just show you this example, like this athlete who most likely have HOCM, deep Q waves and inverted T waves. So let's say this is the normal, and do you guys see the cursor here? This is the normal, this is the HOCM heart, and we see the interverticular septum is hypertrophied. So when we play this video, I want to highlight here, when the waves goes, let's say this is lead 2, this is lead 2. When the waves goes to the lead 2, it gives us positive deflection, but part of the waves goes back to the interverticular septum, and that gives us deep Q wave or negative deflection because the net waves going away. And if that very long, that will give us a hint the interverticular septum is hypertrophied. So knowing the basic science of the ECG can help us also to interpret the ECGs. And same things may happen to the athletes who have myocardial infarction. And yes, some athletes may have that, especially if he's like weightlifter, and some people who may do androgen, they take steroids, and all this can put the heart at the risk of atherosclerosis. So similar changes can happen. Imagine the left wall have ischemic changes, and the waves will not travel to the lead. It will travel away from the lead. And that can give us also deep Q waves. And to interpret this more, of course, we should not only rely on the QRS complex. We have to also look to the other non-QRS complex, like T waves and the ST segments, etc. I'm not going to talk deeply in this because my colleague, Dr. Wafa, she will cover this. I want just to highlight the last thing. There is few rare stuff which can cause sudden cardiac death. One of the rarest thing is the comitus cordis. And unfortunately, we have athletes who suffer from this and they died. And I will just talk briefly about it and what we should do to prevent that. There's no screening can detect such things. So what is comitus cordis anyway? Comitus cordis, if you have a hit in your heart during the T wave repolarization, during certain time of the window, the rhythm may go to B-flat. It's very rare. And let's see this. All right, I'm gonna stop here. This guy he gave him a punch. The blue athlete, he punched the red athlete, the one who wearing the red. And then let's see what happens. Okay, they called the doctors. They came. Nobody did circulation airway breathing. Of course, they are thinking that he's an athlete. He's healthy. Why would I do this stuff? If we know those things can happen, and like now FIFA said, if the athletes collapse without contact, you just collapse. Take your AED bag and sprint to him. You didn't even have to wait for the referee to allow you. Every seconds matter. We know there's athletes who died from this, and if only they did the proper ABCs, maybe they will avoid that. And now that's why FIFA now they recommend in the prevention we have to have the FIFA bags. Not only FIFA bags, there's a lot of companies which make these devices, but it should have the AED device. And this athlete is Fabrice Muamba. If you guys Google him, you'll see that he was collapsed during the league, and he was resuscitated, and he was picked, and he's alive, and he have to resign football after this incident. So now what? We know that, well, we have this athlete, we diagnose him with the HOCM, or we diagnose him with ion channel myopathy. So what we're gonna do? There's two recommendations came. The CEDA conference, they make a recommendation, and the European Society of Cardiology, they did also recommendation for HOCM. All sports should be avoided. This preceded the conference. But what's the European Society of Cardiology? They said only recreational sports. And they put a different recommendation for the ion channel myopathies and different cardiac issues. And we know this happened recently. And I think everyone watched the news, what happened to this guy. He was collapsed, resuscitated. And what they did for him, they put him ICD, implantable cardioverter defibrillator. And they said, like the Netherlands defender Daily Blind, he will have this and he will play with this. So the European recommendation sometimes differ from the American recommendation about that. How about us in Saudi Arabia? Well, if you Google the sudden cardiac death in Saudi Arabia, I believe like not the elite athletes, but for the people who playing football, there's several reports about people who collapsed and they died. And most of them are Black. So we have to know, like when I mentioned the Black ethnicity, we have to know about that. Like Black athletes especially, they may have T-wave inversion from V1 to V6. But what study said, it's not acceptable if we have the V6 and V5, V6 T-wave inversion, further investigations are warranted. So do you think we should screen for the athlete using the FIFA competition assessment form? I would say yes. I would say yes. It's the evidence support that, but you have to make sure you have the good facility. You have to have the good expertise. Because think of the consequences. If you test this athlete and he came back and you interpret this wrongly, think that psychologically and all the consequences if you just throw that word. You have to be careful and do this pre-season, not during the competition. Thank you very much.
Thank you very much, Dr. Mohammed, for this nice presentation, and kindly stay with us to the end of the theme for the discussion. Now I want to invite the second speaker, Dr. Wafa Dawood. She is a consultant cardiologist and consultant electrophysiologist. Okay, and she will talk about, and she's a director of the cardiology program at King Fahd Hospital University. She will talk about the ECG change among athletes, what's normal, what's abnormal. تفضل.
Who see these patients as or healthy individuals. So it's really important that all of us know how to interpret ECGs for athletic patients. So I'm going to talk about ECG interpretation among athletes, why it's really important. As Dr. Hakami mentioned, actually it's very sad when you see healthy athlete who collapse in the field, and unfortunately that's the first presentation and the last presentation, unfortunately. So what we can do to prevent this from happening in the future? Actually, when you type in YouTube about players or sudden cardiac death, you will see a lot of videos, but just for the sake of time, I will just show you as he mentioned, the Danish player, because it was really catastrophic. He collapsed in the field. He was he was the leader of his team, and he was a good player. So he fell down, and what he got, if you see the video, yes. Just watch what happened. He felt dizzy and then he collapsed. What happened? He developed, if you look to his eyes, he's just seeing nothing. This is ventricular arrhythmia. This is what happened when someone gets ventricular arrhythmia. So he was defibrillated in the field and subsequently he got ICD. Of course, he can't play anymore. So he killed his career. But what to do in the future, how to manage this. He's the leader. He played many games. Just now, that's the first presentation. He's lucky that he is going to live, even if he's not going to play anymore. Okay, so sudden cardiac death, it's just one slide, is the leading cause of mortality during intense physical activity. It's a rare event, but it's a huge impact because all of us, we see these people, they are the role model. So it's very catastrophic. Most deaths are due to structural or electrical disorders that are detectable during life, for which several therapeutic modalities exist to minimize the risk of sudden cardiac death. Over 80% of affected athletes are asymptomatic, and sudden cardiac death is the first presentation. 12-lead ECG is effective for detecting athletes with electrical diseases, but also helpful in identifying those with cardiomyopathies. ECG-based screening is now mandatory for pre-competition for all athletes. So why we see changes in athletic individuals? It's most likely secondary to increased vagal tone and increased cardiac mass. More than 70% of healthy athletes demonstrates these training-related ECG changes, which don't warrant further investigation. It includes sinus bradycardia, first-degree AV block, voltage criteria for left and right ventricular hypertrophy, incomplete right bundle, early regularization, and sinus arrhythmia. Increased vagal tone for sure will lead to sinus bradycardia, sinus arrhythmias, and early rebolarization. It's less common to see that first degree and Mobitz type 1 second degree heart block. Actually, this is what we need to see. Can I have mic? أقدر أتحرك فيه. Okay. This ECG, you will see the commonest ECG changes in athletic patient. You see there is early regularization. Do you have pointer? هذا؟ Okay. See, there is early regularization. Early regularization, sinus bradycardia, heart rate less than 60, LVH by voltage, which is S in V1 or V2 plus R wave in V5 or V6, more than 35 millimeter, peak T wave, ST elevation. That's the most common ECG changes in athletic patients. This is 29-year-old asymptomatic soccer player. Okay. I want to go back. Okay. Okay, bradyarrhythmia is again is very common. Actually, that's the importance of exercising, that heart rate will go down. And this is the 12-lead ECG for long distance male runner heart rate. You can see it's 60 beats per minute. And if I want you to see the P wave is not constant and it's very short PR interval. And sometimes it's not, you don't see it. RR interval is constant. It's 60 beats per minute. This is junctional rhythm. It's a common manifestation in athletes. Another ECG for 28-year-old asymptomatic Caucasian handball player. You will see that they have to mention Caucasian, Black, because sometimes, as Dr. Hakami mentioned, Black athletes or African, Caribbean origin, all of them, they have little bit different ECG changes. So this player has again junctional rhythm, CR wave, RR interval is constant, P wave you don't see it all the time. This is again junctional rhythm. This is young academy football player. I want you to see in this 12-lead ECG that inferior leads. In inferior leads, 2-3 AVF, P wave should be upright. You see it here is negative. So it's coming from somewhere different than the sinus node. We call it low atrial rhythm. It's coming from the atrium instead of the sinus node. So again, that's common in athletic patients or individuals, sorry. This is asymptomatic cyclist. I want you to focus in this P wave. There is P wave here, okay? That's a drop beat. We call it a drop beat. See the PR interval before and PR interval after. If you notice that PR interval before is longer than the one after. So this is Mobitz type 1 second-degree heart block. Again, you can see it normally in athletes. Another one with heart rate around 40. No other ECG changes, sinus rhythm, sinus bradycardia, P wave, it's small, but it's positive in inferior leads. And each QRS proceeded with P wave, so this is sinus bradycardia. Sinus arrhythmia, we call it sinus arrhythmia when the heart rate varies with respiration. This is 18-year-old footballer. It's common actually, not only athletes, any young individuals that's common to see sinus arrhythmia. Notice that there is PQRS, all upright, which is normal, but the heart rate just varies with respiration. That's common in healthy individuals. This is asymptomatic female recreational athlete on routine ECG. 12-lead ECG, no other actually abnormalities except for PR interval short. It's around 110 milliseconds. It's abnormal when it is less than 220 milliseconds. But for her is normal. Also, LVH, RVH is common. This is young football player with his ECG. I mentioned that before, 12-lead ECG.
check the amplitude of S wave in V1, V2, R wave in V5, V6 is more than 35 millimeter. That's common. But when you say that someone has LVH, just notice that there is no T wave abnormalities. There is no left atrial enlargement with no left atrial dilatation. So he has only, this player has only LVH by voltage, no other abnormalities. This we call it normal changes. This is 19-year-old asymptomatic soccer player, same thing, has LVH. So why we have to focus on LVH, if there is LVH, if the R wave is amplitude is okay or not, because we don't want to miss people with hypertrophic cardiomyopathy. Isolated increased QRS voltage on the ECG in the absence of other abnormalities. An asymptomatic athlete with negative family history is not reliable indicator of LVH or HCM and doesn't require further evaluation. I'm showing this ECG. I want you to notice the difference. In this ECG, you see there is a T-wave inversion in lateral leads, 1 AVL, also inferior, lead 2, lead 3, lateral leads V4, V5, V6. This is this ECG for someone with hypertrophic cardiomyopathy. So it's not only the amplitude, you have other ECG changes that suggest there is something abnormal, and this athlete should go for further testing. Partial right bundle branch block is also common. 35 to 50% of athletes have incomplete right bundle, secondary to enlarged RB cavity and increased cardiac mass. The occurrence of incomplete right bundle in asymptomatic athlete with negative family history. See, we always focus on past history, family history is very important. It's not only interpretation of ECG. You have to know the background of the patient. This is a 12-lead ECG. Only you have incomplete right bundle QRS duration in V1. It's positive and the duration is less than 120 milliseconds. So it's only incomplete right bundle branch block. Early repolarization is very common. Is defined as elevation of the QRS ST junction, which is J point in combination, or in isolation with the slurring or notching of the terminal portion of the QRS in inferior and or lateral leads. 25% of white athletes and up to 40% of black athletes. In this diagram, I want you to see the difference between the J wave elevation. If there is only slurring, that creates a good prognosis. If you see the notching like this, it carries worse outcome. Again, ST segment, if it is upsloping, ascending, that's okay. But if it is horizontal or descending, you need to do more testing for this athlete. Here, this is 12-lead ECG for 29-year-old asymptomatic soccer player. There is upsloping ST segment elevation, which is a high J point, earlier repolarization. Also, there is LVH by voltage, peak T wave. That's common for athletic individuals. In Black African athletes, you might see with ST elevation and high J point, you see inverted T wave or bifid T wave. But what's more important, it's V1 up to V4, not in lateral, not in inferior. Okay, so this is 24-year-old asymptomatic Black African soccer player. That's ECG. This ECG is normal for him. I want you to see the difference between the two. Here in panel A there is ST elevation upsloping with T wave inversion in V1 to V4. See here, there is horizontal or flat ST segment, followed by T wave inversion. okay, from V1 to V4. That's normal, that's abnormal. You see the difference? Another example, doomed ST segment with T-wave inversion V1 to V4. Here it's horizontal, that's normal, that's abnormal. Horizontal ST segment followed by T-wave inversion, especially in lateral leads, V5, V6. This patient was diagnosed with hypertrophic cardiomyopathy later on. Again, what's normal T-wave inversion in athletes? T-wave inversion is a common electrical manifestation with cardiomyopathies and athletes. So in some individuals needs further testing. Some adolescent athletes, adult African or Afro-Caribbean origin, and endurance athletes show anterior T-wave inversion, V1 to V3, maybe normal variant. Anterior T-wave inversion is reported in up to 14% of endurance athletes. Here, that's just to show you the example of T-wave inversion with ST upsloping in V1 to V4. That's okay. You can pass it as normal. This one is 15-year-old white footballer player. There is only T-wave inversion in V1 to V4. You can pass it as normal. Borderline ECG findings, axis deviation, atrial enlargement, left atrial enlargement, right atrial enlargement, complete right bundle branch block. That's borderline. Here, this is complete right bundle branch block. QRS duration is more than 120 milliseconds, upright and positive in V1. Also, there is a sinus bradycardia. If there is negative family history, no symptoms, you can pass it as normal. So what's abnormal ECG findings? I think we covered all the normal changes in athletic patients. So what's abnormal is pathological AV block, ventricular pre-excitation, pathological cues, non-specific IVCD and left bundle, ST segment depression, pathological T-wave inversion, lateral T-wave inversion, and inferior T-wave inversion, Borgata, long QT, and ventricular ectopy. Morbid type 2 and complete heart block rare and should raise the possibility of cardiac conduction abnormalities, inherited cardiomyopathies and channelopathies, and acquired infiltrative or inflammatory disorder may cause intrinsic AV node disease in young athletes. Whereas cardiac conduction disease is the most likely cause in middle-aged and older athletes. The presence of symptoms, broad complex QRS, abnormal access, and inadequate increase in sinus rate, which is chronotropic incompetence during exercise, is useful to confirming conduction disease. Ventricular pre-excitation athletes with WBW syndrome should have radiofrequency ablation for the pathway. The management of asymptomatic athlete with pre-excitation is still debatable. Non-invasive risk stratification is recommended. For example, exercise stress test. This 12-lead ECG for academy football player and just screening ECG. If you see this rhythm stripped down, there is the PR interval is normal, QRS is not wide. Again, normal complex. Here, if you see short PR, delta wave, wide QRS, this is what we call it intermittent pre-excitation. All of this are the same. Again, back to narrow QRS, normal PR interval. This is intermittent pre-excitation. And athletes or individuals with intermittent pre-excitation, they may have just a low risk pathway. It's not able to conduct all the time. Pathological cues. The international recommendation defines the pathological Q wave as a negative deflection exceeding more than 40 milliseconds or when one which has an amplitude more than 25% of the following R wave in two contagious leads, excluding AVR3 and AVL. Pathological cues and 2 or more contagious leads warrant further evaluation to exclude cardiomyopathies and myocardial disease. Here is the 12-lead ECG for retired athletes showing to see the inferior leads. That's very nice cues. Actually, you don't see even R wave, okay? Very nice inferior lead Q waves. Also, there is late transition of the R wave. This athlete actually diagnosed later on with biventricular cardiomyopathy. IVCD and left bundle, most of the time it is pathological. So the definition of IVCD, when it exceeds 110 milliseconds without specific morphology, it's common in general population, but has occasionally been associated with cardiomyopathy and increased risk of cardiovascular death. IVCD in athletes may reflect combination of high vagal tone and increased myocardial mass. Further evaluation is recommended if QRS is more than 140 milliseconds, and left bundle branch block is commonly present in patients with cardiomyopathy and ischemic heart disease. It's present in less than 0.1 of athletes and should always be considered abnormal. ST segment depression, I will pass this one. T-wave inversion. I showed you examples a while ago. Any lateral T-wave inversion should go for investigation for cardiomyopathies. This is 28-year-old white male. There is T-wave inversion in inferior and also lateral. This most likely has cardiomyopathy. Brugada ECG pattern also is, you have to differentiate it. So I'll just show you this. I want you to see the difference between the normal ECG changes in an athletic individual, T-wave inversion and V1 to V2. Just see here, down sloping ST segment with T-wave inversion. That's Brugada type 1 ECG. That's totally different to athletic ECG. You have to notice the difference and exclude the patients with Brugada from competition. Another example is very clear. Here, there is upsloping T-wave inversion, but here it's downsloping with T-wave inversion. This is Brugada, that's normal. Long QT syndrome sometimes it's confusing. You can calculate it perfectly. You have to use Bazzett's formula to correct a QT interval. Here, 12-lead ECG for 35-year-old male white endurance athletes. If you notice QT interval here, if you just by eyeballing, you will say that there is QT prolongation. But if you focus clear, just see the T-wave itself is bifid followed by U-wave. So that's why you have the false impression of long QT. But if you measure it in lead 2 or lateral leads, actually it's normal, 402 milliseconds. This is 16-year-old white swimmer. Again, just see where is the T-wave and try to measure it. Actually, this is the end of T-wave. By eyeballing itself, it's passing the halfway between RR interval. That's definitely abnormal. The QT interval here is 596 milliseconds. This player was diagnosed to have long QT syndrome type 2. So this is just a summary, what to look and what to do with the ECG when you see any changes. Conclusion, the 12-lead ECG is commonly used to identify young athletes with potentially serious electrical or structural cardiac abnormalities. Athletic training itself is associated with electrical alterations that may resemble serious disease, particularly among Black athletes. Over the past decade, there have been several refinements in ECG interpretation in athletes that have reduced false positive results without compromising specificity. Thank you.
Oh, okay.
Thank you, Dr. Wafa, for this nice presentation. Actually, now for the discussion for a few minutes, then we'll have break. We have very important question regarding the two topic. In a brief, just Dr. Wafa, I will start Dr. Wafa, then we have a question for Dr. Muhammad. Dr. Wafa, what do you think? Is it, how sensitive is it and how specific? And we show that, and we saw some players, even they are professional, their career is playing football and etc. with extensive investigation, and they died after that, or they have any event after that. And I don't know, is it normal ECG? Can we rule out abnormalities?
Actually, whatever you do, you have just to do your best. But unfortunately, still, these professional players now, they are playing and they are having events even after a lot of investigations. So you are just lowering the number. You can't eliminate it at all.
The second one, we saw even the normal ECG among athletes isolated voltage criteria and incomplete right heart branch block and heart block first and etc. Can we rely on this change among athletes? I mean, we don't know who's athletes, who's not. Sometimes even with recreational activity, they came to the clinic and we did ECG, we found these changes. Can we say it's normal, or we have to emphasize about the activities itself?
That's why you have to go to history. You have to ask the patient, what kind of exercise? Is he playing weightlifting, running, swimming? What kind of activity and for how long? How many hours per week? And again, family history is very important, and any history in the past. Some people actually, I have seen patients, they say, yes, after exercise, I feel sometimes I feel dizzy. So some individuals actually, they think that that's just because they are tired, they felt dizzy, so that's okay. No, sometimes no, it's not okay. That's why history is important.
Thank you.
Before doing anything. Even if I have normal ECG, I have negative, positive history, family history of sudden cardiac death, I will not just pass the 12-lead ECG, even if it's normal. I have to do further testing. Sudden cardiac death, actually, it's good that we are here today, even for not athletic patients. If you have any family with the family member, sudden cardiac death, just young individual, family should go for screening. We have to do something for the community. You just I know families, they have 2 members, 3 members with sudden death, nothing done for the rest. We can't bring back the one who died, but at least we have to do something for the living. So it's good you are here today. Hopefully the audience, they listen to my message. Please, if you have positive family history, screen the patients.
Okay. Thank you very much, Dr. Atta. Dr. Muhammad, we heard about the ECG among athletes or among professionals. What do you think about mass screening of ECG among anyone who wants to do activity in general, including even the school students? Should we do ECG? We know that different school among the world. What do you think?
I'll start my lectures with like what happened in US. There's no structured guidelines, to screen everyone with ECG, even athletes. And that's the thing I walked you through is the FIFA believe and otherwise. And so I don't think there is like guidelines or there is any organization which suggests such screening. But as my colleague said, Dr. Wafa, like if someone with premature heart disease, something like early death, it's not always about HOCM. Like we have a lot of other stuff. It could be rhythmogenic right ventricular cardiomyopathy, dilated cardiomyopathy, left ventricular compaction. And the list goes on. And I just bring something quite rare, it's the comitis cordis, which happened and there's no screening to identify that. So maybe Dr. Wafa can add things to that. Yeah, please.
What do you think, Dr. Mohammed, about the best method to be applied in primary care? The easiest one, which I don't know, and we saw your form for the Saudi sport ministry. Is there any other form? What do you think about AHA 14 elements? Is it enough for primary care physicians?
Yeah, I walked you through the evidence, like each elements and what's the evidence say about, including history, labs, physical, and etc. In the family practice, we don't do that. In the military, because I work in the military hospital, I think the new recruitment, they do comprehensive testing, but ECG not among them, unfortunately, yeah. And one thing just I think you guys should know, like collapse not always due to cardiac, it could be exercise-associated collapse. There's other things, heat stroke and dehydration, all this common in athletes, hyponatremia, especially those people who just drink water and they're doing marathon, drink water, there's no electrolytes in that. They may end up with hyponatremia that could cause collapse. So in the primary setting, I am not aware of any guidelines that said, hey, let's just screen everyone. We just follow the American Heart Society and like what they are doing. Like they have risk behavior and they have smokers and metabolic syndromes, overweight, and then chest pain from time to time. And this is time to screen them. But like just for normal population, there's no guidelines I'm aware of. Anyone knows something, let me know, please.
Thank you, Dr. Mohammed. Just the last question from the audience, anyone? Nabil, the mic.
يس دكتورة، شكرا للمحاضرة القيمة. في الواقع إريكسون he has passed through screening, I'm sure, an advanced test. Why he fall down? Because of false negative. They consider him false negative and he fall down, isn't it? You agree for this point, first of all?
Actually, I haven't seen his screening, but as I said a while ago, even with extensive screening, still you will pass some people as normal and then they will have something. So you are lowering the number of events, you can't make it zero.
So this is false negative.
Yeah.
Yes. Okay. Then the physiological changes, what happened to the athletes, it's considered to be pathology for other people, isn't it?
Yes.
So how if you suspect in athletes that this is pathology rather than physiology, what you will do? How you will react to exclude that this is pathology rather than physiology?
You mean for athlete or
athletes? Which we consider that.
So maybe Dr. Hakami, he knows better than me what they do exactly for athletic individuals. But as a cardiologist, what we have to do, exercise stress test. I know they have good exercise, but the idea that they are connected to the ECG, see if there is anything abnormal. Even, for example, PVCs during the stress test, that will be abnormal. Echo to check, and even when we do echo and cardiac MRI, which is very important, the interpretation should be done by expert in sport medicine. Not, I mean, if just cardiologists look to this echo, for sure I will say that's abnormal. But what I'm going to say is abnormal for any individual is maybe normal for him. So someone who has the experience for interpretation of echo and cardiac MRI should look at it.
So not every cardiology can read it.
That's why we have a sport.
Not every electrophysiology also can read it because we
I'm electrophysiologist, not cardiac imaging. Also, that's different. Because so there is a lot of things, unfortunately. Yeah.
Yes, there is a structure and electrical changes, which is needed to be focused on.
Yes, that's why now I think it's mandatory by FIFA. Each team, they have their own cardiologist. If you go for the European footballs, I know Liverpool, everyone, they have two cardiologists, not even one cardiologist, two cardiologists to see for the all of them screening, and they follow them. They go with them for the games. So two other than the other doctors in the team. So it's not only one. But we are talking about big teams. I mean, I don't know about I know that here في السعودية بيعملوا نفس الشيء screening، بس ما أعرف، ممكن دكتور حكمي يفيدنا.
ممكن دكتور حكمي. The neighborhood teams, sport teams, the death among them is high, by far is high, very high. So maybe the last point in my question, are you going to start first statistics about the death rate among athletes in neighborhood sport teams?
I will say something different. At least we need the statistics for sudden cardiac death, even in normal individual, even without, you don't need athletes. So we need two statistics for athletes and for our community. I'm sure the number will not be low at all.
Dr. Hakami?
Yeah, so I believe I don't think it's high. Like we will look to the statistic. Sudden cardiac death still very low, but the consequences is very, very bad. And like if we want to screen the athletes further, of course, echo is important. And now if you follow the guidelines, we can tell the gray zone, for example, left ventricular hypertrophy, the gray zone between HOCM and athletic hearts, we may accept from 13 to 16 mm. Of course, more than that, that's HOCM. And like if we goes to the, like for the amateurs or recreation, athletes. And I think the statistics still, I don't think that we have a lot of people who died from that, but there is from time to time, rarely we see some news about this. And when they collapse and they fall on the ground, they are young. So you expect something happen in their heart. Fortunately, there's no screening. But what we do for the athletes, if they need echo, cardiac echo, and even cardiac MRI, we'll proceed, yes.
Okay.
طبعا دكتور حكمي بس this before, maybe for athletes, when you do the statistic, the number is low, but because it's everyone is watching, that's why you feel it's catastrophic and you feel that we need screening. But I'm sure when we do statistics for the community for sudden cardiac death, the number will be high.
Yes, thank you very much, Dr. Wafa and Dr. Muhammad, for this nice talk. And we have now a break for break and lunch, and we will come back, inshallah, at 1:20 or 1:25. Okay, thank you.
Check.
Welcome back all. It's my honor to introduce our first speaker in the geriatric care theme, Dr. Naziha Al-Mzayin. She is consultant family medicine, trainer in Family Medicine Academy E1 Health Cluster, coordinator of geriatric care program in Qatifa Primary Health Care, and she is head of Middle East Academy of Aging. The floor is yours, Doctor.
Thank you. Good afternoon, everybody. It's my pleasure to be with you today. So today we will talk about a very important topic in geriatrics, that is geriatric assessment. By the end of our presentation, we try to define the comprehensive geriatric assessment and the team involved, list the steps included in geriatric assessment, identify different domains included in geriatric assessment and different scales used, recognize method to implement geriatric assessment in a busy family medicine clinic. So let's start with the case number 1. So Huda is a 67-year-old lady. She is a known case of diabetes type 2, hypertension, and treated breast cancer. She came for follow-up, and she usually comes on wheelchair, accompanied by her neighbor regularly. She is an ex-smoker for the last 10 years and living with her husband who has right hemiparesis, post-stroke, and dementia. Did you imagine this patient? Is she a fit young patient? No, she is elderly, she has disability, and she has comorbidity. She is unable to do home glucose monitoring by the glucometer, and she visits her neighbor to get the insulin injection daily. So she needs assistance even in taking her medication. She has 3 children studying abroad, and 3 lives with occasional visits. Physical examination of this patient showed that she has a high BP and she has a high BMI. Her last lab showed that she has uncontrolled diabetes and she has borderline creatinine and high lipids. This is the list of her medication. So, the problem list. In medicine, we were told that after assessing the patient, we have to put a problem list. So, how far you agree with this problem list, and do you want to add any further problems? So, we list that she has uncontrolled diabetes, uncontrolled hypertension, obesity, and diabetic nephropathy. Anyone has any further suggestion to describe this patient? Polypharmacy, okay. So for this lady, what management you would request or you plan for this patient? What do you advise? As long as that was the problem list, what would you advise for this patient? She has uncontrolled diabetes, uncontrolled hypertension, obesity, polypharmacy. You will keep the same or you will add anything for her management? Okay, for the sake of time, you may take, you may add brandial insulin. She is on basal insulin, you may add brandial insulin. You may increase the antihypertensive treatment and advice for weight reduction by exercise and diet. Okay, do you have any further management for this patient? What if you consider comprehensive geriatric assessment? We come to the comprehensive geriatric assessment, we got the chance of including this patient in our geriatric care. This is the booklet by Ministry of Health. So what do you expect we found? Reviewing the history and completing the full assessment, we uncover that she has depression, she has urinary incontinence, she has poor vision, she has impaired ADLS because of the disc, and she has recurrent falls, besides the other problem, of course. The management plan, according to all the problem we found, was social worker referral, ophthalmology referral, adding vitamin D, ordering DIXA, giving the BCV13 vaccine, the flu vaccine, preferring pelvic examination, and order urine analysis and urine culture. Dietary advice, orthopedic referral, starting SSRI for the depression, considering assessing the husband at a clinic. He is also a patient. He needs assessment and advice for home safety because of the fall. Okay, so you found the difference between the problem list and the plan before and after comprehensive geriatric assessment. We come to case number 2. Mrs. Khadija came to the clinic to get refill medication for her husband, Mr. Jaber, because he is no longer able to attend primary care clinic, and she is asking to refer him to the home care. Mr. Jaber is an 80-year-old gentleman, a case of hypertension, COPD. Last month, while walking in his farm, he fell down and got hip fracture, to which he was hospitalized and hip replacement was done. Unfortunately, he got stroke 3rd day post-op, and asking Mrs. Khadija about daily activity of her husband, she said he needs assistance in bathing, toileting, wearing his clothes. He can feed himself, but he got shocking sometimes. He uses the wheelchair and he is afraid to move with a walker. His mood seems low and he sleeps a lot during the day and stays awake most of the night. This is the list of his medication. So what is the problem list of Mr. Jaber? If we consider the traditional approach, we would include that he has hypertension. We don't know anything about the control. He had hemiparesis. He is post hip replacement. He is in need for rehab. He has dysphagia and he has probably depression. If we include geriatric assessment, we need to assess meticulously the functional capacity of Mr. Jaber, the risk of fall, inquire about urinary incontinence, malnutrition, if there is any weight loss, dementia, caregiver burden, sensory impairment, because he had a fall, why he fell in the first place. Who should be involved in assessment of Mr. Jaber? Is it only us or there is another personnel involved? He should be evaluated by a speech therapist, nutritionist, physiotherapist, psychologist for the fear of fall, social worker for financial support and transportation. So probably from those 2 cases, you came to recognize what is comprehensive geriatric assessment. We know that globally, the population is aging. Saudi Arabia is no exception, and 2050, we are expecting to have 18.4% of Saudi population as elderly. Individuals are living longer with multiple chronic illnesses, making them vulnerable to disability and diminished quality of life. The family physician should be proficient in geriatric assessment because older adults will constitute an increasingly proportion of patients. So we have to be prepared. The definition of comprehensive geriatric assessment is multidimensional assessment aims at determining the medical, psychosocial, and functional status of an elderly. It consists of 6 core components. First, data gathering, team discussion, development of a treatment plan, implementation of a treatment plan, and monitoring and revision as needed. So it's not one-step procedure, it is a continuous procedure. Is there any evidence base that support the use of geriatric assessment or comprehensive geriatric assessment? Yes. There was an improved detection and documentation of problems in hospitals, home care, and clinic setting applying CGA. A meta-analysis of 29 trials showed that hospitalized older adults treated by a CGA team were more likely to be alive and in their own home 12 months after hospitalization. In a survey of primary care physicians in a preferred provider organization who had referred the patient for geriatric assessment, 69% of respondents agreed that outpatient CGA more fully assessed the physical, mental, and social needs of patients than the other consultative clinics. So what are the features over typical medical evaluation? We learned in our medical school history, physical investigation, and management. So the features of CGA that includes non-medical domains. It emphasizes the functional capacity and quality of life. It incorporates a multidisciplinary team. You are not the one only to assist your patient, the physiotherapist, the speech therapist, maybe the dentist, podiatrist, and so on. Number 4, it yields a more complete and relevant list of medical problems, functional problems, and psychosocial issues. Probably we were not used to do this. The team usually has 3 core components: the physician, the nurse, and the social worker. It may include physical and occupational therapists, nutritionists, pharmacists, psychiatrists, psychologists, dentists, audiologists, podiatrists, and opticians. So you may ask me, in a family medicine clinic, how can we apply it? By 2 ways: by asking patient and family to self-assess risk using pre-completed forms, and by using trained office staff to complete validated assessment tools. You may train your nurse; she can do the job before you meet your patient. Do I have to do it for all patients, for all geriatric patients? There are priority groups which deserve to have this CGA: those with multimorbidity, cognitive changes, functional status changes, frailty, risk of falling, medication non-adherence, polypharmacy, transition in care setting, unexplained weight, and family concern for safety. It is not, yes, it is not for those who have terminal illness, advanced dementia, and complete functional dependence, because you cannot improve much in such cases. What are the components? These are the 5 main components: the physical health, mental health, social aspect, functional aspect, and environment. There are elements in each one. What are the scales used? We have many scales, like in activity and dependence. We can assess ADLS using the Barthel Index, the CAS Index, Nottingham Extended Activity of Daily Living, and they have a special scoring rates. Cognition, we can use the mental examination, Montreal Cognitive Assessment, and for gait and balance, we use Time and Go test, Berg Balance test. Psychiatric and psychological, we can use Geriatric Depression Scale, Hospital and Anxiety and Depression Scale, Cohen Manifest Agitation Inventory. Some diseases have special scales, like Lindop score in Parkinson's disease and the National Institute of Health Stroke Severity Scale. Starting by functional status and falls, very important to know the concept of ADLS, activity of daily living, the very much needed strategies for daily living. They are eating, bathing, dressing, transferring, toileting, and walking. IADLs, these are the tasks needed for maintaining independence at household, like shopping, cleaning, managing finance and medication, and transportation. So to assess falls are common, but they are underreported. You can ask by a single question: have you fallen in the past year? Assessment, we can observe the patient coming to the clinic. We can use the Get Up and Go test, and longer than 12 seconds in Get Up and Go test is considered abnormal. Further assessment of the gait and the fall for those who are at high risk includes orthostatic vital sign, visual acuity, and gait balance test, medication review, and investigation of environmental hazards at home. The management, how we manage patients with falls. It's a multifactorial intervention with regular exercise, balanced training, minimizing polypharmacy, treating visual impairment, managing hypotension, and proper footwear. This photo summarizes all the management and prevention strategies. Polypharmacy, I will not talk about it since we have a separate lecture in that. Depression in older adults is usually present in atypical manner. He may not report sadness. He can have apathy, weight loss, cognitive impairment, like responding to questions with I don't know, especially when there is comorbid cognitive impairment. So the AFP and the US Preventive Task recommend screening only if there is assisted depression care, support the ability of accurate diagnosis and treatment and follow-up. Screening by HQ9, and further we can use BHQ2, and if it is positive, we can use BHQ9 for the diagnosis. Weight loss and malnutrition. Undernutrition associated with increased need for healthcare services and mortality, BMI less than 23. It's not like younger people, it is less than 23 is associated with increased mortality. Screening can be accomplished by a single asking question, have you lost weight in the past 6 months? Monitoring weight or asking patient or caregiver to complete mini nutritional assessment. Management, discontinue medication affecting appetite and weight, provide appealing food, ensuring social support, and offering feeding assistance. Hearing and vision. Hearing loss is common in elderly. The US Preventive Task and AFP, there was insufficient evidence to recommend for screening of hearing loss in asymptomatic patient. We can use whisper test for screening. Regarding the vision, decreased vision acuity increase the risk of falls, fracture, social isolation, and depression. So it's important to look for it. Common causes include macular degeneration, cataract, and glaucoma. Again, the US Preventive Task and AFP, the evidence was insufficient to recommend for or against, but there is little harm if you do it. Cognitive impairment rates increase with age. In primary care, impaired cognition may be unrecognized in up to 81% of affected patients. We have a separate lecture about this, so I will not go in details. Urinary incontinence is very important, very much common, especially in females, but it's not reported. We have 2 questions. In the past year, have you ever lost urine or gotten wet? Number 2, if no, if so, have you lost your urine in these 6 separate days? Immunization. It is an opportunity to give immunization, preventive immunization to our patients if they come at the clinic. There are 4 immunization important in geriatric. They are influenza, TDAB vaccine followed by TD every 10 years, the pneumovax 13 at the age of 65, and then 23 1 year later, and 2 doses of zoster vaccine. Advanced care planning, probably our system in Saudi Arabia is not supporting of that, but just for your knowledge, you can take the perspective of your patient regarding prolonging life, maintaining independence, preventing illnesses, relieving suffering, and maximizing time with family and friends. And this website provide pre-formed forms can be filled by the patient. So after we have collected all the parts of the physical, social, and mental assessment of the patient, we have to write a problem list and should be updated annually by identified geriatric assessment, and care plans should be modified based on the patient goals. So the take-home message, comprehensive geriatric assessment is defined as multidimensional assessment aims at determining the medical, psychosocial, and functional status of an elderly. It has advantages over traditional medical approach by including non-medical domain, emphasizing the functional capacity and quality of life, incorporating multidisciplinary team. It has 6-step data gathering, team discussion, development of a treatment plan, implementation of the treatment plan, monitoring, and revisiting as needed. These are my references. I would like to thank you for your attention. Now we would like to welcome our teacher, Dr. Ibtisam Baisa. for a special lecture about insulin. Welcome, Dr. Abdesam.
Bismillah ar-Rahman ar-Rahim. Dear guests and colleagues, I would like to welcome you all, and I would like to thank the organizing committee for giving me this opportunity. And I'm going to talk about the right insulin, right time, right dose for type 2 diabetes. This is my disclosure of relation, and this presentation is sponsored by Eli Lilly. And this is objective, and in view of the limited time, 15 minutes, so I have hardly time to talk about insulin. I will be focusing on insulin initiation and intensification to premixed insulin, and this should be continuation to Dr. Saleh lecture that you have heard today morning, applying the current recommendation and guidelines, and it will be based on 2 case scenarios. So I have to start with this, and I think you are all aware without any doubt that tight glycemic control early and aggressively reduces all risk of complications. And this is what we call the legacy effect or metabolic memory. I think you are all aware about this. So the earlier you do it, the better is the outcome. And I have to stress on this as well, and Dr. Saleh have already talked about it, is we have to avoid the clinical and therapeutic inertia. So we have to adopt a proactive management and intensive early combination approach rather than the reactive management. And this is what we call the reactive management, is we wait for the blood glucose or A1C to go really high, like 9 or 10, before we add another drug or intensify our treatment. And by then, your options for treatment is really limited, and you have no option except adding insulin, and you may need to do even multiple daily injection of insulin. And with that, patient already may be having already complication. And with this regimen, you may predispose your patient even to more complications and side effect, as has been seen with the study. So what we recommend is to adopt what we call the proactive management. So for any rise of the A1C, you should take an immediate action by adding another drug, whether it's oral or injectable, whatever suitable for your patients, to keep and maintain the glycemic control within the set target. You have to achieve your target not more than 6 to 12 months. It does not mean that I have put 12 months and then achieve, but it should not exceed 12 months. So we know all the treatment options and selection. One size does not fit all. And that's what makes diabetes unique, because there is no rules and the treatment will differ from one patient to another. And we know that insulin remains the most effective treatment up to date. And we have different types of insulin, and the selection will depend whether you want to target fasting only, postprandial only, or both, or one of them more than the other. So the selection of the type of treatment will depend on that. So insulin, as you know all, is ultimate treatment in many people with type 2 diabetes, and over time, many people will require insulin. So you should add insulin whenever is required without any further delay. We are lucky now to have newer options of insulin with the insulin analogs that have shorter duration of action and faster and longer action with basal insulin. So with that, you will be able to achieve your target with less hypoglycemia and weight gain as used to be with older types of insulins. So any people with type 2 diabetes, these are the scenarios of insulin categories that any patient with type 2 may be on alone or with oral medication or other injectable. They may be either on basal insulin or basal insulin plus bolus or basal bolus or basal plus, or premixed insulin or basal plus GLP-1 receptor agonist. I'll be focusing today about the premixed insulin in view of the time. So I'm going to have you here with 2 case scenarios to discuss how to initiate and intensify to premixed insulin. So our first patient is 65 years old man with type 2 diabetes. He has no cardiovascular or renal disease. BMI is 24. He's currently on the classical treatment, sulfonylurea gliclazide, metformin, and sitagliptin. And his latest A1C was 10.5, and glucose home monitoring, as you've seen here, he has high fasting blood glucose and high postprandial for dinner. So classically, what would you do? Audience? You add What type of insulin? Usually this is the classical and easiest way is to add basal insulin. So this is what the physician have done. He added basal insulin 10 units and up titrated it to 26. With that, you can see his fasting blood glucose now is at target. However, his postprandial still is high. And your patient actually tell you that I don't want to take any more injection. And his A1C is 8.5 now. So what would you do next now? You have the option, and this is a poll question. So we'll have a question from the online audience. Intensify basal insulin to basal +1. Switch basal insulin to mixed insulin analog once daily before dinner. Add GLP-1 receptor injection, or change basal insulin to mixed insulin twice daily, or intensify to basal bolus regimen and stop sulfonylurea. So this is a poll question. So we can have the poll question now. And also the audience, you think about the right answer. What answer do you think is the most appropriate in this patient? So are we having the poll question? Oh, okay, I don't see it here. So we have different options. So the audience, what do you think is the most likely here? Okay, I've just been starting 10 minutes. Okay. So what would be the appropriate? Audience, this patient refused to take an injection, yes? Raise your voice. What option? الخيارات? Yeah, it's okay. So they have different options, right? Right? So what do you think yourself? Basal plus prandial? Because this patient refused second injection. Classically, this is what you do, is you add prandial. Yes, now I have the results here. So the majority answered A, adding prandial. And this is actually the classical, but you have to appreciate that the patient refused to take another injection. So the right answer here will be to this patient is you switch him to, can we have the, yeah, is to switch him to premixed insulin, from basal to premixed insulin. With that, he will be shifted to a single injection. And I'm going to discuss with you how to do that. We know that basal insulin alone does not provide meal coverage. And the patient has to have strict predictable meals in order to have good glycemic control. And we know without any doubt that postprandial is also important to achieve A1C targets, especially if the patient consumes large amount of carbohydrate. So we know that the first option as classically is adding basal insulin to oral agent. However, and also intensifying it from basal by adding prandial, and then you can progress from there. This is one option, and this is a commonly used option. Another option, and this is also in the guidelines, from basal, you add prandial. However, the latest guidelines again emphasizes that you can initiate and intensify to premixed insulin once or twice daily. So this is in the guidelines and recommendation. So option 2 for initiation is with premixed insulin once daily. And also you can intensify from basal insulin to once daily or twice daily premixed insulin that you can also up titrate and intensify further to 3 times daily of premixed insulin. So premixed insulin is commonly used, target both fasting and postprandial. It lacks clear practical guidelines. Which insulin, which premixed insulin? Now we are lucky to have the analog premixed insulin. We have the Aspart Novomix 30, and we have the Lysobro Humalog Mix 25 and 50. And as you can see, as compared to the human insulin, they are more physiological with faster action and better control. They have the advantage is that they can be injected immediately or 15 minutes before the meal, and they can be given up to 3 times daily. So also studies have shown that comparing basal insulin to Aspart mix, the mixed insulin can achieve targets safely with less also hypoglycemia and weight gain as reviewed by many studies. The advantage of mixed insulin is that you can provide the basal, the fasting and postprandial coverage with less number of injection. However, it lacks the flexibility of the injection or dosing, as well as it requires consistency of the meal. So we have discussed the 2 options for initiation, basal versus premixed insulin. So how would you select the best option for your patient to initiate with basal or premixed insulin? Let us assume this is a blood glucose profile for our first patient with fasting of 180. And as you can see, his postprandial is really high, almost 300. So the difference between his postprandial and fasting is more than 50. And this is what we call postprandial glycemic excursion. So if you target, and this is another scenario, blood glucose profile in yellow, fasting is the same 180, but his postprandial is really around 200, 220. So the postprandial glycemic excursion here is small, less than 50. So if you target your fasting blood glucose, for example, with basal insulin, and as you know, from 180 to 100, that will bring the whole curve down. That includes also the postprandial. So in the second scenario, maybe basal insulin alone will be enough to control his fasting and postprandial. But in the second scenario, as you can see here, if you give him basal insulin, you know that basal insulin will not be enough to bring his postprandial to target. So definitely you will have to add prandial insulin or start with premixed insulin from the beginning. So you can predict which patient will do well on basal alone or with basal plus prandial or premixed insulin. So how to initiate with premixed insulin, starting by 10 units as usual, adding it with the main meal of the meal with the highest prandial load, or to target fasting if it is high, or target pre-dinner if it is high, by adding it at morning or evening. And then you titrate your dose by increasing it by 2 to 4 units, at least 1 to twice weekly. And then our time is running 5 minutes. Maybe you can give me a little more because it's interactive. Anyway, and if the dose exceeds 30 minutes, then you have to split the dose to 50-50. So if the total daily dose exceeds 30 units, then you have to split the dose. Then that will be too much for one dose. Then you split either to 50-50 or 70-30 or 30-70 based on the blood glucose profile. So this is our patient who was in Lantus, 26 units. He was switched to premixed insulin, 26 with dinner, and he was reinforced to have consistency of the meal, especially with dinner. An alternate way, instead of starting with basal, then titrating, then adding prandial, or switching from basal to premixed insulin, you may initiate immediately with premixed insulin, because you know that this patient will require prandial. Instead of giving 2 injections in 4 steps, you may do it in 1 injection in 2 steps only. And then you titrate the dose as required. Titration, as I mentioned, every 1 to 2 weeks by 2 to 4 units. You don't combine basal insulin with premixed insulin in the same patient, okay? That increases the risk for hypoglycemia. You can titrate to 3 injections of premixed insulin, or you can give 2 mixed insulin with 1 prandial in the other meals if required. Sorry, I'm fast for the time. So we have discussed this first patient who was on basal insulin, refused to take another injection. He was switched from the basal insulin to premixed insulin once daily, and the dose was up titrated to 30 units before dinner. And with that, and also his dimicron was reduced because of the risk of hypoglycemia. And with single injection, he was at target for his fasting and postprandial. So now quickly, we'll also discuss that you also can intensify from basal plus or basal bolus to premixed insulin, and also from to premixed insulin twice or 3 times daily. And this is again in the guidelines, as you can see here. How do you switch from basal plus to premixed insulin? You calculate the total daily dose. If you are concerned about hypoglycemia, you reduce it by 20%, and then you divide it commonly to 2 injections, and you give 50% of that in the morning, 50% in the evening, or 70-30, 30-70, based on the blood glucose profile, and then you titrate the dose as usual. The third option for initiation is with GLP-1 receptor agonist, especially if A1C is near target and you are concerned about hypoglycemia, weight gain, and you want to address cardiovascular and renal benefit. Our patient refused to add another injection to basal insulin. So the alternate, you may give him the fixed combination ratio of GLP-1 receptor agonist with basal insulin. Now we have 2 drugs in this class, Disoltofy and Soliqua. What about oral agent? Definitely you have to continue with all oral agents. Sulfonylurea, you need to reduce the dose. When you add 1 prandial, if you add the second prandial, then you have to stop. DDP4 inhibitor should not be combined with GLP-1 receptor agonist. So our second patient is a 71-year-old man known to have diabetes, on mixed insulin 70-30. He is on 44 units in the morning and 36 units in the evening. And and 36 units in the evening. And he actually consumed large amount of carbohydrate, and he complains of frequent hypoglycemia. And you can see A1C is 9.4. He has hypoglycemia in the morning, post breakfast, high blood glucose, and post dinner, high blood glucose. So what would you do with this patient? Poll question: change to basal bolus, increase AM and BM premixed insulin to 70-30. Increase the dose, change to mixed insulin 50-50 twice daily, stop insulin and start glimepiride, DDP4 inhibitor, and metformin. So poll questions, and also the audience, I need your opinion. What do you think? What would be the most 50-50? Any other options? Okay. Okay. Okay, so I can see also the online people, they still also favoring the 50-50. So I think, can we stop? عشان الوقت بس لأنه الوقت فعلا قصير. So I think what you have suggested is 50-50. I think many people have suggested that as well and from online. So 50-50 would be the appropriate answer, as you mentioned. Basal bolus will be another option actually, but 50-50 you may achieve your target with less number of injection. So at any time you may switch from premixed insulin to basal bolus, and we know that this is in the guidelines as well. And we know that premixed insulin requires constant meal and does not permit flexibility with the dosing. However, the basal bolus, although it has increased number of injection, but it has more physiological and more adjustable dose. How would you do that? Change from premix to basal bolus or basal plus. You calculate the total daily dose, okay? And you give 50% of that total daily dose as basal, and 10% of that total dose you give it as brandial, whether once, twice, or 3 times daily. And then you titrate the dose as usual, and then reduce the dose if you are concerned about hypoglycemia. So our patient was on premixed insulin 70-30, 44 units in the morning and 36 in the evening. Total daily dose is 80. So 50% of this 80 will be 40, so you give it as basal, and 10% of the 80 will be 8 units, so you give it as bolus, whether before breakfast, dinner, or lunch. But this patient has mainly breakfast and dinner, which is high, so it's enough you give it at those 2 meals. If you are concerned about hypoglycemia, you may reduce the total dose. So this patient was switched to basal insulin 40 and brandial insulin 8 units with breakfast and dinner. As I mentioned, you reduce the dose if you are concerned about hypoglycemia, and actually this is in the guidelines. You may switch from low mix 70-30 to high mix 50-50. What is the difference? 70-30 provide more coverage on the basal insulin and fasting blood glucose and less on the brandial, and increases risk for hypoglycemia and hyperglycemia, while 50-50 provide equal effect on both the brandial and the fasting. So target pre-meal more than postprandial with 70-30, equal target fasting and postprandial with 50-50. And sorry, I'm rushing because I know that you are in rush. So if we assume this is again a patient with blood glucose of fasting 180, he consumed large amount of carbohydrate, very high postprandial above 300. And this patient, if you bring his fasting blood glucose down, even with 70-30, 70-30 contains little amount of brandial. So this will not be enough to bring his blood glucose to control, as compared to another patient with postprandial glycemic excursion again, but is not as high as the first one. So in the yellow patient scenario, probably 70-30 will be enough, while in the green one, 50-50 will be adequate. And also studies have shown that this is an option to switch to 50-50. You can get target A1C without the need to switch to basal bolus, also studied in Ramadan. And this is how you switch. It's 1-to-1. And then you titrate from there, okay? If the dose is more than 30, then you need to split your dose if it is 1. So our patient, he will switch from 70-30 to 50-50, the same dose. Also, another way is you may calculate the total daily dose and reduce it by 20%. So that will be 64% if you are concerned about hypoglycemia, and our patient had hypoglycemia. And then you split it to 50-50 with breakfast and dinner, or 70-30 with breakfast 70 and 30 with dinner. Our patient, actually, this would be more suitable, 70-30, because he had hypoglycemia. We want to reduce the hypoglycemia. And also his postprandial for breakfast is higher than his postprandial for dinner. Again, consistency of the meal is important. So with that, I will conclude. We have discussed in the second case, this patient was switched from low mix to high mix insulin, and with 2 injections, he was able to achieve his glycemic target without the need to go into basal bolus. So take home message, in conclusion, we have discussed the 3 options for initiation. You may use GLP-1 receptor agonist if your patient is near target. You want to address cardiovascular and renal benefit, minimize weight and hypoglycemia. Basal insulin will be good if you want to target fasting and postprandial glycemic excursion is less than 50. Premixed insulin will be good if you want to address both fasting and postprandial, and the postprandial glycemic excursion is more than 50. After initiation, we have discussed the 3 options for intensification, either adding basal, bolus to basal, or switching to premixed insulin, or adding GLP-1 receptor agonist. Of course, you can continue or add any other drugs as long as it is from different class of treatment. Also, we have discussed the low mix and the high mix. The low mix will be good if you have, if you want to target fasting more than postprandial, and the high mix would be suitable if you want to target both fasting and postprandial equally. We have discussed the first patient, how to initiate and switch from basal to premixed insulin, and we have discussed the second patient, how to switch from low mix to high mix insulin. With that, ladies and gentlemen, you should always consider the general condition of the patient before you initiate the insulin regimen and select the device. Premixed insulin is a good option for to switch from basal and also from basal bolus, and high mix also is good for patients whom you want to address the postprandial. And selecting the appropriate treatment for the appropriate patient at the appropriate time result in achieving your target safely at reduced risk for complication in the appropriate time. With that, I would like to thank you and sorry for taking more time. Thank you very much.
Thank you, Dr. Ibtisam. Now we have Dr. Amani Shaban giving us a lecture about polypharmacy in geriatric. Dr. Amani is a senior specialist pharmacist in pharmacology and toxicology, and she is the pharmacy director of Saudi Al-Babtain Cardiac Center and head of drug tracking system and Saudi Food and Drug Authority. Welcome, Dr. Amani.
Good afternoon, everyone. It's a great pleasure to be with you in this very fruitful conference. And I would like to thank the organizing and scientific committee for the kind invitation. As we all know, that the presence of the multiple chronic conditions will increase the complexity of the medication management for both physicians and the patient, and impacts negatively on the patient outcome. Knowing that almost more than a third of our old patients are taking more than 5 medications, and 25% of the adverse drug reactions as a result of this polypharmacy is preventable, put a big burden on our shoulders as healthcare professionals to tackle this issue as a polypharmacy when the good drugs lead to bad outcome, to find a solution to improve the patient outcome. So during my talk, I will focus first about the problem itself, what's polypharmacy, how we can tackle it, what's the risk factors, and the consequences out of that. Then we will go to the approach that we can use and the assessment tools when we are dealing with the polypharmacy, and I will end up with some take-home messages. So at first, by definition, polypharmacy is a common healthcare problem. We all know that almost 40 to 50% are observing and dealing with this problem in daily practice, and as much as the medication increase, the adverse drug reaction is increasing exponentially. According to the literature, a systematic review has been conducted because there is no clear definition of polypharmacy, and many of the healthcare providers is defining like how many is too many. It's differ from one person to another. One is saying more than 5, one is saying no, it depends on the patient condition, and so on. So according to the systematic review, different definition has been used as the co-prescribing of multiple medication, the inappropriate use of medications in general. So they are focusing on the use, not the number. The using medication without clinical indication, like the over-the-counter medication and herbals. But they all agree that the use of more than 5 medication is considered as a polypharmacy. Approximately 4% of older patients is taking more than 5 to 9 medication. And we all know that as the patient is aged, more health condition is bringing to the surface, like hypertension, diabetes, and we have this mixture for most of our patients. And also approximately 18% of the older population are taking more than 10 medication, and it's called hyperpolypharmacy. When we are tackling those two issues, we will tackle it differently. taking more than 5 medication is different than taking more than 10, and making in consideration that those patients are 65 years and older. So when we come to the definition of taking that one patient is taking more than 5 medication, are we saying that all patients, we need to consider it as a problem? Of course not. There is appropriate polypharmacy. We know that there are many treatment guidelines stated that 1, 2, 3 is the medication or the medication that the patient should be on based on the optimization of the benefit outweighing the risks, or it will improve the quality of life, or it's more system for the symptoms control, or it's an evidence-based. You cannot go or oppose the line. But in the same time, even if it's appropriate polypharmacy, we cannot ignore that there is increase of possibility of adverse drug reaction, because each patient will react to his medication, even if it's evidence-based, differently. Now, our problem, when it's a problematic polypharmacy, when the harm is exceeding the potential benefit, when there is misunderstanding, when there is medication that shouldn't be on the list of the medication treatment. Why we are concerned more about old population than the younger one? Because normally there is a physiological changes when we are aging, okay? So according to the pharmacokinetic properties of the body, the absorption will be changed, distribution will be changed, metabolism and excretion. We know that the absorptive service will be decreased. There's alteration in the gastrointestinal motility and the pH, and we can imagine if any patient is taking medication that's affected by the pH of the body will be changed accordingly. In the same time, also there is a decrease in the total body water and increased fat as the person is aging. Also, there is a reduction in the liver activity and enzyme activity, and also the excretion, which is a major issue. So in general, the change in the physiology, how the body will act on the drug will be changed, and also how the drug will act on the body will be changed with age. What are the risk factors? When we come to the risk factors, we have to differentiate whether it's the patient issue or the system issue, because whenever we have a polypharmacy as an issue or adverse drug reaction or medication error, and we do the root cause analysis out of that, where was that problem comes from? And that's why you need to focus on the problem and the risk factor out of that. So as a physician in the clinic, it will highlight for you if the patient is aging, is more than 62, he has cognitive impairment, he has developmental disabilities, frailty, mental health condition. Many of the patient has multiple conditions like coronary artery diseases, diabetes, hypertension. All of this will give a hint that he is more at risk of polypharmacy than the others, and especially if he has been seen of multiple specialty, which is the reality. So as a consequences of that, what will happen to our patient? The patient will have a decrease in quality of life. It will decrease the immobility issues, increase the mortality and morbidity as well. The patient will have a lot of experience falls, frailty, disabilities, and medication non-adherence, because he has plenty of medication that he has to remember to take every day. The other thing that we need to tackle when we are talking about the polypharmacy is the health system. Health system will play a major role in that. If we don't build a great or safer practice system, we will fail that and we will be part of it. So the risk factors for polypharmacy that concerns the health system, if we have poor medical record keeping or poor transition of the patient, we just send the patient somewhere and he is taking another medication from another place without any follow-up, prescribing to meet the disease-specific matrix, and the use of automated refill system. We think usually that the technology will help us. Technology is helping us when we utilize it wisely. we are the one who should control it, not the other way around. And on consequences of that, there will be a decrease of physician's function and productivity, and increases medication error. And on top of all of that, increases the expenses on the healthcare system. According to the cohort retrospective study, a polypharmacy contributes to increased risk of outpatient visit, hospitalization, and approximately 30% increase in the cost. And this is too much when it comes to people who doesn't have insurance or health insurance, and they need to follow up with the private sectors, and even for governmental sectors, it's too much money that we need to consider when we are considering the budget need for each patient. So what do we need to do? We can adopt the de-prescribing approach. The de-prescribing approach is the process of initially stopping medication or reducing it to improve person health outcome and decrease adverse effects. So we need to make in our mind our goal. Our goal is to decrease the possible adverse drug reaction, more patient understanding and adherence, and this will help in correcting polypharmacy and prescribing cascade. How we can tackle this? First of all, it's very important to know the patient medical history. As I mentioned in the beginning, there's appropriate and inappropriate. Without knowing the patient medical history, you will never know whether it's indicated in his treatment plan or not indicated, whether he will follow you after you are saying that you will delete some medication off his list or take some medication from his bag and buy it over the counter when he leaves you. So it's very important to sit with the patient, understand and tackle all aspects. Second thing, you need to have and mention all possibility that the patient might think about: over-the-counter medication, herbal medication. If he has a bag, don't ignore single medication that's in the bag. Also, you need to remember whenever you are reviewing the medication, the indication for each. And it's the easiest thing to delete and start deleting medication on the list by knowing if there is any medication without any indication. And you have to verify and assess the patient adherence. So whatever you are planning to do, if the patient is non-adherent, or the problem may be because he did not adhere to his medication, so you are not solving a problem and you will start from the beginning. You also have to consider the functionality and life expectancy and the cost of the medication. So the de-prescribing is a systematic process to identify and discontinue medication in which existing or potential harm outweighing the potential benefit of the individual, making in consideration the current level of functionality, life expectancy, values and preferences. The physician should identify and prioritize the medication to discontinue and discuss the potential de-prescription with the patient. You need to align whatever you are planning to do with the patient from the beginning till the end. You cannot plan it yourself without hearing the patient or his preference. So the approach includes either discontinuing medication, decreasing, or alternating the medication. After reviewing patient existing medication, we have to avoid duplicate medication for the same indication before assessing the patient adherence. And we have to avoid adding any other medication before assessing the patient adherence, and also if he is more than 5 medication. And you can use a general tools that's been used worldwide, like Aroma, where you will assess, review, minimize, optimize, and reassess again. And they call it the implicit tools, medication appendix, appropriateness index, the Pierce criteria, stop-start criteria, fit for the age, and no tears. All tools are there for you to use, but we need to consider that there's no validated tool or strategy has been proven to be superior on top of the others. Sometimes it's explicit, sometimes implicit, and sometimes mixed. And you as physician, you might use too many tools in order to eliminate any adverse drug reaction that might be happening to your patient. So as explicit tool, explicit means it's clear. So it will be a checklist and you will know what to delete and what not to delete. We need to consider that by using these tools, the patient complexity is not considered in decision-making. And that's why sometimes you need to have both ways. As an example of those, the Beers stop and start criteria. I will start quickly by stop criteria. I know that it's not much used as Beers, but it's worth mentioning because it has a valid strategy that it might be useful in sometimes. So it's a medical review tools designed to eliminate any medication to that risk overweighing the benefits by reviewing the list of the medication for any duplication, if there is medication disease interaction, or if there is a medication that needs or required adjustment. Both stop and start criteria used together usually to identify medication that may be inappropriate, so it will be stop, and alternative medication that can be added or started and more appropriate to the patient's statement. This is just the abbreviation of the stop and start screening tool for older patient potentially inappropriate, and the start screening tool to alert doctor to write treatment that is appropriate to the patient. The second tool is the Beers criteria. It's actually a tool started by Mark Beers in 1991, and it's been updated and reviewed by American Geriatric Society over the year. And I believe that most of you are using it in your clinic. And the most important for this is to use the updated one as it's frequently revised over the year. The criteria is including over 50 medication designated in one of the three categories, either those that should always be avoided or those that are potentially inappropriate in older adults with particular health condition or syndromes, or those that can be used with caution, and will give an alert on what to start and how to start deleting that. The tool is available in the booklet guidelines for the guidance of the American Geriatric Society of Beers criteria, and it's available as a tool that can be used and implemented in daily practice. A tool is to assess healthcare providers in improving medication safety for older patients, and the rule of that is to give the inform the clinical decision-making and all people, including researcher training, on how to optimize the best medication in the patient treatment. And you can find it actually in their websites, as well as a hard copy that you can buy it. So the goal of using Beers criteria is to improve care of old adults by reducing their exposure to potentially inappropriate medication. This should be viewed as a guideline for identifying medication for which the risk is outweighing the benefit, and the list is not meant to be or to replace clinical judgment. And this is very important. You need to customize your need based on your patient that's in front of you, not based on a paper that you are ticking. Prescribing and managing disease conditions should be individualized and customized. The booklet is tackling the major medication that causes harm. When you are looking to that categories, it contains like about 8 tables. Anticholinergic medication because of the delirium and memory loss that they might cause, the sedative and anxiolytics, narcotics, cardiovascular medication, and list of miscellaneous medication that can be used as well. As we are in the technology era, and to make it easier for you, there's an application that you can install it in all of your phones. It's called the AGS, which is American Geriatric Society iGeriatric application, and it's easily to implement it in daily practice. Other tools, which is implicit, it needs more clinical judgment, but it's more time consuming. It contains many questions like the medication appropriateness index. With all of that, it's easy to talk, it's hard to implement. Do you agree with me? We wish to optimize and to apply best practice and best safe practice for our patient. But we always have problems with the time. The time is constrained for the physician and for the patient as well. And also the patient may be reluctant to discontinue any medication. That's why I told you that we have to sit with the patient at first and see his preference, or maybe other patients are reluctant to stop any medication that's prescribed by other physician. And this is our problem. And that's why it's very important to align your goals as physician wherever you are. And I think the kingdom are going through this. I will talk about it in a while. Another problem is the lack of system support. So whenever you have a chance as a leaders or people who can update the system for the patient safety, please do. And don't be hesitant to change anything, because changing is difficult in the beginning, but when we think about our goal and patient safety, everything is possible. I think, and I believe that major challenges for you physicians is feeling the pressure in a single visit to tackle the patient condition, his family needs, what I need to do. And that's why there is a collaborative, as Dr. Nada, I think, or okay, Dr. Nada mentioned earlier that there's a collaborative efforts by the others, and without that, actually it will save time for everyone and tackle the issue and save the patient from any adverse drug reaction by, for example, virtual clinics. Another tools that can be used and facilitate work as well is the prescribing algorithm, and it's ready. You can print it, you can put it in your office. Just whenever you have a patient with proton pump inhibitor, half of our patients are on Nexium and they don't have any problem with their stomach acidity or having any problem. Benzodiazepine receptor, antipsychotic description, deprescribing algorithm, and anti-hyperglycemic deprescribing. I think it's a very good tool to use. And this is just an example just to see if you can use it in the future. As we are in the technology era, implementation of technology is important, and utilizing it wisely is more important than using it. And whenever you have a health information system, we know that polypharmacy, the starting point actually is to take the best possible medication history, which is called as a medication reconciliation process. So whenever you have a system also to support that, like therapeutic reconciliation program within your system and the health informatics that supports this will decrease the possibility of polypharmacy. I will end up with the vision of 2030 as the Council of Cooperative Medical Insurance with the Ministry of Health are working hard, and actually it's yearly will be launched within the next year, hopefully. But they agreed on that they will have a unified platform called Nafis that will connect all the patient all around the kingdom with one file, and this will actually help a lot in decreasing the polypharmacy, because no single pharmacist will be allowed to add a medication without seeing that there is a duplication from another physician from different specialty. So some take-home messages that I want to conclude with is that the Beers and STOP criteria are here to guide, not to give or delete the clinical judgment. We need to take your time. You need to take your time with the patient to tackle all sources and ask about the things that he is not telling you, because believe me, you will be surprised of the things that's hidden, not on the bags in the house. Consider the risk and the benefit before any decision. It's very important to build a trustful relationship with the patient. In my work, I believe that whatever comes from the heart touches the heart, and what the patient needs is the care. And whenever he feels that you care about him, believe me, he will go back home and remember what you are saying. So even with the availability of technology, you are the final decision makers, And don't underestimate the consequences of polypharmacy, and always think of the quality of life of older patients because they are precious to someone else. Thank you so much. And thanks.
Thank you, Dr. Amani, for this excellent lecture and for being on time. Next speaker will be Dr. Leila Dahnin. She is a consultant in internal medicine and geriatric in Qatif Central Hospital, and she will be talking about management of dementia in primary healthcare. Welcome, Dr. Leila.
Assalamu alaikum, everyone. Thank you for the organizing committee for giving me this opportunity to be here with you today. I'll be talking about important topic here about the management of dementia in the primary healthcare. I will first review a dementia case. By the end of this talk, we'll be able to learn how to define dementia, to differentiate between mild cognitive impairment and dementia, differentiate between dementia, delirium, and depression, recognize common presentations of dementia, and learn how to assess and manage dementia in primary healthcare setting. I'll start with a case history here. This patient was brought by her daughter. This patient is 72 years old, was brought to your office. She noticed that she has been increasingly forgetful and indicated that there has been gradual memory decline for the past 4 years. Now the patient quickly forgets conversation and misplaces items, which result in her thinking that people must have moved or taken the items. She also has difficulty finding words. You, as her primary care physician, has noticed also that the patient missed 2 previous appointments. Her daughter indicates that her mother has gotten lost in a familiar neighborhood. Sometimes she doesn't seem to recognize people that she has known for years. The patient's family also reported that the patient's memory for long-term information seems a bit fuzzy. For example, it was stated that the patient remembers vacations from the past, but when talking about them, she seems to mix up details from various vacations. The patient is not particularly concerned about her difficulties, and she is not all that interested in treating her memory decline. Her daughter, however, is quite concerned. Review system revealed that the patient has become slightly withdrawn, occasionally more angry and irritable than usual. Her sleep and appetite are okay. Her past medical history is significant for knee osteoarthritis, dyslipidemia, diabetes, and vitamin D deficiency. She is on atorvastatin, metformin, weekly vitamin D, and over-the-counter paracetamol. Her family history was unremarkable. Her functional history, she remains independent for her activities of daily living, including bathing, dressing, grooming, toileting, and feeding. She recently needs prompting to take medications. Her housework is done recently by a paid caregiver. Finances and transportation are assisted by the family. Social history, she lives in a 2-story house with her husband. She has 1 daughter who's a nurse and a younger son. She's a housewife and had secondary school education. She never smoked. Her physical examination findings, she appeared all female, appeared her stated age, fully conscious and alert, well nourished. There was no evidence of depression or psychotic symptoms. Vital signs were stable. Her neurological exam was pertinent for normal muscle tone and power with no suggestion of cerebellar dysfunction. She had normal gait. Her speech was fluent with obvious word finding difficulties. Her general exam was unremarkable and she had normal vision and hearing. This is her initial mini-cog or mini-cognitive test. It was abnormal. She got 1 of 3 words and she had abnormal clock drawing. When she was asked to draw a clock with all the numbers and the hands pointing to 10 after 11, she got this. Her initial investigation showed normal CBC metabolic panel, B12, TSH normal, were normal, A1C was 6.8. She had a brain CT that showed age-related atrophy with mild microvascular changes. I think there was a question here, but it's missing in this slide. So what do you think is the diagnosis in this patient? Is this dementia? Is it delirium? Is it mild cognitive impairment, or is it depression? Anybody wants to answer this question? Yes, this is a straightforward history for a patient who is developing dementia. So here I will, there are three diagnoses that interact actually: delirium, dementia, and depression. Very common entities in older adults. They interact, they are, when present, they are not mutually exclusive, i.e. You can have delirium and you can have dementia at the same time. Delirium is a risk factor for dementia. Patients with dementia are at higher risk to develop delirium. Depression also is common in patients with dementia, and it's a risk factor for dementia. And delirium itself can be misdiagnosed as depression. So how to differentiate between the three entities? In terms of the onset, delirium is acute condition, dementia is insidious, and depression has variable onset. In terms of duration, delirium lasts for days to weeks, dementia lasts for months to years, and depression duration is variable. In terms of the course, delirium has fluctuating course, that's typical for delirium. Dementia is insidious and slowly progressive, and depression has diurnal variation. In terms of conscious level, delirium is characterized by impaired consciousness, while dementia, the conscious level is usually intact, and depression, the conscious level is unaffected. In terms of attention and memory, delirium, usually patients have inattention with poor memory, while attention is intact in dementia and intact in depression. The effect is variable in both dementia and delirium, but usually patients with depression will have depressed affect. So what is the definition of dementia? Dementia is simply defined as a disorder of cognition, usually affecting multiple cognitive domains that results in social and occupational dysfunction. In a simpler term, it's an umbrella term that describes condition characterized by impairment cognition and behavior and in personality. This leads to social and occupational dysfunction. It usually progresses at an insidious rate. It cannot be explained by an underlying medical or psychiatric condition, and it represents a decline from a previous level of functioning, distinguishing it from a learning disability. The highlighted words here are very important. To define dementia, you have to make sure that it fulfills the criteria. And our patient, she has multiple cognitive impairments in different domains like short-term, long-term memory, visuospatial, and she has affected social and occupational function, and this is different than her previous level of functioning. So the next question is how to differentiate between dementia and MCI. Mild cognitive impairment, it's an early stage of cognitive change. You can consider it as the intermediate stage between normal aging and dementia. Here, the patients or family members notice change in thinking and memory or cognition. The impairment is documented by formal testing. The patient is still able to independently carry out daily activities. People with MCI are more likely to develop Alzheimer's disease or other dementias than people without MCI. Another important thing about MCI is that it is a potentially reversible condition and can occur in the setting of some medications that can affect cognition in patients with delirium, post-delirium or post-acute hospitalization. This is the continuum of cognitive impairment. As you see that it's cognitive impairment can range from mild cognitive impairment until severe dementia. Patients will progress differently. The impact of cognitive symptoms will be different in different patients. So what are the commonest causes of dementia? Alzheimer's disease accounts for 60 to 80% of cases. Vascular dementia is also another common cause. Mixed dementia, i.e. a combination of two pathologies like vascular and Alzheimer, it's quite common. Dementia with Lewy body and frontotemporal dementia. So how would these patients present? People with dementia can present with problems in cognitive function, such as confusion, memory loss, problem planning, reasoning. They will have emotional control issues like mood swings, personality changes. Patient who is usually socially active may become like withdrawn. They may have apathy. Changes in behavior like wandering, aggression, agitation, repetitive behaviors. Patients may present with also physical health problem like incontinence and weight loss, and they will have difficulty in performing daily activities, such as their ability to cook, do housekeeping activities, manage their medications, and also their activities of daily living like bathing and dressing, etc. So how do we assess patients with dementia? In history, you will document the cognitive domains affected. Like in our patient, she had short-term memory, she became repetitive, she has issues with long-term memory, she has issues with getting lost, i.e. visuospatial function, she has difficulty in her basic activity and advanced activities of daily living, i.e. she had difficulty with like executive function. You always need to interview the patient with a family member, and you need to have an informant-based history, i.e. from a close family member or a friend. You need to document the time course of the onset and progression of cognitive and motor symptoms. Also document the time course in the impairment in social and occupational functioning, as evidenced by impairment in the activities of daily living and instrumental activities of daily living. We always need to screen for depression and to exclude delirium in all cases. In history, we can review possible risk factors, including advancing age and history of head trauma, late onset major depressive disorder, a few years of formal education, risk factors for cardiovascular disease. Family history is relevant in patients with young onset dementia, i.e. patients who have cognitive impairment below 65, as rare forms of familial Alzheimer's disease exist. The most important aspect in physical examination that you need to focus on are the neurological exam findings, including the gait. You will find gait abnormalities in patients with normal pressure hydrocephalus, in patients with Lewy body dementia. Also, identify the presence of any focal deficits like in vascular dementia. Also look for extrapyramidal signs like rigidity, tremor, bradykinesia in patients with Lewy body dementia, also in patients with Parkinson's disease dementia. So in terms of how do we screen those patients using cognitive tests, there are many available validated tests that can be used. The most easy and test is the mini-cog test, which takes 3 minutes, about 3 minutes to do, and it's validated and with comparable sensitivity and specificity to other longer standardized tests. In mini-cog, it has two components. First, the 3-word recall, and the second component is the clock drawing. For the 3-word recall, if it's abnormal, you suspect dementia. If it's normal, you will dementia is not suspected. If it is in between, you do the clock drawing test, and abnormal test indicates suspected dementia, normal test indicates no suspected dementia. This is the instruction for the patient to do the clock. In patients who have low education and who cannot do the clock drawing, you can do the some sort of verbal fluency testing, like asking the patient to name 4-legged animals or a list of words with a specific letter. As I said, depression screen is important in all patients. When you suspect dementia, you can do a simple screening with BHQ2, which has only 2 questions. If it is positive, you can proceed to more like a formal depression screen, like either formal interview or geriatric depression screening scale. If you suspect a patient with dementia, the first step after history, physical examination, and cognitive testing, you need to do basic blood work investigations to rule out reversible causes, such as B12 level and thyroid function test. You always do also like CBC and metabolic panel. B12 and deficiency and hypothyroidism are potential reversible causes of dementia, but they are not common. The yield is low, but they are important to be ruled out. If there is high clinical suspicion, you can do neurosyphilis and HIV testing, RBC folate in patients with alcoholism, calcium in patients with multiple myeloma, prostate cancer, or breast cancer. In patients who have who are younger and have rapidly progressive course or atypical course, you can do lumbar puncture, EEG, or serologic test. At this stage, you would refer those patients to neurology service. Neuroimaging is controversial. I mean, the use of brain imaging is not indicated for all patients with suspected dementia. Like patients with typical Alzheimer's disease may not need to do to have MRI brain, for example. But in certain conditions, like younger patients below 65, if patient symptoms began suddenly or progress rapidly, if there is evidence of focal or asymmetrical neurological deficits, or if the clinical picture suggests normal pressure hydrocephalus, gait disorder, or unexplained incontinence, you would do brain imaging. Also in patients with history of recent fall or other head trauma. The next thing we will discuss here is how to manage those patients. The main goal of management is to optimize the quality of life and maximize function. The management is divided into pharmacological and non-pharmacological. The non-pharmacological is the most important form of management. The principles of non-pharmacological management include initially ruling out reversible causes by reviewing medications that potentially lead to cognitive loss, also ruling out reversible conditions such as delirium or depression. We have, in all patients with dementia, we have to identify and treat comorbidities as they affect outcome, and they are commonly unrecognized or present atypically in patients with dementia. We have to provide the patient and or caregiver, when appropriate, with information regarding the diagnosis, the progression of symptoms, the prognosis, and associated behavioral symptoms. In all patients with diagnosed dementia, there are important safety issues that need to be addressed, like fall prevention of fires and floods for those patients who are still maintaining some independence at home, wandering prevention, like using the or advising the bracelets for wandering. We have to address driving. Some patients with dementia are still having a license and they are at risk of to themselves and others. So this is very important to address. Patients also may have issues with their financial management, and they are like exposed to potentially to like financial abuse. So we have to address this safety issue. And another important is the medication management. Many patients present with adverse drug reactions and reactions related to either non-adherence or to duplication of medications or taking the medication the wrong dose. For example, many patients I have seen that they're taking like daily high dose vitamin D instead of the monthly dose. So medication need to be addressed, and many of these patients will need medication management and supervision by a caregiver. Another important aspect of dementia care is advanced care planning and advanced directives, including establishing a surrogate decision maker. As Dr. Naziha said, maybe the system here in Saudi Arabia does not support advanced care planning, but I think it's our responsibility to start implementing these concepts in our practice. Caregiver support, I want to emphasize that dementia is overwhelming for the person and their families and carers. The emotional and physical stress of looking after a person with dementia is difficult, especially in the middle and later stages. That's why caregiver well-being should be part of any dementia care plan, whether at initial visit or in follow-up. So caregiver, so in every visit for a patient with dementia, we need to address caregiver stress and caregiver support. We can connect caregivers to social services to support the group like to Alzheimer's Society, and we can offer them education and training, especially in areas related to, for example, communication skills with patients with dementia, and also education about the behavioral changes and how they deal with this with these changes. In terms of pharmacological management of patients with dementia, there are three main groups of drugs that can be used for management of dementia. The first group is the cognitive enhancers that include cholinesterase inhibitors and memantine. There are currently three approved CIs or cholinesterase inhibitors, which are donepezil, galantamine, and rivastigmine. In randomized controlled trials, they have been shown to have modest effect with regard to decreasing cognitive decline, improving or maintaining ADL function, improving behavior, and improving overall subjective clinical ratings. Again, I want to emphasize that the effect is modest, it's not big, and patients and families should have like a realistic expectation when we are discussing these medications with them. The benefits of these medications extend to patients with Alzheimer's disease, vascular dementia, Parkinson's disease dementia, and dementia with Lewy body. Cholinesterase inhibitors has been shown to be beneficial especially for patients with Parkinson's disease and dementia with Lewy body for improving their hallucination. They do not treat frontotemporal dementia. Common side effects include nausea, vomiting, diarrhea, confusion, incontinence, nightmares, leg cramps, and syncope and bradycardia. And patients who have history of syncope or bradycardia, cholinesterase inhibitors are contraindicated. The next drug also that's considered as cognitive enhancer is memantine. And the RCTs has shown that memantine has a small effect for improving or decreasing cognitive decline, decrease in functional decline, decrease in the number of hours spent with the patients, and no increase in adverse events. For memantine is indicated for patients with severe dementia. For the CIs, they are indicated for mild to moderate dementia. Other two groups of medication that can be used are antidepressants. It's important to notice that antidepressants are not routinely indicated for patients with mild to moderate depression. They are indicated in patients with like pre-existing severe depression. Sometimes we use antidepressants with sedating effects, such as mirtazapine and trazodone in patients to manage insomnia. The last group of medication is antipsychotics, typically the second generation antipsychotics. The only two indications for antipsychotics in the setting of dementia are if there is risk of harm to patients or others. Sorry. There is risk of harm. Or if the symptoms are like distressing, if the patient's distressed with psychotic symptoms such as severe hallucinations, delusions, or severe agitation. We always try non-pharmacological measures first. We need to be cautious. We start small doses. We reassess patients typically like in 6 to 12 weeks.
and we always need to do frequent trials of tapering. The problem with antipsychotics are that they increase the risk of mortality and increase the risk of stroke. The hazard ratio is 1.6. So we always need to put this in the discussion when we start those patients with dementia and behavioral issues on antipsychotics. We need to avoid benzos and medications with anticholinergic effects. So when do you need to refer to a specialist, whether geriatric medicine or neurologist, or sometimes geriatric psychiatrist? Any patients with newly diagnosed or suspected dementia or cognitive impairment, you can refer. Patients with dementia associated with behavioral and psychological symptoms of dementia. You can also refer patients with dementia with caregivers significant, like caregiver stress. You can refer them to specialized geriatric clinic. Patients below 65 are better referred to neurology, and patients also with rapidly progressive dementia can be referred to neurology. They can consider like more testing like EEG and CSF examination. Patients who are homebound due to severe dementia or severe behavioral symptoms can be referred to home care. If you think the patient has delirium, you need to refer to ER for evaluation, not refer to the clinic, as those patients, delirium is acute medical emergency and need to be evaluated in emergency room. Most patients will likely need admission to the hospital. Dementia is chronic, progressive, and irreversible. And although there is no cure, with early recognition, especially in non-specialized health settings and supportive treatments, the lives of people with dementia and their carers can be significantly improved. Physical health, cognition, activity, and the well-being of the person with dementia can also be optimized. Thank you.
السلام عليكم. دكتور أسامة عبد الرحمن إمام كنا نتمنى يكون معانا اليوم صراحة في هذا الجمع. نسأل الله أن يغفر له ويرحمه. هو من أحد ضحايا كورونا اللي فقدناهم هذه السنة. توفى يعني فجأة. نسأل الله سبحانه وتعالى له العفو والمغفرة. ذكرنا اليوم كنا نتمنى يكون بيننا، ولكن سبحان الله كل إنسان يعني له عمره، فندعي له يعني. شكرا.
Assalamu alaikum. Asa al-khair jami'an. We know that you are tired at the end of the day. Last sessions will talk about men's health. It will have only 2 talks, and inshallah it will be brief and on the time. I would like to invite on the first speak, Dr. Hassan Al-Faraj. Dr. Hassan Abdul Majid Al-Faraj, he is consultant urologist and andrology, medical director of Qatif Central Hospital, and he will talk briefly about medical management of impotence. Welcome, Dr. Hassan.
شكرا جزيلا. السلام عليكم جميعا ومساكم الله بالخير. Last day, last session. الله يعينكم. It's my great pleasure to be with you here, and I'd like to thank the organization committee to giving me this chance, and I promise you to be on time. My topic is about erectile dysfunction or impotence, and I'll try to cover these things: definition and pathophysiology, types and etiology of impotence, and diagnosis and risk factor, and treatment options and modalities, and when to refer your patient to a urologist or specialist. I'll present this case since we were asked to have a case scenario. This is a 61 years old who presented to family physician clinic complaining of weak stream, nocturia frequency, and dribbling of urine for the last 6 months. He is known to be diabetes, type 2 diabetes mellitus, and hypertensive on treatment. And there was no previous surgery or trauma. He is a smoker for the last 40 years. And fortunately, he was asked, and it is very rarely, 5 to 10% of family physicians at primary care practice ask their patient about sexual history. When he was asked, he really took a deep breath because nobody was asking him this question, and he was not courage enough to speak up. So when he was asked, there was decreased libido with erectile dysfunction for the last 1 year, and there was no treatment for this. So on physical examination, he was stable vital sign apart from slightly elevated blood pressure, and he has elevated body mass index up to 33. System examination were within normal. Both tests were normal in size and consistency. PR examination, moderately enlarged prostate, and this elderly male show depressive mood. At the investigation, CBC was normal, renal function, liver function was normal, fasting blood sugar was elevated 210, hemoglobin A1C was 11%, and the testosterone was low, 6, PSA was 2, and this is the international index for erectile function score. This is, we assess the severity of impotence, mild, moderate to severe, according to a questionnaire of 5 questions and a score of 5 to 25. The lower the score, the more severe the erectile dysfunction. Ultrasound, there was enlarged prostate of 60 gram, not milligram, with both void residual of 120 ml, and there was no suspicious area. At this stage, in the primary care level, the differential diagnosis, this patient is elderly, type 2 diabetes, uncontrolled, hypertension, hyperlipidemia, hypogonadism, obese, erectile dysfunction, and he has sign symptom of PPH. What do you think here? But the first thing is a metabolic syndrome, where you have patient with all these criteria and they came to the clinic. The other one is, I will say about ADAM. ADAM stand for androgen deficiency for aging male. We usually concentrate on menopause, but we do have for the aging male a term called andropause, where they may need sometime testosterone replacement therapy. So it has to be considered in the list of differential diagnosis, because impotence per se or erectile dysfunction is not a disease. It's a symptoms represent another variety of disease. So the management for this patient, he was started in alpha blocker, tamsulosin, to optimize his prostate symptoms. He was advised for lifestyle modification, and I will speak about it. He was educated about the disease, and he was shifted from alpha beta blockers to angiotensin converting enzyme inhibitors, and I will tell you why. And optimization of the treatment to control his blood pressure, his diabetes, and to reduce his weight. And he was started in phosphodiesterase enzyme inhibitor number 5 with maximization of the dose and follow up after 3 months to see the response of the treatment. After 3 months, he was seen again, and he was labeled as non-responder to phosphodiesterase inhibitors. And about 40% of patients did not respond to phosphodiesterase inhibitors for too many reasons. I will mention them. He was happy about the treatment of benign prostatic hypertrophy, where Dr. Ammar will talk about lately, but he was not happy at all about the treatment of erectile dysfunction, and he was not satisfied. Accordingly, his testosterone was low. He was replaced with testosterone replacement therapy for 3 months, and to continue testosterone plus PDE5 inhibitors, and to be assessed after 3 months. He was reassessed again in the 3rd visit, but still he's not satisfied neither with the testosterone replacement or phosphodiesterase inhibitor. The patient was offered, and I will mention you, we have 1st, 2nd, and 3rd line of therapy. He was offered the 2nd line of therapy, which is vacuum device for erection or injection in the intracorporal, but he refused these 2 modalities, and he opted and decided to go for 3rd line therapy, which is a penile prosthesis, which was implanted with 3 pieces device called American Medical System. And I will show you the picture. 6 weeks after the insertion of penile prosthesis, he used it. It was functioning very well, and he was very satisfied with the result, and his partner was very thankful. This is the case. Now I'll proceed to the topic of erectile dysfunction. By definition, it is consistent inability to maintain or sustain enough erection for satisfactory sexual intercourse for both partners. The definition is simple, but the situation is not. The situation is very complex, and the consequences very serious if not treated and tackled early. This is just brief to remind you of the anatomy. We have 2 corpora cavernosa. This is the erectile tissue, and we have 1 spongial is the corpora spongiosum. Usually we have blood supply, and to have intact erection, you have to have normal vascular system, normal neurological system, and endocrine system where testosterone or prolactin has to be normal, and normal psychological status of the patient. If any impairment of this system, it will affect the potency of the individual. For neurophysiological erection, we have to have a stimulation. This stimulus will release of a neurotransmitter called nitric oxide, and this nitric oxide leads to accumulation of cyclic GMB, which results endothelial tissue in the corpora cavernosa, which is the erectile tissue, get dilated, and then the corpora cavernosa tissue will be engorged with the blood and resulted in erection. And this is the difference between the erected state and the flaccid state, where you have empty blood in the corpora cavernosa, where it is filled the corpora cavernosa in the erect state. And as we mentioned, it has to have multi-system normal to have this picture and enough erection and rigid. While evaluating patients with erectile dysfunction or impotence, you have to put in your mind what type of erectile dysfunction. We have to classify it or sub-classify it accordingly to the type. It's either primary, it never have an erection at all, or secondary, it happened later in life. Situational or non-situational, which is constant. Or the most important thing, you have to differentiate between a psychogenic or organic cause, because the approach, the treatment, the outcome is totally different. So we have to label our patient. Impotence is primary, secondary, situational or constant, or organic or psychogenic, and we proceed from there. There's too many causes of erectile dysfunction. The first, I'll talk about the psychogenic cause. We have performance anxiety, depression, loss of attraction to a partner, and relationship problem or difficulties, guilt or stress. Any kind of stress might happen to and cause psychogenic impotence. While the organic cause, and I'll talk about how to differentiate between organic and psychogenic cause of erectile dysfunction. Vasculogenic at arterial, venous, or at the level of the corporal cavernosa. We may have atherosclerosis, hypertension, or trauma, and causes vasculogenic impotence. A neurogenic is another cause, hormonal, where we may have hypogonadism or hyperprolactinemia as a hormonal factor causing erectile dysfunction. Drug-induced, and we'll talk about it, antihypertensive, antidepressant, and there is some drugs more likely affect and drugs less likely affect the potency of a male. Alcohol and smoking in affecting potency negatively. What is the relation between medication used and potency or erectile dysfunction in men? There is drugs which is very obvious, more likely to affect potency negatively, beta blockers. That's why our patient, we shifted from beta blockers to angiotensin converting enzyme inhibitors, while you see less likely to affect sexual function is calcium channel blockers and ACE inhibitors. The others which may affect is like beta blocker, statin, diuretic, especially thiazide, and antidepressant and antipsychotic drugs. Risk factors. There's too many risk factors for a male to develop impotence. The number one is aging, and a lot of talk was there is physiological changes at the aging process, a chronic disease, smoking, obesity, lack of physical therapy and sedentary life, depression, and elevated cholesterol. If you see the smoking and obesity, 24 times and 22 times increase the risk of developing impotence, while these two factors can be avoided if you improve your lifestyle. And you can see also all these risk factors attribute to cerebrovascular accident and MI. They share the same risk factor. And it's really, if a person developed MI, it's a serious predictor of a future developing, if he developed an impotence, 1 year later expected to develop MI or having a cerebrovascular accident. So it's really serious triggering factors for the future health of the person. How to diagnose and evaluate erectile dysfunction in male? We have 3 aims, in fact. Number one, we have properly diagnosed and subclassify the type of impotence, including risk factor, to manipulate it and improve the patient condition. Assess the severity according to the International Index of Erectile Function, mild, moderate, and severe, and establish a treatment plan accordingly. So diagnose your patient, risk factors, assess the severity, and start your treatment plan. There is some practical evaluation when you evaluate men with erectile dysfunction in your clinic, especially in the family physician level. Detailed history, as usual, you take medical, surgical, trauma, drugs, all these things. Don't forget about sexual history and ask your patient, especially if you have some of these risk factors. Don't anticipate your patient to voluntarily talk about it. So it's our role to trigger this area and ask our patient. Physical examination, we have to focus about these things: blood pressure, size and consistency of the testis, focused vascular and neurological examination, and about the hormonal factors. Laboratory test will do CBC, fasting blood sugar, lipid profile, testosterone, and prolactin level, initially to assess our patient. This is very important to differentiate between psychogenic and organic cause. Usually the psychogenic is sudden onset. It's situational. There is normal, something called normal awakening and nocturnal erection, where it can be measured by a tool called Regiscan. Normal erection with masturbation and tumescence present. There was no relationship problems. I mean, sometimes there is a relation problem in the psychogenic impotence, and there is some major life events patient going through, like losing beloved one or anything like this, and anxiety and fear and depression. While in organic, usually in elder, they have comorbidities and it's gradual in onset, and there is lack of tumescence, and there is no major life events happen. And this will usually differentiate between the psychogenic and organic cause of impotence, because the treatment options and the response, the outcome is different. So this is very important to differentiate between the psychogenic and organic cause. Is it primary or secondary? Is it situational or constant? This is the slide describing the International Index of Erectile Function, measuring the severity through 5 questionnaires. Each will have 1 to 5. 5 is the lowest and 25 is the highest. The lower we have in the score, the more severe is the disease. Treatment of erectile dysfunction. After establishing diagnosis, know the risk factor, know the type and subtypes of erectile dysfunction, ideal medication for treatment of erectile dysfunction should have these 5 criteria. It has to be effective, it has to be available on demand, and it has to be free of toxicity or serious side effect, and easy to administer. Also, it has to be inexpensive. These 5 criteria has to be there for any treatment of erectile dysfunction. The first thing we have to do is the lifestyle modification. As we see in our patient, obese, uncontrolled diabetes, sedentary life, smoker, all these can be modifiable. So lifestyle modification is the first line of the treatment. It will improve even the outcome with medication. So avoid smoking and alcohol, maintain ideal body weight, regular exercise and healthy food, and consider alternative for medication if they contribute to the erectile dysfunction, and always optimize the management of comorbid disease like diabetes and hypertension to expect better useful outcome for your treatment. We have 3 lines of therapy for erectile dysfunction, and we have to individualize our patient based on that, and we have to start from first line, second line, third line therapy. First line is the oral medication. As you all know, these medications are very famous, called phosphodiesterase enzyme inhibitors, number 5, and usually work in accumulating cyclic GMB after the nitric oxide stimulation, and it will increase endothelial tissue relaxation and engorgement of the blood within the corpora cavernosa. The most famous is sildenafil, which is called Viagra. Tadalafil is the Cialis, and vardenafil is the Levitra, and the new one is now the Staxin. Okay. These drugs are totally contraindicated in patients who is taking nitrate. Nitroglycerin sublingual or others is totally contraindicated with this medication. Otherwise, if there is no other things like taking nitrates, it is safe to take this medication. Usually start with minimal dose, check the response of your patient, then maximize it accordingly. Second line of therapy, if you have first line failed, you proceed to the second line therapy, which is vacuum device for erection, and I will show you a picture of that and how does it work. Alprostadil, which is prostaglandin E1 intracorporal injection or trimix mixture of drugs, prostaglandin E1, phentolamine, and babaverine mixed in one syringe and to be given intracorporal. And you measure the response after 10 minutes of injection, and either you increase or decrease the dose of injection accordingly. If this thing failed or the patient doesn't want the second line therapy as what happened in our patient, then you proceed to the third line of therapy, which is a surgical penile prosthesis implant. And we have 2 types here, either 2 pieces malleable device, or we have 3 pieces, which is American Medical System, 3 pieces inflatable device. And we go in systematic stepwise manner from first line, second line, and third line therapy. And these are the pictures of the drug commonly used. This is the Levitra, and in the middle, Cialis in the left, Cialis there, Levitra, and Viagra. This is the erectile vacuum device where you put this in the penis and create a negative pressure through battery or electricity. And then there is, in the base, there is a ring. It will be in the base of the penis and maintain erection. It's really painful. It's not romantic, and very few people who likes to use it. And this is another second line therapy where you put injection directly to the intracorporal bodies. Avoid the 12 o'clock and 6 o'clock where you have the urethra and neurovascular bundle there, and put it in this as drawing. So don't inject in this area 6 o'clock and 12, otherwise you inject it intracorporal. And in 10 minutes time, you will have the result directly of erection or no erection. This is the penile prosthesis we use. This is the malleable type. They usually implant this in the corporal cavernosal tissue. And this is the third type, the second type, the more advanced. This is a 3 pieces device where we have cylinder, we have pump, and we have the rods. It is inflatable according to the need, and deflated after that. It's more physiological. People like this, it's more expensive. But the problem with these penile prosthesis, if it's failed, you have to take it out. And there is no going back to second line or first line therapy. You have to re-implant again. Causes of failure. Why patients who receive PDE5 inhibitors, sometimes they don't respond. Either incorrect dosage, incorrect use, timing, or lack of sexual stimulation, because it doesn't work automatic. You have to with the patient, he has to wait. There has to be a sexual stimulation to have more effective drugs. Inadequate patient education about the disease. There might be unidentified hypogonadism and anxiety of performance, uncontrolled comorbidities, and psychological factors, or severe erectile dysfunction at the presentation. All these things might lead to failure of or calling non-responding to PDE5 inhibitors. The most of which is number 5, comorbidities, where patients have other comorbidities is not well controlled. When to refer your patient to the urologist? Patient who fail medical management. You tried, you give him the drugs, and you maximize the dose, but non-responder. Refer patient to the urologist or specialist. Patient who has Peyronie's disease, and Peyronie's disease is fibrosis in the corpora cavernosa, and that's why we insist in examining the patient penis at the time of presentation of erectile dysfunction. Lastly is the patient who requested or who need a surgical implant at the time. In these 3 conditions, you refer your patient to the urologist. Why referring patient to the urologist? because it's only specialty dealing with erectile dysfunction, and they are trained well to deal patients with erectile dysfunction, and they can offer modalities of treatment from medical lifestyle modification to surgical intervention. We have to know that ED represents a significant aspect of urology practice, and we have seen that in our clinic. And urology support staff are more comfortable and they feel good and their comfort zone to work with patients with erectile dysfunction. Take-home message is this: erectile dysfunction is a predictor of serious underlying disease. Don't underestimate patients who came to you with erectile dysfunction. The capillaries and arteries in the penile tissue is much smaller and narrower than the arteries and capillaries in the brain and the heart. That's why impotence and erectile dysfunction developed earlier, and then the CVA or OMI might develop later. Family physician can help in early diagnosis and detection of treatment and initiating treatment of erectile dysfunction. And really, it will improve the quality of life if the patient became responder to the treatment and speak up about his condition. And the best place to tackle this issue as primary healthcare and family physician setting. Follow the proper assessment of patient with ED at primary care setting and initiate the treatment as soon as possible, since you know it is safe, there is no contraindication, and expect a good result with this patient. Refer your patient to a urologist when need, and we mentioned the condition that you need to refer your patient to the urologist. Thank you very much.
Thank you, Dr. Hassan, for this excellent, comprehensive, up-to-the-point presentations, and with sticking to the time. And last session, we'll talk about benign prostatic hyperplasia management in the primary care. And it's my pleasure to introduce Dr. Ammar Kbesh. He is consultant family physicians at Medical Academy in the E1, and he is the medical director of Qatif Primary Healthcare. Welcome, Dr. Ammar.
Test. Okay. It's okay. Good evening, everybody. It's too loud, right? Okay. Now it's the end of the day. And I'm sure that you're tired, so try to be quick. But I don't promise that. All right. These are my objectives, and I have no disclosures. We're gonna go through a few cases, so hopefully it will be a nice discussion. A 60-year-old male presents to the primary care with increasing urinary frequency without burning. He has occasional urgency and significant polyuria 3 times each evening. There is mild weak steam, but it's not bothersome. He has limited his caffeine and fluid consumption with no avail. Examination demonstrates a moderately enlarged prostate. There is no nodules and no tenderness. So this is typical presentation of a patient with PPH. The age is 60. Presentation is mainly of a storage symptom with some obstructive symptom. So how are we going to investigate the German? Any ideas? So shall we go with all of these investigations? All right. Now, American Urology Association recommends or dictates that in a resource-limited setting, urine analysis alone can be used as an initial assessment for patients with PPH. However, in certain patients, further investigation like blood work, of course, as a basic biochemistry, PSA imaging might be used, and we'll see some examples of that. All right. Now, we diagnose this gentleman with a PPH with IPSS score of 10, which is moderate LUT symptoms.
we're going to talk about later. Besides non-pharmacological management, what medications will you consider to initiate? So what if these medications are possible to be initiated in patients with PBH? Sorry? Tamsulosin, all right. What about the others? Dexazocin, sulfasentan, finasteride, tadalafil. So is it only tamsulosin as a first line or as an initial therapy in patients with PBH? Well, most of these medications can actually be considered as an initial medication for patients with PBH. It depends on the other comorbidities and the patient profile. For example, in a patient with concomitant erectile dysfunction, tadalafil has been used, and it is very effective for both conditions. Dexazocin might be used in a patient whose blood pressure is probably uncontrolled, and you might want to seek both diagnoses at the same time. Right. Another case was a 44-year-old male, known case of hypertension. He's on amlodipine, 10 milligram, complaining of 4 months history of frequency, urgency, and nocturia, but there is no obstructive symptoms. Examination is unremarkable. So even prostate examination is unremarkable. Urine analysis was within normal. So in contrary to case number 1, this gentleman is a younger age and presenting with mainly irritative urinary symptoms. Urine analysis was within normal. The prostate examination is normal, all right. So what are the likely differential diagnoses? Overactive bladder, non-neurological conditions like diabetes, polydipsia, PBH, amlodipine side effects. Yeah, 4 months. No difficulty in micturition, no reported difficulty in micturition or obstructive urinary symptoms. Excuse me? Yeah, overactive bladder is a possibility, sure. Yeah, diabetes. Well, this is only a simulating questions because all of these are a possible differential in this patient. Amlodipine side effects, behavioral, PPH as well, still one of the differential, yet it is of a lower proportion. All right. Would you like to consider medications at this stage or would like to further investigate them? All right, straightforward. Huh? Case 3, I will skip. Case 4, a 78-year-old male, known case of hypertension, allergic rhinitis with rhinitis medicamentosa, and he has some dyslipidemia, knee osteoarthritis. He is on tamsulosin 0.4 mg once daily. He is self-medicating with nasal decongestant as well. He is on statin and non-steroidal, complaining of worsening complaints for 1 year, hesitancy for quite few minutes. He has dribbling, intermittency, weak stream, and he has also no clear frequency or urgency and no nocturia. So mainly significant obstructive symptoms that's been worsening for the last 1 year, while he is on tamsulosin 0.4 mg once daily. Okay. Prostate examination demonstrates severe enlargement, and the antigen PSA level is 3. So how would you approach this gentleman? All right. We can increase the dose of tamsulosin to 0.8 mg per day. All right. Anticholinergic. Well, he is self-medicating with nasal decongestants. So we know that sympathomimetics can precipitate bladder outlet obstruction. So we should manage that. The patient is also having constipation, but he's not bothered by the symptom. However, we know that treatment of constipation will help to regulate bladder dysfunction. All right. So probably for this patient, we're gonna deal with the rhinitis medicamentosa, with the constipation. What about urological medication? Well, addition of a 5-alpha reductase inhibitor is probably a good choice in this patient. Now, we know that it's not going to be effective right away, but with this patient with a high PSA will likely need a dual therapy to control his symptoms. Case 5, a 58-year-old male who's known case of PPH, but he's off medication with IPSS score of 14. He's having hypertension, heart failure, non-sustained VT, and he has recently underwent cardiac ablation 2 days ago. He's complaining today of constipation and inability to void since this morning. These are the medications. Now you diagnose acute urine retention. What are the likely culprits in this patient? Any ideas? Well, he underwent anesthesia or sedation with the ablation, and this is a well-known precipitating for bladder outlet obstruction. Okay, he is also in paracetamol codeine combination, which might also precipitate bladder outlet obstruction. All right. How would you manage? Sorry. Yes. So Foley's catheter insertion, right? Foley's catheter insertion is the mainstay therapy here. What about addition of an alpha blocker? Well, American Urology Association recommends alpha blocker to be initiated and kept for 3 days on any new patient developing acute urine retention, right? So if a patient developing acute urine retention that is related to PPH, to be initiated on an alpha blocker and kept for 3 days before a trial of voiding free, voiding without a catheter trial, all right? However, in this patient in which we have a clear culprit, which is the sedation or the anesthesia he underwent to, it was not needed a one-time catheterization, and restarting the alpha blocker alleviate his symptoms. So we've done with the cases. We'll go through some basics. The presentation is storage irritative symptoms, I'm sure you know about, but there are other presentations like acute urine retention or recurrent UTI or stone formation. IBSS score, international prostate symptom score is a self-administered questionnaire of 7 questions, Likert scale from 0 to 5. This is the score. It is recommended by American Urology Association to monitor and to follow patients with PPH. Also, we have a question, which is a very important question, quality of life due to urinary symptoms. Now, how do we ask about that? We can ask the patient, if you were to spend your life with these urinary symptoms, how would you feel about that? Okay, so this classifies the bothersome score, whether the patient is bothered by his symptoms or not, and it's important. We're gonna see it in a minute. Differential diagnosis, we have to keep in mind urological and non-urological conditions, of course, like prostatitis, prostate cancer, urethral strictures, and the non-urological conditions like sleep apnea, diabetes insipidus, and side effects of medication. All right. Now, We're going to go through the investigations a little bit later. Which of the following statements are true in PPH? The prostate size is strongly correlated with LUTS, which is lower urinary tract symptoms. Any ideas? False, it's poorly correlated. PPH is more common in Asian population. It's false. All right. It might be associated with a male pattern baldness. Yes. All right. So this is the correct answer. Uroflowmetry is an essential component of the diagnosis of PPH. Definitely not, right? Uroflowmetry is a non-invasive method to measure the velocity of the urine output. If it is less than 15 ml per second, this indicates a limited urinary flow. Which of these symptoms or signs are less likely to occur in a patient with PPH? Microscopic hematuria, recurrent UTI, renal stones, bladder ultrasound with a low pulse void residual. See? Well, all of these actually are not common in a patient with PPH. Microscopic hematuria per se should not be seen, and if seen, it should indicate other differential diagnoses. You have to look for it, maybe prostate cancer, maybe bladder cancer, maybe some nephrological disease. All right. These are the risk factors. The management, we have the non-pharmacological and pharmacological. The goals of the therapy is to improve the lower urinary symptoms, to improve the quality of life, and to decrease the progression of the symptoms and decrease the need for urological intervention. True or false? Patients with mild IPSS LUTS should not be offered pharmacotherapy. Okay, the decision to treat is not based on the IPSS score, rather than on the patient bother score. So if he is really bothered by the symptoms, even if they are mild, we should offer the pharmacotherapy. 2, anticholinergic agents alone or in combination with an alpha blocker might be offered as treatment option of patients with PPH or patients with storage predominant LUTS symptoms. What do you think? True. Okay. Anticholinergic can be offered and sometimes used in such patients. However, we should keep in mind that they do not have a significant bladder outlet obstruction and they do not have a high post void residual. 3, 5-alpha reductase inhibitors should only be used in prostate volume of 50 cc or more. What do you think? Wrong. Clinical trials have shown that 5-alpha reductase inhibitors are beneficial in patients with a prostate volume of 30 cc. And this can be decided by bladder ultrasound or as a proxy with a PSA level of 1.5 or more. 4, alpha blockers are the only first-line therapy for LUTS, PPH. False, of course. Watchful waiting is actually one of the therapies that we might use for patients with PPH, because we know that a lot of patients is very predominant and a lot of patients are not bothered by their symptoms. So if their symptoms are mild to moderate and they are not bothered by the symptoms, so simply non-pharmacological management and follow-up is the way to go. These are lifestyle interventions that must be applied, limiting fluid intake, decreasing diuretics, decreasing bladder irritants, avoiding constipation. weight control, and physical activity. We have some additional interventions that are uncommon in our practice that we should incorporate. Kegel exercise can be used for urinary urgency. And we have time voiding regimens and double voiding techniques for patients with obstructive urinary symptoms, especially with high BVR, bladder post-void residuals. Timed voiding regimens, we ask the patient to void by the clock, like every 90 minutes or so. And with double voiding techniques, we ask the patient to make a second attempt at voiding a minute or two after the initial void. Both has been shown to improve BPH symptoms. All right, so this is a pathway obtained from American Urology Association. So we take history, perform examination, including PR, and performing a urine analysis. We might consider BVR or uroflowmetry if available in our setting. If a patient has bothersome symptom, then we go to the non-pharmacological management and the standard pathway for pharmacological management. We usually initiate an alpha blocker, but it's not the only first-line therapy. Tadalafil or 5-alpha, phosphodiesterase 5 inhibitor can be offered or can be started in patients with concomitant erectile dysfunction. Then if a patient has shown incomplete improvement or still unsatisfied about the results, we can offer either a 5-alpha reductase inhibitor if we have a demonstration of large prostate, 30 cc or more, and we can consider a trial of phosphodiesterase 5 inhibitor in concomitant with an alpha blocker to improve the symptoms. If failure to improve, then we might either assist the patient for further investigations. If a patient is having overactive bladder predominant symptoms, which are storage symptoms, we might consider anticholinergic in combination with an alpha blocker or a beta-3 adrenergic blocker agonist. How can we estimate prostate size? We're gonna skip it. We have passed by it. Pharmacotherapy, we have alpha blocker, 5-alpha reductase inhibitors, phosphodiesterase inhibitors, anticholinergic, and beta-3 adrenergic agonist. All right. This is a game that I was trying to make just to match the side effect with the agent. Frequency and nocturia, for example, can be a side effect of amlodipine. Erectile dysfunction and decreased libido is one of the major side effects of erectile dysfunction and decreased libido. No, out of the medications to the right. Finasteride, right? Okay, decreased libido and erectile dysfunction can be caused by finasteride, ejaculatory dysfunction and retrograde ejaculation. It can be caused by alpha-1A selective blockers like tamsulosin and the more selective blocker like silodosin, right? Dizziness can be caused by alpha blockers in general, more with the non-selective like dexazothin, okay? Now, alpha blockers, the treatment effects of alpha blockers are seen within days, right? But we might need 2 to 4 weeks to see the adequate or full response of the medication. 5-alpha reductase inhibitors. Now, there were some concerns about cancer, prostate cancer with 5-alpha reductase inhibitor. However, recent data showed that both finasteride and dutasteride have a protective effect. It decreases the risk of prostate cancer by 25%. However, it might lead to a late diagnosis of prostate cancer. And we know that finasteride and dutasteride decreases the level of PSA by 50%. It's recommended in a patient with progression to LUTS, like despite monotherapy, like our patient. And it's only recommended in a patient with, we have demonstration of a prostate enlargement, either by a digital rectal examination, a PSA level of 1.5 or more, or an ultrasound. Now, maximum effect of 5-alpha reductase inhibitor might take 6 to 12 months. And this is very important that we need to notify our patients. Efficacy starts by 3 to 6 months, while the maximum effect take up to a year. Sorry. Tadalafil, phosphodiesterase 5 inhibitors can be used as a monotherapy or as a combination in patients with PPH. Now, it is recommended, especially in patients with erectile dysfunction. However, American Urology Association mentions that we should discuss this medication with the patient irrespective of erectile dysfunction. Anticholinergic, they are beneficial in patients with primarily storage symptoms. Combination therapy are more effective than monotherapy. We can go alpha blocker and 5-alpha reductase inhibitors. We can go alpha blockers and anticholinergic, or we can go tamsulosin and mirabegron, which is a beta-3 agonist studied, and it has been shown to improve LUTS symptoms in patients with predominant storage symptoms with low risk for acute urine retention. Few slides to finish. Herbal remedies. Now, palmito, I'm not sure if it is available in our area. However, it comes frequently in the exams, right? Now, in 2002, there were a meta-analysis showing that it's improving the nocturia, improving the self-reported symptoms, and improving the uroflowmetry. However, a 2012 Cochrane review of 32 trials found no efficacy, no evidence of efficacy. And the American Urology Association recommends not to encourage its use, rather to discuss it with the patient. The prognosis, now we know that combination therapy will decreases the risk for acute urine retention by 81% and decreases the risk for invasive surgery by almost 70%. These are the indications to refer to a urologist if we fail therapy, if we have recurrent stones, if we have bilateral hydronephrosis, etc. These are the list of surgical interventions that might be used. This is the end of my session, so thank you very much for your attention.
Thank you, Dr. Ammar, for this excellent comprehensive presentations. At the end, just we will have 5 maximum of 10 minutes of discussions. I would like to invite Dr. Hassan, Dr. Ammar, Dr. Leila, Dr. Amani. Any question from the audience? Okay, we'll start by online questions. Dr. Hassan, there is a question for you. Is there any absolute contraindication for medical management of erectile dysfunction?
We mentioned the absolute contraindication to use phospho-BDE5 inhibitors is patient who is using nitroglycerin only, or those who develop sensitivity to the medication.
Another question from the online. What are the medication available from MOH for the first line?
None. None.
Okay. Another question regarding the questionnaire for erectile dysfunction. It is self-administered or done by the physicians?
For the injection?
Yes.
For the injection, usually the first injection is given by the physician, educate this patient, ask him to demonstrate back how to inject and proper dose. Then patient can be taken at home as self-injection or can be injected by partner even.
Okay.
If the patient is disabled to do it.
What about the questionnaire, Doctor?
Yeah, questionnaire has to be filled by the patient.
Yes.
Demonstrate, we have 5 questions and the patient will put 1 to 5 for each. Then we accumulate.
Is it available in Arabic version or not?
Yeah, it's available in Arabic version, also translated.
Thank you, Dr. Hassan. One question for Dr. Ammar. What about the ultrasound threshold for severity of BBH? Using ultrasound to assess the severity of BBH.
The severity of BBH is never by imaging. It's by history, all right? Now, the ultrasound will only help to give the measurement of the prostate size and will help with the post-voidal residuals, right? So the severity of the disease is mainly assessed by the history rather than by the ultrasound.
Okay, thank you. Dr. Layla, only one question for you. Is there any evidence of alternative therapy in dealing with dementic patient?
There is no conclusive evidence for alternative therapy for dementia. There are many non-pharmacological modalities for dementia, but basically for alternative therapy, no. Some modalities like reminiscence therapy, like cognitive stimulation, aromatherapy, so many modalities, even like pet therapy and therapies with the dolls and other things, but no conclusive evidence.
Okay, any question from audience? تفضل دكتورة.
When you suspect a patient presented with cancer, prostate cancer, في الالدرلي يعني 75 وفوق الكلينيكال، انا ابغى اشوف الكلينيكال.
In a clinical examination, you might find a nodule in the prostate examination, or if the PSA level is higher for age, higher for the cutoff of age, or if there's family history of prostate cancer, it might raise your suspicion. Also, if there is abnormalities in the urine analyses, for example, that warrant you to think the cause. Any other opinion, Dr. Hassan?
Suspecting the prostate cancer, as Dr. Ammar said, first, positive family history, you have to suspect. Digital rectal examination, if you suspect the nodules, a PSA of more than 4. These will let you suspect and investigate for prostate cancer.
Okay. هلا نحن جانا patient presented with UTI symptoms, acute UTI symptoms. Within 1 week أعطينا management did not respond ولا حتى improvement يعني. عملنا الالتراساوند كانت irregular shape. تحولنا على المستشفى أخذوا البايوبسي طلعت كانسر ميتاستاسيس.
Okay, UTI.
Yes. Exactly.
Cancer is the same. Appreciate exam is high. Very important issue. PSA is not necessarily to be high in prostate cancer.
Okay.
Sometimes we have poorly differentiated prostate cancer, poorly differentiated, high glycemic. Is there. And testing and
Thank you.
Just one comment and one last question for Amani. So, the comment is my research, and I did one questionnaire for the diabetic patients. I don't know if it's done in the Saudi Arabia. Around 20% among them having sexual dysfunction, male and female. So it's very high prevalence. So we don't know about, there is another study. My question about food, we know that polypharmacy, it's common in elderly. What about food-drug interactions? Is there any instruction from the pharmacist regarding elderly patient? We saw many interaction actually not discovered, not between the drugs, between the food and the medication. Is there any precocious medication, especially, or the common medication prescribed in elderly and some foods?
There is a clear food-drug interaction for certain medication. So the ideal work that will be a safe medication practice is to set the medication or the drug-food interaction is general, because it will be applied for adults and for elderly, for adults and for pediatric, because the interaction is like chemical interaction regardless of the age. Maybe with age, with the physiological changes, it may aggravate that, but there is a fact of list of medication that have certain interaction with food, and it's the job of the pharmacist to provide this information with all times.
Thank you very much for all the speakers and for the attendees, either here face-to-face or online. Thank you very much, and hopefully to see you, inshallah, in next conference.
حياكم الله، شكرا لكم. احنا ودنا نختم ونصور. نصور مع بعض. هو ختمها حلو، هو ختمها كويس الدكتور. تبي تصورون على المسرح ولا ورا؟ هناك احلى؟ احسن؟ ايه؟ وقفت التسجيل صح؟ قبل ما بس ختاما نشكر الجميع المشارك في الملتقى. دكتور نزيه، سبيشال ثانكس لكل الحضور سواء اونلاين او ان بيرسون. شكرا ايضا لكل السبيكرز والمودريتورز. بيج ثانكس للليدر اوف ذا او الشيربيرسون اوف ذا ساينتفك كوميتي والتيم اللي معاه والاورجنايزنج تيم. We are very lucky to have you within us في التيم. يعني كانت أمنية أو حلم إن احنا نعمل conference to our precious trainers. اشتغلنا على هذا المشروع من سنة أو أكثر. A lot of obstacles، لكن today we forget كل الobstacles اللي شفناها الحمد لله. نتمنى نسمع من الجميع الفيدباك، سواء إذا وصلكم إن شاء الله في اللينك. حيوصل اللينك إن شاء الله للحضور تقريبا around 14,700 وصلنا online plus الحضور اللي in person. We will send إن شاء الله through emails the feedback. ونتمنى نسمع منكم ونشوف يعني what do you want to يعني to have أو إيش نشتغل عليه للnext year إن شاء الله. وإن شاء الله هذه بداية خير والجاي أجمل. تحب تقول شيء؟
إن شاء الله. الله يعطيك العافية دكتورة ندى. أول حاجة الحمد لله كان نعمة من عند رب العالمين وفضل من الله سبحانه وتعالى أن قدرنا نعمل هالكونفرنس. احنا ما كنا متوقعين ممكن هذا يعني الظهور اللي ظهر فيه الكونفرنس، بس الحمد لله توفيق من رب العالمين. أنا initially I want to thank you دكتورة ندى for your great support. And I want to thank the scientific committee one by one. دكتورة إيمان، سلمان، دكتورة تغريد، شعبان، دكتورة غدير دحيلب، دكتورة إسراء، وأيضا دكتورة رشا العواد. I want to thank all of you, the trainer. Actually, you are the skeleton of this conference, and it's your conference, and for all attendees and the on-site and the online. The online we exceed, actually it's a very high number. more than 14,000, almost 14,000, and this is a huge number actually, and reflecting on us. And this is responsibility, as we said in the beginning, and this responsibility will become will be with us in the future, inshallah. And it's not the first CCC. We will see you, inshallah, in the second CCC next year. Thank you.